the diffuse large B-cell lymphoma who are primary refractory or relapse within 12 months after initial therapy, whether this is going to be superior to the conventional treatment, which is the salvage chemotherapy followed by autologous transplantation. And in this study, they enrolled 359 patients. It was multi-center. Key eligibility study was age above 18 with refractory large B-cell lymphoma, either primary refractory or relapse within 12 months after first line of therapy, and who were eligible for autologous transplant. They were stratified based on their response to the first line of therapy, and they were randomized between the use of Axicil versus salvage chemotherapy followed by autologous transplant. And in this study, they allow only bridging using steroid. There was no chemotherapy. Primary endpoint was event-free survival. The study met its primary endpoint after a median follow-up of 24.9 months, with the median BFS for conventional therapy was 2 months versus 8.3 months for patients treated with Axicil. The overall response rate was in favor of use of Axicil, with the overall response rate of 83% versus 50% in salvage chemotherapy followed by autologous stem cell transplant patient, with a CR rate of 65 versus 32. And most importantly, in a pre-specified overall survival analysis at 5 years, which is a longer follow-up for those patients, the use of Axicil as a second-line therapy showed improvement in overall survival, with a median overall survival not reached after 5-year follow-up versus 33% in the standard of care arm. We have also to emphasize here that even the standard of care arm, 33 months of median overall survival, was actually something much better when you compare it with the historical control, because we know that post autologous transplant, the median overall survival is something between 10 to 12 months in general. However, because more than 50% of patients, they actually proceeded to salvage immunocellular therapy of the protocol. Yet, despite of that, Axicil is still showing an improvement in overall survival compared to the standard of care. So that's the conclusion of ZUMA-7. I would like to discuss the real-world effectiveness data that was presented at the EHA 2025, focusing in a subgroup analysis utilizing Axicil as a second-line therapy. So this data was actually patient-level observational data from the CIP-MTR with the aim to looking into the outcome of effectiveness and safety outcome. A total of 461 patients were included into this analysis, collected, including all patients received with relapsed refractory DLBCL who received Axicil as a second-line therapy between April 2022 and July 2023. About half the patients enrolled into this study, they were not actually eligible for ZUMA-7. Most of the eligibility based on echo performance status and presence of some comorbidities. The median follow-up for the analyzed patient was 12.4 months. So as you can see here, the median age was 64, and with the male predominance. And you can see here that median time from diagnosis to infusion was 9 months, and median time from leukapheresis to infusion was 29 days. It's about what we usually see with this product. And as I mentioned, 52% of patients, they were not eligible for ZUMA-7, and 50% of patients, they are eligible for transplant. So the overall response rate was 79, comparable to what we saw with the ZUMA-7, with a CR rate of 64%, and median duration of response, or 1 year duration of response was 66% of patients. And looking into event-free survival, the 1-year event-free survival was 54%, and 1-year overall survival was 74%, comparable to what we saw with the Zuma 7 study. So most importantly, looking into multivariable analysis for the effectiveness, looking into subset of group of patients depending on their age, comorbidities, cardiac comorbidity, hepatic comorbidity, and infectious as well as infectious comorbidity. We can see that overall survival was shorter with patients with cardiac morbidity. And that's the main finding. And patients who are younger, compared to patients who are younger, patients with older than 65, also they have shorter overall survival, as you can see here. So in terms of safety, the overall CRS was 88%, with only 5% they developed grade 3 or higher. Overall ICANS was 48%, with only 23% they develop grade 3 CRS, equivalent to what we saw with the Zuma study. Other adverse effects, including the cytopenia, 6% develop prolonged neutropenia, 11% develop prolonged cytopenia, thrombocytopenia, and 3% develop secondary malignancy. Most of these malignancy are skin malignancy, with only 1 or 2 patients develop myeloid malignancy, including MDS. 27% of patients died in this analysis, and the major cause of death was disease progression, followed by infectious complication, and followed by organ failure. Looking to multivariable analysis for the safety subgroup, again, older patients, they are at higher risk of ICANS, and also patients with prolonged with infectious comorbidity, they are at higher risk of prolonged cytopenia. So moving into the next abstract, which is a real-world outcome using axi-cell for rectal transformation for large B-cell lymphoma. This again presented at the ICML. So as we know that rectal transformation is an aggressive type of lymphoma, and it's associated with poor prognosis, with a short median of survival of less than 5 months. And published data about the safety and efficacy of CAR T-cell in this situation are limited. Again, this is a CIBMTR data collected between October 2027 and August 2023. They collected around 91 patients, median age of 56, with the echo performance status 0 to 1 in 69% of patients, so kind of fit patient. With 70% of patients, they have 78% of they have at least one comorbidity. Prior autologous transplant, 7% of patients, and prior allogeneic transplant in 12% of patients. Median time from CLL diagnosis to rectal transformation was 57 months, and the median number of line of therapy between the diagnosis of CLL until the rectal transformation was 1 line and can reach up to 8 lines. 45% receive venetoclax for CLL, and 57% receive BTK inhibitor for CLL. Stage of the rectal presentation was 80% in majority of patients. This is what we usually see with rectal transformation. Median time from rectal transformation diagnosis to axi-cell infusion was 9 months, and the median number of lines between rectal transformation and axi-cell infusion was 1 line and can reach up to 6 lines of therapy. In terms of response to CAR T-cell infusion, 30% of patients achieve, the response prior to CAR T-cell infusion. So 30% they are in CR or BR. However, you can see here that 65% of patients, they are actually in progressive disease before the CAR T cell infusion. 50% of patients received bridging therapy prior to infusion, and median time between leukapheresis and access infusion is 29 days. Looking to the efficacy data, the overall response rate is 68% of patients. 50% of patients achieved CR despite receiving multiple lines of therapy prior to cell infusion. And if you look to the median duration of response was 8 months, 18 months, and median duration of complete remission for those who underwent complete remission was 56 months. The progression-free survival median was 4 months, and 2-year progression-free survival was 33%. And the overall survival median was 16 months, and 2-year overall survival was 43 months. Kind of like a favorable outcome compared to patients who are refractory rectal transformation, who went into cell infusion. 60% of patients, they went with disease progression. So they did a landmark analysis taking patients who were alive or free of disease at 12 months after the infusion. And you can see here there is a remarkable outcome with the median with a 2-year progression-free survival of 84% and a 2-year overall survival of 76%. In terms of safety, nothing really different from what we saw with DLBCL in general. 8% grade 3 or higher CRS and 28% grade 3 or higher ICANS. However, there is a higher risk of prolonged thrombocytopenia of 27%. 57 of patients died, and the most common cause of death was primary disease progression, followed by CRS and neurotoxicity, different from what we saw with the DLBCL, and followed by infection and organ failure. So in conclusion, Axi-cel showed good efficacy data and safety, acceptable safety profile in highly difficult to treat disease, rectal transformation, with overall response rate of 68%, CR rate of 53%, and median duration of response of around 18.7 months. This will be my last abstract presentation, a pilot study using Axi-cel for treatment of relapsed refractory primary or secondary CNS lymphoma. We know that we don't have enough data to treat this kind of disease using Axi-cel. However, this was presented at the ICML, and this is actually a prospective study, pilot study. The aim of this study is to determine the safety of this approach, as well as doing some correlative studies that can help understand the disease biology and the response assessment for the CAR T cell. They included 18 patients into this study. 70% of them, they are actually primary CNS lymphoma, and 90% they do have a parenchymal disease. And median prior number of therapies before is around 3, and 33% of patients, they underwent autologous stem cell transplant. And the time from diagnosis to enrollment into the study was 489 days, and time from last therapy to enrollment was 72 days. If you look to the safety profile, any grade CRS was seen in 89%, and 44% they developed ICAN. Grade 3 or higher ICAN was 28%. And the prolonged cytopenia as well, 56% of patients, they develop prolonged cytopenia. We're talking about grade 3 or higher within the first month. In terms of efficacy, As you can see here, more than 80% of patients, they actually develop, they do have an overall response rate with the CR and BR rate. The overall response rate was actually better in the primary CNS lymphoma compared to secondary CNS lymphoma because there were more progressive patient in this group. And looking into duration of response, median of 13-month duration of response for those patients. Looking into the progression-free survival and overall survival, the median progression-free survival was around 14.3 months. So in conclusion, Axicil is a safe for treatment of primary and secondary CNS lymphoma with no increased risk of high-grade ICANS or cerebral edema. And it showed also some efficacy with a durable response with a median PFS reach beyond 1 year. With that, I conclude and happy to take any questions.
Thank you, Dr. Badr, for this elegant presentation. The floor will be open probably for 1 or 2 questions in the limited time. Dr. Ayman Ibrahim.
Thanks, Dr. Badr, for the elegant presentation. I just would like to ask about the Richter's patient. Have they checked the clonality? Are they clonally related or not related to CRM? Because this will affect the treatment. If they are not clonally related, why they go for?
Well, I'm not sure if they did that. I have no information about this. Yeah, it's very important to know whether it's clonally related or not.
Any other question? So, Dr. Badr, we know that Yescarta has shown impressive efficacy, but how have management strategies evolved in clinical practice to avoid the complications, the CRS, the ICANS, administering the steroids at the beginning, or to avoid this?
To mitigate the risk of complication and including ICANS and CRS. I think establishing well-developed protocols for early detection of this kind of complication or unique complication is very important. Like establishing algorithm of treatment and monitoring and questionnaires and all these things. So and from the beginning, it's the right selection of the patient. Like patient selection is very important to select the appropriate patient that are fit and able to tolerate the treatment. And then early monitoring, early detection, and intervention. So that's the key. And early early detection, early intervention, that's the main key. We don't use the prophylaxis use of dexamethasone. I know that in cohort 6 they showed acceptable outcome, but we usually don't do it. So we rely heavily on early close monitoring, early detection, and intervention immediately for this to mitigate this risk.
Thank you, Dr. Badr. I think the next symposium will be moderated by Dr. Fadl al-Shayban. Dr. Fadl.
Assalamu alaikum. Good morning, everyone. Today, I'm honored to introduce my friend and my colleague, Dr. Salim Eldada, Consultant Fellowship and Training Program Director, Adult Hematology and Bone Marrow Transplant, King Abdulaziz Medical City in Jeddah. He will be talking to us about piecing together the success of first-line DLBCL treatment. The floor is yours.
Thank you, Mr. Chairman, and good morning, everyone. Assalamu alaikum. So my task will be to discuss the frontline therapy, the success of the frontline therapy in diffuse large B-cell lymphoma. Diffuse large B-cell lymphoma is a curable malignancy, and with the current treatment that we have, we expect to cure 60 to 70% of patients with the frontline therapy. However, late relapses still occur. CHOP has been the standard of care for therapy for non-Hodgkin lymphoma in general and diffuse large B-cell lymphoma specifically for more than 30 years. And this paper published in 1993 in the New England Journal of Medicine showed that 3 different intense therapies, intensive chemotherapy regimen did not beat CHOP in the treatment of lymphomas, non-Hodgkin lymphomas. And for more than 20 years now, we know that addition of rituximab to CHOP improves the outcomes in diffuse large B-cell lymphoma, and it's a standard of care for more than 20 years now. So diagnosing the diffuse large B-cell lymphoma start with the pathology review and immunohistochemistry and the determining the cell of origin. So more than 80% of cases will be classified as diffuse large B-cell lymphoma NOS. Around 5 to 10% of cases will be high-grade B-cell lymphoma with or without double hit. And after that, PET CT scan is indicated in all patients at baseline. Bone marrow biopsy is optional. Sometimes you do it to distinguish between concordant and discordant marrow involvement in lymphoma. And if you have a high suspicion of CNS involvement, you need to do workup, including head MRI and LB with flow. So after staging workup, 20 to 30% of cases will be limited stage disease, and the majority of cases, 70 to 80%, will be advanced stage disease, which is stage 3 and 4. So first, starting with limited stage diffuse large B-cell lymphoma, I'll start with a case, a patient of mine, 78-year-old male, presented with progressive neck swelling for a few weeks. Past medical history is negative. On examination, he had bulky left neck mass, 10 by 12 centimeter, with right cervical lymphadenopathy. ECOG performance status is 1. His lab showed normal CBC and LFT. LDH was 320, and staging PET CT scan showed avid bilateral neck lymphadenopathy with no disease elsewhere. Tissue biopsy showed diffuse large B-cell lymphoma with c-MYC rearrangement. No BCL2, no BCL6. Rearrangement. So how would you treat this patient? Would you give 4 cycles of R-CHOP plus 2R? Or would you give 3 cycles of R-CHOP plus radiotherapy? Would you give 6 cycles of R-CHOP? Would you give 6 cycles of Polar-CHP? Or will you choose C and D? So going back to the patient, his IBI is 2, his age is more than 60, and his LDH is above normal. However, if you go to the stage-modified IBI, his stage-modified IBI was 3, which is considered high. His age is more than 60, LDH is above normal, and his stage is 2. And if you look at the NCCN guidelines for stage 1 and 2 disease, if they have bulky disease, more than 7.5 centimeter, and their stage-modified IBI is more than 1, you would treat this patient as advanced stage disease. And the recommended regimens are either R-CHOP or Polar-CHP in patient with stage-modified IBI more than 1, and this is category 1 recommendation. The SWAG trial published many years ago compared combined modality therapy with CHOP and radiotherapy versus 8 cycles of R-CHOP in patients with limited stage diffuse large B-cell lymphoma. The initial result after 5 years follow-up showed the superiority of the combined modality therapy over just simply 8 cycles of CHOP. However, on longer follow-up at 10 years, the outcomes were similar because of the excess relapse in the abbreviated chemotherapy plus radiotherapy. The German Lymphoma Alliance Group did this important trials to show it was an non-inferiority trial comparing abbreviated chemotherapy with 4 cycles of R-CHOP plus 2 R infusion versus 6 cycles of R-CHOP in limited stage diffuse large B-cell lymphoma, the FLAIR trial. So what they did, they had a patient who were less than 60 years of age, 18 to 60, with stage 1 and 2 disease, normal LDH, echo performance status 0 to 1, and non-bulky. And they were randomized to either 6 cycles of R-CHOP or 4 cycles to R-CHOP, 4 cycles of R-CHOP plus 2 R infusions. And the primary endpoint was BFS. The study met its primary endpoint. The experimental arm was non-inferior to the control arm, and actually it was 3% better in the long-term follow-up after 66 months of follow-up. The BIT-directed therapy was tried in limited stage diffuse large B-cell lymphoma, and this is an example trial, the SWAG S1001. So in this trial, they included again non-bulky disease, less than 10 centimeters, stage 1 and 2. They received 3 cycles of R-CHOP followed by interim BET. And if the interim BET is negative, they received 1 additional cycle of R-CHOP. And if the interim BET is positive, they received radiotherapy plus radioimmunotherapy. More than half of the patients in this trial were above the age of 60. And if you look at the BFS at 5 years, 89%, and overall survival, 91% for patients who are interim BIT negative. What about bulky diffuse large B-cell lymphoma? We know that bulky disease is associated with inferior outcome irrespective of the patient IPI. And in the MIN trial, it showed that patients who received chemotherapy or chemoimmunotherapy, if they have bulky disease, they had inferior outcomes. So the suggested therapy for limited stage diffuse large B-cell lymphoma without bulk include non-BIT directed therapy or BIT directed therapy with decision after 3 cycles of R-CHOP. A suggested approach for limited stage would be 4 cycles of R-CHOP plus 2 R infusion in patients who are less than 60 with normal LDH echo 0 to 1 and non-bulky disease. So patient with IBI of 0. You may use a BIT 3 directed therapy in non-bulky disease with risk factors. However, if you have a stage modified IBI of more than 2, probably 6 cycles of R-CHOP or whole R-CHOP is preferred. Sorry. For patient with bulky disease, it's preferable to use 6 cycles of R-CHOP with end of therapy consolidation based on the results of PET-CT scan. So back to our case, my patient received 6 cycles of R-CHOP from April to August 2021. End of therapy PET-CT scan showed Dovine 4 response, partial metabolic response. Subsequently, he received consolidative radiotherapy, and follow-up PET-CT scan showed complete metabolic response. Currently, he is 82 years in age, alive, and in remission. So what about advanced stage diffuse large B-cell lymphoma? Second case, 39-year-old male, hospital employee, background of type 2 diabetes on insulin. Sorry, I did not write diabetes. And hypothyroidism and smoking. He lives in Jeddah with his wife and kids. So in June 2024, he started to have progressive left inguinal swelling, excisional biopsy done in August 2024. On examination, his echo is 0, or he is obese with a BMI of 39.7, almost 40, and he has no palpable lymphadenopathy. So his white count is normal. His CBC is actually normal. His LDH is elevated, 294. His TSH is elevated. He was non-compliant to the thyroxine replacement. His vitamin D is low, 26. Viral serology is negative, and his hemoglobin A1C is 9.4. So he was not, his diabetes was uncontrolled. So this is PET-CT scan, showed lymphadenopathy above and below diaphragm, non-bulky with splenic deposits. So he had a biopsy which showed diffuse large B-cell lymphoma, germinal center subtype, CD20, PAX5, CD10 positive, and Ki67 was 80%. So the final diagnosis is diffuse large B-cell lymphoma, stage 3S with an IBI of 2 for stage and LDH. how would you treat this patient? 6 cycles of R-CHOP, 6 cycles of dose-adjusted R-EPOC, 6 cycles of Pol-R-CHP, or 6 cycles of R-CHOP plus ibrutinib. So the recommended regimens for advanced stage disease are either R-CHOP, category 1 recommendation, or Pol-R-CHP, again, category 1 recommendation in patient with an IBI of 2 or more. So over the years, many trials, over the last 2 decades, many trials have failed to show efficacy benefit over R-CHOP. So enhancing anti-CD20 with the use of obinutuzumab in the Goya trial failed to show superiority over R-CHOP. And the addition of targeted therapy like lenalidomide in the ROBUST trial, ibrutinib in the Phoenix trial, and bortezomib in the remodel trial all failed to show superiority over R-CHOP. Intensification of therapy with dose-adjusted R-EPOC in the CLGB 50303 also did not show improvement in outcomes, and even R maintenance and diffuse large B-cell lymphoma have been tried, and it failed to improve the outcomes. However, we have a positive trial, which is the use of anti-CD79B polatuzumab in previously untreated diffuse large B-cell lymphoma. This is the design of the POLARIX trial. You are all aware about it. So it was a double-blind randomized control trial. So they had more than 800 patients overall. The age inclusion criteria, age 18 to 80 with an IBI 2 to 5 and ECOG performance status 0 to 2. So they receive 6 cycles of R-CHOP or 6 cycles of Pol-R-CHP with 2 additional rituximab infusion with end of therapy PET-CT scan. The primary endpoint of the trial was PFS, progression-free survival. So looking at the baseline characteristics, median age was 65, 66, and actually 2/3 of patients, almost 2/3 of patients were above the age of 60. Looking at the Ann Arbor staging, although the number was small, however, this trial included patients with stage 1 and 2 disease, almost 11% in each arm. So looking at the baseline characteristic, bulky disease in almost 44% in each arm. ECOG performance status was mostly 0 to 1, and IBI was 2 and 38% in each arm, and 62% IBI 3 to 5 in each arm. Looking at the cell of origin, half of the patient had German center GCB subtype diffuse large B-cell lymphoma, and around 1/3 had activated B cells, and the others had unclassified cell of origin. And keep in mind that the cell of origin was done by gene expression profiling, not by immunohistochemistry. And dual expressor was in 38%, 41% in the both arms. The trial included patients with double and triple hit lymphoma. However, the number was small, less than 10% in each arm. So looking at the toxicity, the rate of peripheral neuropathy was similar between both arms, less than 2% grade 3 or 4 peripheral neuropathy in both arms. Febrile neutropenia of grade 3 and 4 was more in the Pol-R-CHP versus R-CHOP, 14% versus 8%, and that mandated primary G-CSF prophylaxis in all patients. So this is the primary endpoint you're looking at now. So the Pol-R-CHP was superior to R-CHOP in terms of PFS at 2 years, almost 77% versus 70%, with the hazard ratio of 0.73, so 27% relative risk reduction with a significant p-value. Looking at the subgroup analysis, patients who were actually older than 60 had a lower hazard ratio, so greater benefit. So the hazard ratio was 0.7. And patient with IBI 3 to 5 had again a lower hazard ratio 0.7, so a greater benefit. And looking at the cell of origin, the EBC subtype have a lower hazard ratio, 0.4, greater benefit when with polar-CHIP versus R-CHOP. And again, remember that the cell of origin here was determined by gene expression profiling. A dual expressor, a patient had a hazard ratio 0.6, so they benefited again from the polar-CHIP. And double or triple hit lymphoma in this initial report had inferior outcome with polar-CHIP with a hazard ratio of 3.8, but that have changed in the longer follow-up, as I will show you. So this is looking at the Kaplan-Meier curve for 5 years follow-up. So the benefit was maintained at 5 years with 5 years BFS of 65% for polar-CHIP versus 59% for R-CHOP. And the numbers of second-line therapy required were 23% less with polar-CHIP versus R-CHOP. The overall survival, so looking at the overall survival, numerically, there were fewer deaths in the polar-CHIP. However, this did not reach statistical significance as the hazard ratio is 0.85. There were fewer progressive disease in the polar-CHIP, fewer total death from progressive disease in the polar-CHIP. However, the non-disease related deaths were similar between both arms. I'm not sure if you can, I think you can see it from here. So if you look at the, specifically at the double hit lymphoma in the middle, non-Hodgkin lymphoma, high-grade B-cell lymphoma, or double and triple hit, the hazard ratio at 5 years follow-up is 0.67 for BFS and for overall survival 0.46, favoring polar-CHIP in the longer follow-up. However, the numbers are small to draw a definite conclusion. The other hazard ratios are sustained at the 5 years follow-up as compared to the 2 years analysis. So looking at the analysis of death, as I mentioned to you, there were more deaths due to progressive disease at 5 years in the R-CHOP than polar-CHIP, the experimental arm. With regard to toxicities, there were no change at 5 years follow-up. So the difference in the hematological toxicities and infection were less than 5%. So for more than a decade now, we know about the story of the cell of origin in diffuse large B-cell lymphoma, and we know that the outcomes are different according to the cell of origin. So non-GCB subtype have inferior outcomes. However, the story is more complicated, and if you do integrated genomic analysis, you can identify more distinct subtype from the just simply ABC or GCB subtype. So an important paper published in Nature of Medicine 2018, so almost 7 years ago now, the molecular subtype of diffuse large B-cell lymphoma and their outcomes. So they did integrated genomic analysis, and they classify the diffuse large B-cell lymphoma into 5 different clusters. And these clusters include 2 GCB enriched diffuse large B-cell lymphoma and 2 EBC enriched diffuse large B-cell lymphoma, and 1 cluster that is unrelated to GCB and ABC. They have biallelic TP53 inactivation. So in the last Lugano, the first late-breaking abstract was discussing the benefit of polar-CHIP in the DLB class-defined molecular subset in newly diagnosed diffuse large B-cell lymphoma. So as I mentioned to you, the 5 different subtypes that we have, C1, C2, C3, C4, C5. So C1 and C5 are actually ABC enriched. C1 is low risk ABC enriched with possibly genetic feature resembling marginal zone lymphoma. C5 is higher risk ABC subtype. They have BCL2 copy gain, MYD88 mutation, and CD79B mutation. C2 is as I mentioned, has biallelic inactivation of TP53, and they are ABC GCB independent. C3 has a high risk GCB with BI3K signaling pathway alteration, and C4 is a lower risk GCB, and they have JAK-STAT and BRAF pathway alterations. So when they looked at the outcomes, they found that a patient in the cluster 5 had different outcomes according to the treatment given. So the 5-year BFS was 70% in those cluster if they received Pola-R-CHP versus 42% in R-CHOP, with a significant hazard ratio of 0.38 and significant p-value. So what about double hit lymphoma? We know now that we define double hit diffuse large B-cell lymphoma with the presence of c-MYC and BCL2 rearrangement. And in those patients, it seems that intensification of therapy with R-EPOCH may actually improve the outcomes. However, keep in mind that this is based on retrospective analysis. We don't have randomized clinical trials showing superiority of this approach. So what about the CNS relapse risk? So we know that the CNS IBI can be used for risk stratification for CNS disease in diffuse large B-cell lymphoma. It has the 5 parameters of the IBI plus kidney or adrenal involvement. So, and 2 different study groups from Germany and Canada confirmed that patients with high CNS IBI 4 to 6 have more than 10% risk of CNS relapse or progression. However, if we identify this, do we have an evidence that intervention would prevent the relapse? Until now, I can say no. We have multiple retrospective analysis that the approach of CNS prophylaxis actually does not prevent against CNS relapse progression. And as I'm showing you now, the meta-analysis showing that actually the CNS prophylaxis does not prevent the CNS relapse. So suggested approach for advanced stage diffuse large B-cell lymphoma, 6 cycles of R-CHOP 21 in patient with an IBI of 0 to 1, 6 cycles of Pola-R-CHP in patient with an IBI more than 1. R-CHOP is an alternative, 6 cycles of dose-adjusted R-EPOCH in double or triple hit lymphoma, and no clear benefit for CNS prophylaxis. So there are a number of trials that we expect the result in the upcoming years. Number of ongoing phase 3 clinical trials with bispecifics, CAR T cell, and new medication antibodies in the phase in development for diffuse large B-cell lymphoma. So I'll just mention to you a few studies to wait for. The ESCALATE trial, which is the use of acalabrutinib in combination with R-CHOP for patients who are younger than 65 or younger with non-GCB diffuse large B-cell lymphoma. So we know the Phoenix trial with ibrutinib plus R-CHOP was negative. However, if you look into the subgroup analysis in patients who are below 60, they had an event-free survival and overall survival benefit for ibrutinib plus R-CHOP. So Acala now they're using it as in patients who are younger than 65. So maybe the result would be positive. The Frontline trial is a phase 3 clinical trial for Tafalin plus R-CHOP versus R-CHOP, a newly diagnosed high, intermediate, high risk diffuse large B-cell lymphoma. We expect the result of this trial within 2 years. The SKY-GLUG trial is a trial of bispecific upfront phase 3 clinical trial, glofitamab plus Pola-R-CHP versus Pola-R-CHP in patient advanced stage diffuse large B-cell lymphoma. We expect the results in 2 to 3 years. And there is another bispecific and the trial in the upfront therapy, the epcoritamab with R-CHOP in patient with diffuse large B-cell lymphoma, the EPCOR diffuse large B-cell lymphoma 2. Again, we expect the result in the coming 2 to 3 years. There is another trial, the Zuma 23, using Axicel actually in the upfront therapy of diffuse large B-cell lymphoma high-risk patients. So this is my final slide, and thank you all for listening.
Thank you for this excellent presentation. We'll take questions from the audience. Any question? Okay, so in the POLARIX trial, it showed a 27% reduction in the relative risk reduction. What does that mean in clinical practice?
So that means fewer relapses or progression that will so less patient will need second line therapy. So that's an important point to remember.
Okay, and like in the POLARIX as well, it showed like 23% of patients required less subsequent therapies. What do you think of the cost-effective analysis of using POLA in frontline setting?
Yeah, so we know that second line therapies are actually expensive, and diffuse large B-cell lymphoma, the option of using CAR T-cell bispecifics. So you will actually be cost effective if you use your best approach upfront, because less patient will need second line therapy.
Any other question?
Dr. Darwish.
Well, the transformation will chip be an option then? I know there is no yet trial to prove that, but these are even more in need of higher treatment than others. The Richter transformation.
I'm not sure. Wallah. Not sure. That's something to look for. I'm not sure.
Okay. Would you think the polatuzumab is applicable only to high-risk population, or you would generalize it for advanced stage patients?
So, as per the trial, patient with an IBI of 2 or more, they are eligible to receive polarchip, and this is category 1 recommendation actually. And I've shown you that even in limited stage diffuse large B-cell lymphoma, some of the guidelines, they include polarchip in patient with limited stage and high risk disease, such as patient with high stage modified IBI 2 or more. So in those high risk patient, you would consider polarchip even if they're limited stage. For advanced stage, the label include patient with an IBI 2 or more.
Okay, excellent. Take 1 or 2 questions.
First, I'd like to thank you, Dr. Salim, for this excellent talk, actually. I have a simple question. In your practice, if you have a patient who is germinal center subtype, okay, it's only by immunohisto, we don't have NGS, and he's IPI 2. You choose pola-R-CHP, or you still go with the R-CHOP?
So our group agreed to use the polarchip in all patients as per the POLARIX trial, regardless of the cell of origin. So as you said, we don't have we don't identify the cell of origin based on gene expression profiling. We do only immunohistochemistry, and the subgroup analysis included patient with showed the subgroup analysis was actually for patient who had, as per the trial, the cell of origin identified by gene expression profiling. So we agreed that in all patients, regardless of the immunohistochemical subclassification, we use polarchip. That's what we do in our center.
Thank you.
Okay. Last question. What do you think of the use of progression-free survival as an endpoint for the POLARIX trial rather than overall survival?
That's an excellent point, and I think many of the ongoing trials actually use BFS as a primary endpoint. I think demonstrating overall survival benefit would be difficult, especially with the very effective second and third line therapy options that we have. So we have now the CAR T-cell, we have the bispecifics, and demonstration of an overall survival benefit would be difficult. So I think it's more reasonable to use the BFS as the primary endpoint. And actually, many authorities accept this BFS as a primary endpoint in diffuse large B-cell lymphoma.
Thank you. Question?
Yes, I just want to add something regarding the question regarding Richter transformation and CD79B. Actually, what we know with polatuzumab is data regarding patients and diffuse large B-cell lymphomas expressing CD79. Richter transformation, even the DLBCL form, has quite a different phenotype from a de novo DLBCL. So sometimes this is the reason why some targeted drugs, don't have efficacy in this setting. For CD79, what we know is that Richter transformation doesn't express high levels of CD79B. If this is some kind of obstacle to the efficacy of polatuzumab in this setting, I don't know, because we know that, for example, for CD30 antibodies, even if you don't have high levels of CD30 expression, they can still be effective. So for sure, this is something to look into it.
Yeah, but I think also the evidence for these approaches is still minimal in Richter's transformation. So we don't have evidence for that use. Yeah.
Okay. By this, I believe we conclude. Thank you, everyone, for listening. Thanks for the excellent presentation. Now we'll have lunch in the prayer, Juma prayer, the break.
السلام عليكم بدنا نبدا من 7 minutes بس عشان يخلصونا كلمه
Assalamu alaikum. So we will start the afternoon session in about 5 minutes from now.
خلاص Is he ready? Dr. Stefano ready? You know?
Yes, I'm ready.
Yes. Assalamu alaikum. Good afternoon, everyone. So we will start this session. It's my pleasure to introduce our next speaker, Dr. Professor Stefano Luminari. He's a full professor in medical oncology in University of Medina and Reggio Emilia from Italy. He's the head of the unit clinical research in oncohematology in the hematology division. And he is very active in lymphoma research, in particular follicular lymphoma and Hodgkin lymphoma. And he will summarize to us the abstracts from the latest Lugano meeting on follicular lymphoma. Please go ahead, Professor.
Thank you for the nice introduction. And first of all, I would like to thank the organizer for inviting me and also ICML committee for providing me the data. So today I will discuss you about the contribution related to follicular. First, these are my disclosures. And this is the outline of my presentation. So I will present mainly 4 abstracts, 3 related to the first-line therapy and 1 regarding the relapsed refractory setting. So just starting with the first one, the AP-R-CHOP is a phase 2 study from LISA, the French group, who is testing the hypothesis and the efficacy of tazemetostat combined with R-CHOP in newly diagnosed follicular lymphoma advanced stage patients. So there is a clear rationale behind this study, which is actually related to the activity of single-agent tazemetostat, which is an EZH2 inhibitor that has been shown to be work and to be active and associated with responses in the relapsed refractory setting. And we know that follicular lymphoma frequently present mutation in EZH2. That is a very early genetic event in the pathogenesis of the disease. And in both mutated and mutated cases, single-agent tazemetostat is active without any significant toxicity. So there is a strong rationale to test the combination of tazemetostat combined with R-CHOP. This has been done with this very simple design, R-CHOP conventional treatment for 6 cycles followed by 2 rituximab dose, combined with tazemetostat starting from day 2 cycle 1, and prolonged for the first phase of maintenance for the first 4 doses of rituximab maintenance that was completed up to 2 years. The main study endpoint was response, and starting with the clinical characteristic of the patient, 62 patients were enrolled and reported at the meeting. All of them were stage 4. In 21%, there was an involvement of peripheral blood, and half of the patient had bulky disease. A ZH2 mutation, which was tested retrospectively, was shown in 24.2% of the case. Remember, the inclusion criteria did not require a ZH2 mutation. Looking at the primary endpoint of the study, which is complete metabolic response, overall in the sensitivity set, the complete metabolic response was 80%, 79%, which clearly met the initial study hypothesis. And looking at the data divided by EZH2 status, as expected, I would say, complete metabolic response was higher in the mutated cases versus 73% versus the 46% in the wild type cases in the safety set. And looking at survival data, progression-free survival at 30 months was 76.2%, while overall survival it was also observed being 92.5% overall with only 6 deaths. And what was interesting to see here is that the presence of mutation of AZH2 did not impact the risk of progression-free survival, as shown in the bottom right panel. In terms of toxicity, it is difficult to assess the added toxicity caused by a combination of R-CHOP with tazemetostat. I think that the main toxicity event were expected in this platform without any new signal of this combination. Overall, you can see the details of the toxicity event are shown here. I would like to outline these 5 second primary malignancy which were observed in the course of the study: 1 prostate cancer, 1 colon cancer, and 3 acute myeloid leukemias. As a spotlight on this acute myeloid leukemia, these are, I would say, unexpectedly high in terms of frequency. 3 cases, 2 females, 1 male. They're all old, and there is some subsequent analysis which is still ongoing to test whether there may be a role of inhibition of AZH2 in contributing to the emergence of these cases. Remember, AZH2 is also a marker, a hallmark of clonal hematopoiesis, and maybe inhibition of this gene interaction with this gene may represent an initial signal for transformation. But I think we need more follow-up and more data to confirm this hypothesis. So the second and third study are related to bispecifics, and bispecific in particular mosunetuzumab first line. The first study was presented by Lorenzo Falchi from MD Anderson, from Memorial Sloan Kettering in New York. This is the largest study. You will all know what mosunetuzumab is. It's a CD30, CD20 bispecific antibody with documented activity as single agent in relapsed follicular lymphoma. And in this study, this is the first study actually, and the largest study in which the activity and the safety of mosunetuzumab single agent, in this case is administered as subcutaneous agent, are being tested in the first line setting of follicular lymphoma. This is the study design. Mosunetuzumab again subcut as initially mentioned, 5 milligram and then 45 milligrams as very easy and quick step-up dosing, then 45 milligrams every 3 weeks up to 8 cycles. After 8 cycles, response assessment. If a patient was in CR, then the treatment could be interrupted. For patient in PR, the treatment could continue for additional 8 cycles up to a maximum duration of treatment of 1 year. The study inclusion criteria are those typical of high tumor burden, follicular lymphoma patient newly diagnosed, and the main study endpoint was response rates as per Lugano. These are the characteristics of the 78 patients. You can see here 74% was stage 4. And most of the patients required GELF criteria to be met in order to be included in the study. You can see the details of the GELF criteria, which are not present as single criteria but may be combined. This is why the sum of the percentage is higher than 100%. But the most frequent GELF criteria was the presence of large lymph nodes. But this is a characteristic of a patient population of high tumor burden patients. And in terms of overall response, the main study endpoint, 82% complete response rate with an overall response of 95%. I think very good results, which were consistent across the different risk group. You can see in the right-hand side of this slide, young and old patients respond similarly, like male and females. Patient according to SUV max baseline, bulky disease, yes or no, grade 1, 2 versus 3A. So quite consistent data confirming the activity of this bispecific in the first line setting. And in terms of adverse events, the toxicity profile of mosunetuzumab in this case was that expected, no ICANS, no tumor lysis syndrome, only 1 grade 2 episode of tumor flare reaction. Since this was a subcutaneous administration, of course, you can see injection site reaction being listed as the most frequent event, but this is only an event that represented by itching, pruritus, or some kind of low erythema. There is up to 30% of the patient population who experience some kind of neutropenia, but only less than 20% experienced grade 3 or 4 neutropenia, which was, however, not correlated with infections. And cytokine release syndrome seen in up to 50% of the patient, mostly grade 1, and mostly seen during cycle 1. Progression-free survival, even if this was not the primary endpoint and the follow-up is short, is very promising with an 89% progression-free survival rate at 1 year. And the follow-up, of course, is going on, and we need to look at updates of this study to see if these data are confirmed with additional months and years of follow-up. Overall survival, 98.7% rate at 1 year, again, excellent results. So the conclusion of this study was, of course, suggesting that the efficacy of mosunetuzumab not only is confirmed, but is seen with very promising results in the first line that may represent a future setting for development of this interesting study. Toxicity, no really matter of concern, what we see. And moving to the subcutaneous administration is, in the first line, is a very safe and a better way of administration compared to the conventional IV administration that is usually mandated for the reimbursed mosunetuzumab in relapsed refractory setting. And the second study, again, bispecific in first-line follicular lymphoma, is now this is a sponsored study by the manufacturer of mosunetuzumab, presented by Elizabeth Buddy and the Morning Sun phase 2 study. These are the key inclusion criteria: previously untreated follicular lymphoma, high tumor burden according to the Guelph criteria. The administration, again, is subcutaneous with the very short step-up dosing, 5 milligrams on day 1, 45 day 8, and then up to 45 milligrams as the full dose given every 21 days. In this case, similar to what's shown before, patient did not interrupt the treatment after cycle 8. They had to go up to 17 cycles for 1 year, and it was an optional maintenance therapy for patients who were shown to be responding to the first year of treatment in this case. The primary endpoint was progression-free survival rate at 24 months. Characteristic of the patient, 102 patients, 64.5 median age. 1 out of 4 patients presented with B symptoms, and similarly, 1 out of 4 patients presented with elevated LDH, and the stage 4 was observed in 53.9% of the patients, 39.2% at bulky disease, and 3 to 5 FLIPI was reported in 45.1%. Again, a typical population for a first-line newly diagnosed high tumor burden patients. The complete metabolic response in all patients was 60.8%, with an overall response rate that now is shown as partial metabolic response, according to the Lugano criteria, which used PET, was 87.3%. And as you can see, the response rate was quite consistent across the different risk group. Here you can see the higher risk group, so the elderly patient, complete metabolic response 48.9%, high FLIPI 45%, elevated LDH 44%, those with B symptoms 65%, and those with bulky disease 55%. So consistent responses across the different risk groups. And also here, the progression-free survival is shown. The median follow-up is still very short, 11.8 months, but at 1 year, the progression-free survival rate was 82.8%. In terms of safety, similar to what has been observed before, nothing really new. Again, injection site reaction, grade 1 and 2 observed as the most frequent adverse event. CRS, little less than 40% of the patient experience grade 2, grade 1 mainly, and few grade 2 patients, no grade 3 or grade 4. Of course, there is a problem with COVID-19, which was documented in approximately 20% of patients, but grade 1 and 2 only. And only 8 cases, 7.8%, experienced adverse events, which led to discontinuation of mosunetuzumab. A focus on CRS, as shown before, differently from the IV administration, the CRS that are still very low in terms of grade are mainly observed after first dose. So the first 5 milligrams are those associated with the highest rate of CRS, which however was still low. Up to 1 out of 4 patients experience a CRS of grade 1 and 2. And you see then, maybe, I think because of the subcutaneous administration, the CRS rate decreases significantly starting from second week and to subsequent treatment dosing. And CRS, corticosteroids and tocilizumab are used respectively in 7.8% and only in 6% for tocilizumab to treat CRS. So in conclusion, again, there's a documented activity of mosunetuzumab single agent with a very promising response and progression-free survival rate, and there is a strong rationale to support the ongoing phase 3 studies, which are now comparing bispecifics and also including mosunetuzumab, in this case combined with lenalidomide, with immunochemotherapy in the first-line setting. Remember, there are at least 5 studies which are now enrolling patients and comparing bispecific and oral in combination versus the standard immunochemotherapy in the first line. And the final abstract, moving to the relapsed refractory setting, is the InMind study presented by Laurie Sen. This is an update of the late-breaking abstract presented at ASH. Actually, in this study, the combination which was tested was an R-square plus tafasitamab compared with R-square, and tafasitamab being an anti-CD19 naked antibody with the activity as single agent and with a label that allows us to use this agent in combination with lenalidomide in relapsed refractory diffuse large B-cell lymphoma. Well, in this phase 3 study, TAFA R-square was compared in a double-blind fashion with a standard R-square in a patient with follicular lymphoma who were relapsed refractory to at least one prior line of systemic therapy. Randomization was 1-to-1. The treatment was fixed duration up to 1 year, only 12 months of treatment without any maintenance afterwards. And the primary study endpoint was progression-free survival, with an hypothesis to show better results of the triple combination versus the standard lenalidomide rituximab combo. These are the characteristics of the 548 patients. The median age was 64. And you can see these are characteristics of advanced stage patient, relatively high risk, with approximately half of the patient being classified as FLIPI, high risk in terms of FLIPI 3 to 5, and with most of the patient, 82%, meeting the GELF criteria as a requirement to start the treatment. For the remaining 18% of the patient, other criteria were used to take a decision about starting a therapy in this relapsed refractory setting. And all lines of therapy starting from first relapse were allowed. Most of the patients were in second line, as you can see here. The median number of prior lines of therapy was 1. So this is actually a therapy for the first relapse of follicular lymphoma patient. 1/3 of the patient had POD 24, and 42.5% were refractory to prior anti-CD20 therapy. And this is mainly the main study results: progression-free survival by investigator assessment, with clear evidence of better efficacy for the tafasitamab R-square compared to the R-square, and with a reduction of the risk of progression, disease, or death of 57%. So the hazard ratio was 0.43, fully meeting the initial study hypothesis of superiority. And what is, I think, important to look at this study curve is that after 1 year, so when the treatment is stopped, you don't see the drop in the curve of progression-free survival, meaning that the efficacy is there and is durable also after the treatment was interrupted. And the efficacy of the combination compared to the R-square was seen across the different subgroups, and in particular in the bottom of this slide you can see the pre-specified subgroup, which were also sized well enough to show enough power. The TAFA R-square was more effective regardless of POD24 refractoriness of number of prior lines of therapy. Also important, time to next treatment, one of the additional endpoints, and not met the median time to next treatment for the TAFA R-square, while the placebo R-square was associated with the median time to next treatment of 28.8 months. Overall survival, no difference, but only a trend towards better efficacy of the TAFA R-square. We need more follow-up to see if this data will translate into a significant difference. In terms of toxicity, I would say quite surprisingly, no significant increase of the major events for the TAFA R-square combination, which was associated with a slight increase in terms of gastrointestinal disturbs and only numerical higher rates of other events like infections and neutropenia. What was observed here is an increase in the rate of COVID-19, which was observed in up to 60% of the patients treated with the TAFA R-square and only 2% for patients treated with the R-square. So actually it was a safe combination. The addition of tafasitamab to R-square did not significantly improve and increase the toxicity rate in these patients. Some details about additional endpoint, histological transformation was observed mainly in the R-square plus placebo, 9 cases, while no case in the experimental arm was documented with the transformation during follow-up. And in terms of the CD19 expression at relapse, of course, more patients experienced CD19 loss. However, these were very few. Out of 13 samples, 7 out of 8 tested for CD19 were positive, while of course 16 out of 16 tested patients in the R-square plus placebo arm were confirmed to be positive. So it looks like that exposing patient to tafasitamab in this case was not associated with a significant loss in CD19. So going to the conclusion of this study, I think this is very important to set the stage for a new standard as soon as it is approved for the relapsed refractory follicular lymphoma patients, starting from first relapse, considering the higher efficacy of the combination and considering also the very limited and very limited problems associated with the safety, which was very well acceptable and very well taken. Of course, we need more follow-up to see overall survival data. And I think this is the first big change that we are looking forward to improve our management of follicular lymphoma patients starting from the first relapse. And new data are expected for the currently ongoing and still open study, mainly in second line, which are comparing additional and alternative options, mainly represented by the use of bispecific antibodies. And with this, I would like to thank you for your attention, and I'm very happy to take any question.
Thank you very much for summarizing these abstracts, and we'll have some time for questions. Dr. Mubarak.
Thank you so much, Prof. Numenari, for the excellent presentation. A question about the in-mind. Do you think the R-square with this data still an acceptable option when the TAVA is available? That's the first one. And how would you position the TAVA-LIN within the landscape of the relapsed refractory, especially for those who progressed after the bendamustine rituximab in the second line?
Very important question about the treatment algorithm, which is, I think we can update now with this data. If TAFA R-square is available, I think there is no role for R-square alone. I would favor TAFA R-square in all the patients that I would consider for R-square. And I think that the second question is that we may say with enough robustness of data that we have a new standard for second line therapy in follicular lymphoma, which is TAFA R-square. And I didn't show you the data, but there are additional analyses conducted about prior therapies, and where they also looked at the prior bendamustine exposure, and still there was difference and the TAFA R-square was associated with better efficacy compared to R-square. Also, when bendamustine was used as a first-line therapy in the patient who were primarily exposed to bendamustine.
I think one important question will be whether this will compete with chemoimmunotherapy, because we don't know, of course, we don't have head-to-head comparison with TAFA R-square versus chemoimmunotherapy, but that will be the next question with these chemo-free regimens, and whether they are best, or we should think of them in a subgroup of patients or for all patients, and it will be difficult to decide for a patient. Of course, cost is another important factor in this, because it will be very expensive compared to chemoimmunotherapy.
Yes, this is a very important point. I think that we are reshaping the treatment paradigms for follicular lymphoma. So assuming that we have all the options available, I think that today the only place for chemo is first line. Starting from relapse, I think there is no need to expose patients. Of course, considering patients who are not transformed and assuming that at least the first relapses are every time biopsied to exclude transformation. So if a patient is relapsing with follicular, I think there is no role to give additional chemotherapy starting from first relapse. I would start with chemo-free second line. I already started to do this with R-square before TAFA R-square data became available, because you know how, so the R-square is active, but even if it is not active, it allows with bispecific and CAR-T. So I think that we can imagine a full chemo-free approach to follicular lymphoma patients starting from second line. And if your question is also about autologous transplantation in relapsed follicular lymphoma, there was some recommendation about use of ICT in second line for POD24 patients. But I think that, again, considering how active are these agents, how safe they are compared to high-dose chemotherapy, I would personally avoid autologous stem cell transplantation, I would say, in most of the patients. Maybe some exceptional very young case with a very aggressive disease, but maybe in this case we are discussing about transformed cases.
Thank you very much, Dr. Luminari. So we've got, a couple of minutes to ask one more question. Go ahead, please.
Thank you for your talk. If you consider that all options are available, bispecifics and tafasitamab, and what would you choose for your second line? Would it be an option to use a bispecific rather than an anti-CD19, putting in mind that you're going to use a CAR-T cell in third line?
Yes, so clinical trials are currently on the way for disclosing that data. I think that at next ASH we will see some preliminary data about the bispecific study in second line plus. Remember, most of these studies, I would say all of these studies are considering bispecific in combination. So EPCO R-square and Mozu-Lena, they're not using bispecific alone. So it's a very difficult question without any data from randomized trial. I think that they're both effective. They're probably, I like very much the idea of combining a bispecific with lenalidomide. And in this case, I would probably favor a bispecific in combination versus TAFA R-square instead of just giving bispecific single agent. And in this setting, I would probably keep CAR-T as third line. Maybe considering an earlier use of CAR-T only in patients with early relapse, so about 24 young patients in this case, but I think they represent 10-15% of the cases. Assuming that the data for the ZUMA-22 study are positive, which is study comparing CAR-T versus immunochemotherapy or R-square in second line POD24, that would be my main choice for CAR T. Well, otherwise, I would keep CAR T for third line.
Any other question? Okay, one more question here.
Ciao Stefano dal Gisa.
Hi, ciao.
Ciao. I have a question regarding the first line, and is if you consider chemo-free regimens for first line and when?
This is a great question. I think that we can imagine a full chemo-free approach for follicular lymphoma patient, even if today we don't have that magic drugs in first line. We have a very important chemo-free agent which is available, which is rituximab. When given as single agent, it is a full chemo-free program. And in low tumor burden, you may remember the recent update of the Ardeshna study for low tumor burden patient. You can have 2/3 of the patients treated with the rituximab single agent. These were low tumor burden, advanced stage, were still free from subsequent therapy after 15 years of follow-up. In this case, if the patient relapse, you can still stay on chemo-free approaches, R-square or tough R-square in the future, and then move to the T-cell engager, the CAR T. So for the time being, I would consider more frequent than in the past to give rituximab single agent to some patient starting first line and allowing to stay chemo-free from the very beginning. Of course, when the data from the currently ongoing randomized study comparing bispecific versus immunochemotherapy will be ready, then we may imagine a different future. But today, we can already stay chemo-free for some patient without harming the patient with projected overall survival, which is very similar to those patients who start with immunochemotherapy. But this is something that we should start thinking about. Since it is an indolent disease, but with a long-lasting course of the disease, which is measured into decades, there's no need to push too much on the toxicity.
Great. Thank you very much, Professor, and we will move to the next speaker.
Thank you.
Thank you very much.
Enjoy the rest of the meeting.
All right, so thank you very much. And moving on from a disease of the elderly to a disease of the young people, Hodgkin lymphoma, there's nobody better than Dr. Riyad Al-Faqih to summarize our best of ICML. So Dr. Riyad Al-Faqih is a professor of medicine at Al Faisal University, and he's a consultant hematologist and therapist at King Faisal Specialist Hospital. So Dr. Riyad, what's new in Hodgkin lymphoma?
How about now? Okay. So thank you for inviting me and thank you for the nice introduction. I was asked to summarize two abstracts about Hodgkin lymphoma from the last ICML meeting. So the first abstract is about therapeutics, teslilizumab, a new checkpoint inhibitor, and the second abstract is about minimal residual disease use in Hodgkin lymphoma. So as you know, checkpoint inhibitors are very effective in Hodgkin lymphoma, and that's because of the immune escape that exists within the microenvironment in Hodgkin lymphoma. So these drugs are very effective, very well tolerated, and we started to use them in the second, third line, but nowadays, even in the first line, we do use checkpoint inhibitors. So teslilizumab is anti-PD-1, pretty much like Nivo and Pembro. The difference is it doesn't bind much to the macrophages, and as such is not cleared quickly. So maybe the persistent is higher than the other checkpoint inhibitor. Also, it has a higher affinity to PD-1, so maybe it has a better efficacy. In a Chinese population, so the first phase 2 trial was done in a Chinese population, and you see the result, the overall response rate 87%, CR rate 63%. This is pretty impressive for a single agent checkpoint inhibitor. And the question of the current study is to confirm these findings in a different population, mainly Caucasian population. So this is the TIRHOL study. So the TIRHOL is teslizumab in patients recruited from France, Belgium, US, and Australia. So predominantly Caucasian people as compared to the other study, which is predominantly Chinese or all Chinese patients. So they had two cohorts on this trial. The first cohort is patients who had a transplant in the past and then failed 2 or more lines and then got the drug on this trial. And the second cohort is patients who are not eligible to transplant, failed 2 drugs, and then were recruited on this. They made some amendments in during the study. So they allowed patients with more than 1 line of treatment to be recruited, not 2 lines. And also they allowed patients without prior exposure to BV to be recruited. The primary endpoint was overall response rate, and you see the secondary endpoint, duration of response, TTR and CR rate, as well as other exploratory endpoint like PFS-OS. So this is the patient population. Again, we have 2 cohorts and 45 patients in total. The first cohort is post-transplant, and you see this is a young cohort, and probably this is why they were eligible to transplant. The majority received BV before, 78.6%, and 43% received radiotherapy, and all of them were transplanted, so 100% post-transplant failure. Cohort 2 is a little older, 69, and this is why probably they're ineligible for transplant. As you see, around 42% of these patients were refractory to the prior line, and 74% did receive BV in their previous treatment regimen. So this is the result. Last column is overall, and then cohort 1 in the first and cohort 2 in the second. So as you see, the CR rate is 31% as compared to the Chinese trial was 63%. So big difference, almost half. And the overall response rate, 66.7%. And again, in the Chinese trial, it's 87%, also much higher. So it did not translate in a Caucasian population. And if you look at the cohorts specifically, so you see cohort 1 is post-transplant cohort. The complete response is little higher than the cohort 2. But all in all, when I look at it, it's pretty much like the current checkpoint inhibitors that we use currently. Now, they had described the pattern of response on this checkpoint inhibitor. So as you see here, the median time to response was 2.69 months, and that's pretty much like the checkpoint inhibitors. Duration of response, 12.3 months, but was much higher in patients who achieved complete metabolic remission, 25.6 months. And 4 patients of these patients, although were ineligible to auto, underwent auto later on after receiving the treatment. Now, they describe different pattern of response with this drug, and I'll show you a few slides about this. So on this slide, you see some patients, when they were started on the drug, imaging showed progressive disease, but later on it showed response. And this is well-known phenomenon for checkpoint inhibitor. You can have a flare and then patient respond. So these are 3 patients who did that. 5 patients did not have a flare, okay, did not respond, but their clinical symptoms went away, and they were treated for a while on this trial. And then 8 patients, they got initial response and then lost response, then responded again. So in total, 16 patients had these, response pattern and were counted as progression in the evaluation, but they were on the drug for a median of 9.8 months despite progression, or by definition, a progression of the disease. This is one of the examples. So this is a patient treated with ABVD and then auto transplant and then started on the trial. After 4 cycles, he's in CMR. At cycle 20, he has progression, but clinically was fine. So he was continued on the drug and received 33 cycles in total. So 13 cycles more
after progression. So that's around 39 weeks, and then relapsed with obvious relapse. So basically like a stable disease or clinically stable disease despite little progression on imaging. So PFS, 5.6 months, OS, 75%. The causes of death, as you see, lymphoma progression, toxicity, 1 case of peritonitis and 1 septic shock. And you see the graphic presentation of these patients. Adverse events, pretty much reflecting the checkpoint inhibitor adverse event. If you look at the immune-related adverse event, the total rate was 37.8%, but the above grade 3 were limited to only 6.7%. So pretty much well tolerated like any other checkpoint inhibitors. Now, this is about the pharmacokinetics. So what they showed with the dosing, the concentration goes up, then stabilize. On the last curve, what they showed, patients with stable disease or progressive disease did have lower concentration of the drug in the plasma. They also demonstrated that some patients developed autoantibodies to the drug, so probably eliminating the drug much faster. And maybe this is the group who ended up with stable disease or progressive disease because they're eliminating the drug by immune mechanism. So all in all, overall response rate 64%. CR was 43% in cohort 1, 26% in cohort 2. Durable responses specifically in patients who go into CR. But again, because it's complex to evaluate these patients by imaging as a result of the pseudo-progression, maybe a better way to track them with MRD when this becomes standard of care. This is a slide, that I added. So this is the other checkpoint inhibitors, comparing them to tislelizumab. So as you see, Nivo resulted in 69% overall response rate and PFS 14.7. Pembro in the phase 2 resulted in 72% overall response rate, CR of 27%. And this is Keynote 204, Pembro versus BV, overall response rate 65 and CR 24%. So pretty much same efficacy. So it's another checkpoint inhibitor added to the ones available on the market. So I don't see it as a home run, but it is one other option for these patients. So the second abstract was about the use of minimal residual disease in Hodgkin lymphoma. You all know the SWOG 1826 trial, Nivo AVD versus AAVD. So this trial was very well taken in practice, and many people started to use Nivo AD as a standard now because it showed little better progression-free survival, but most importantly, a better tolerance profile as compared to BV-AVD. During that trial, the investigators, as a collateral investigation, they checked for circulating tumor DNA at baseline, before cycle 3, and the end of therapy. So this abstract looked into these MRD patients and the significance of MRD. And why they are doing this? Because, as we said, imaging PET scan can show false positive and false negative. So MRD may be a better way to identify these patients, more sensitive and more specific. And as such, we can tailor our treatment based on the results of MRD rather than PET directed. So the way they did a targeted panel to detect these mutations, and they did whole genome sequencing. So it's not only positive, negative MRD, they were also able to quantify how much of this circulating tumor and DNA is available in the plasma. So it's quality and the quantity of the MRD. So this is the patient population. They took 400 consecutive patients, 401 consecutive patients on that trial. It's like random, okay, 400 patients consecutive. And 13 of them, they were unable to do the MRD, so they were excluded. The other 13 did not have a mutation burden at baseline, so there is nothing to track, and as such were excluded as well. They ended up with 375 patients. as you see here. And on these 375 patients, we did have the baseline, the before cycle 3 and end of therapy result, and they correlated these results with the PFS and so on. So on these patients, 388, remember SWOG has around 1,000 patient plus. So on this subgroup with MRD testing, they looked into the PFS. So Nivo-AVD PFS was 91%, BV-AVD PFS was 81%. And that's in parallel with the results of SWOG 1826 because the PFS at 2 years was around 92% for the whole population. This is the baseline characteristics of these patients, 375 as we said. So young population, 25, 53% female, races, you see them over here, all advanced disease because SWOG was stage 3 and stage 4. B symptoms in 61% of patients, high IPS in 37%, bulky disease 30%, and you see the split of therapy for these 375, so almost equal in between Nivo-AVD and BV-AVD. So this is the result, okay? At baseline, everybody has MRD, right? So everybody has these molecular signatures that we will follow. So that's the dark blue. And before cycle 3, only 16.9% have persistent MRD. The others, the MRD is gone. At the end of therapy, 9.3%. And then they look into this for Nivo-AVD versus BV-AVD, and you see the numbers there. No big difference, right? So at baseline, everybody has these mutations. Cycle 3, 17%, 8% at the end for Nivo-AVD, and then for BV-AVD, 16.6% and 10%. So pretty much the same results, and you expect around 83% to be MRD negative in the interim, so before starting cycle 3. They looked into the baseline MRD. So when they checked baseline MRD for these patients, they looked into the high-risk patients. And evidently, the high-risk patients, like patients with B symptoms or patients with high IPS defined as 4 and above, had higher level of this mutational burden, as you see in the green curves, okay? So patients with higher risk disease had higher level of mutational burden at baseline. And here's the result. So if you look at patients with high tumor mutational burden at baseline versus the ones with lower, the one with lower had a better PFS, 89% versus 82%. So at the presentation, if your burden is high, your PFS is lower probably. And that translated the same if you split it by BV-AVD and Nivo-AVD. So basically, high baseline circulating DNA correlates with worst outcome, whether this is from the DNA or just because these patients are the high-risk patients, we can't tell. Now, this is the nice finding about this study. So this is cycle 3, inter-M MRD. If you're inter-M MRD, your PFS is 64% versus 91%. So very big difference, statistically significant. If you look into it for Nivo-AVD versus AAVD, similarly, there is a split and statistically significant. So if inter-M MRD is positive, that correlates with much worse PFS as compared to the negative. Now, because they were able to do what we call quantitation of this MRD, so what they did the amount of drop in the MRD. So they said some people dropped a lot, some people, but stayed positive. Other people dropped a little and stayed positive. So let's see these patients who dropped a lot versus dropped a little. Does it make a difference? And here you can see these patients. So in gray are the MRD negative. In green are the ones who dropped, but not much. In blue are the ones who dropped significantly. And the cut line was 3.64 logs. There were 31 patients on each of these groups, the major drop versus minor drop in baseline circulating tumor DNA. And what you see, the ones with a major drop actually run very close to the negative MRD. So if you have a major drop, so they established like a significant drop. Okay, you don't have to be MRD negative, but if you drop 3.64 logs from the baseline, probably you're like the MRD negative patients and you behave very well. And even if you're MRD positive, probably you don't need to do anything or escalation of treatment. And that translated well for both Nivo-AVD and BV-AVD cohort. End of therapy. If positive end of therapy, that's bad. PFS 42% versus 92%. So this group, probably you have to intervene definitely. And if you do it also by Nivo-AVD versus PV-AVD, also the split is there and very statistically significant. So very sensitive. End of therapy positive, 60% chance of progression at any time point. So in summary, circulating tumor DNA was present in 97% of classic Hodgkin lymphoma patients. And 3%, they were unable to detect the mutation and as such do ctDNA. The clearance in the interim before starting cycle 3 correlates with the better progression. If you have major clearance of the circulating tumor DNA, it also behaves like a negative MRD. At the end of therapy, if the patient is still positive, the risk of progression is around 60%. And their conclusion that this technique is probably ready to be used in clinical practice to treat these patients. Now, what is not clear is what you do with these patients who are, minor drop on the interim. Do you escalate their treatment? We don't have an answer. That's not tested. For patients at the end of therapy who still have MRD, 60% risk of progression, also, what do we do? Do you transplant these patients? What do you escalate? What do you do? Also, we don't have answer for this. But at least prognostically, this test can help you to watch these patients maybe closer and be ready to escalate your treatment as soon as you detect signs of progression. And that's it. Thank you.
Thank you very much, Dr. Riyad. Very nice and informative summary. So we'll open the floor for questions. So Dr. Mubarak.
Thank you, Dr. Riyad. So do you have any explanation if we are talking about the ctDNA almost the same in both group at cycle number 3, like 16, 17, 8, 10, but by the end we still had that major differences. We used to say in an elderly patient maybe more interruption of the brentuximab AVD, but that was not reflected by the end of therapy circulating DNA positivity. So do you think the subsequent follow-up into the negative ctDNA a longer time made any differences between the two groups? Because you would expect if they have the same outcome at cycle number 3 and end of therapy, at least they have a comparable outcome at the end, not that major differences in at 10%, maybe absolute differences in progression-free survival.
I'm sorry if I don't know if I got the question very well, but you're asking about the negative and the major drop, if it'll stay the same or?
Yes, I mean, the primary endpoint was the progression-free survival, and it was a 92 for the Nivo-AVD, 81% for brentuximab. If we are talking about the same ctDNA positivity and negativity at cycle number 3 and end of therapy, so how do we explain that differences?
I see. So why there is difference despite the clearance of the MRD is similar? That's a good question. In my assumption, because AAVD was more intense and more toxicity happened, it may be because of delays of treatment or, as you know, on the echelon, as well as on this trial, many patients ended up with dose reduction and dose discontinuation in the AAVD as compared to the Nivo-AVD. There was statistically different number, of discontinuation in between the two arms. So probably it's because of the side effect. Many people on the AAVD progressed.
It might be just the sustainability of the RD, maybe that's the point, but we don't have just only end of therapy. We don't have any subsequent.
Correct. Correct. Needs more follow-up, يعني, and then it'll answer this question.
Dr. Riyad Dada.
Thank you, Dr. Riyad, for your elegant presentation. Tislelizumab, pembrolizumab, nivolumab. Tislelizumab, as you know, is the FC part is engineered and differently from the Pembro and the Nivo in order not to be eliminated very quick through the macrophages. You mentioned the Chinese data, the first data, 60 and above 63, 64%, the complete remission rate, and this study showed 42%, 43% complete remission rate. And Pembro and Nivo, I think there is a difference, Riyad. Pembro and Nivo, the highest complete remission rate. So it's between 20 to the highest, what I remember, is 28%. It was with pembrolizumab in the phase 1 trial. But on the other hand, the progression-free survival, Nivo and Pembro, 14 to 16 months. Here you mentioned, I think, something with 12 months.
Yeah.
So what's your take, Mr.?
First of all, these are different trials. So we're comparing trials to trials. Patient population is different. Do I see a big difference? Frankly speaking, no. I mean, the way we teach our fellows, I tell them, you know, with checkpoint inhibitors, 2/3 will respond. So overall response rate, 67%. And 1/3 may be in CR. Okay, that's 30%. And this is what this drug showed. I don't see it as a big difference. Now, they talked about these 16 patients that they responded, did not respond, but probably similar scenario happened with the Nivo and Pembro trials, but because we didn't know this phenomenon, it was not reported. I don't see it very different, frankly speaking. It's pretty much the same.
Okay. One more question, Doctor.
Okay, thanks, Dr. Riyad. So how can you explain with the checkpoint inhibitor in the cohort 1, that's the group received it after auto-transplant, they did better in terms of responses, although you would expect these patients are, you know, more heavily treated and they do worse. So that's the first question. Second question, any data for use of allotransplant with the rate of GVHD in that group of patients?
So no data on GVHD and tislelizumab. And regarding the other patient population, you know, when you use checkpoint inhibitors, you depend on the patient's immune system, right, to do something and declare the tumor. It's true that they got auto-transplant, these patients, and they may be more treated than the other group. But at the other end, they were much younger as well. There was 20 years difference. So I don't know if that explain, you know, the different immune response or more stringent immune reaction, and as such better result in the younger group.
Okay. So we've got some time, Dr. Riyad. So if you allow, so I think the population is not necessarily a population you'll see in your clinic. Most of the patients you would transplant, you would put them on BV maintenance, and later on when they progress, they'll go to a checkpoint inhibitor. Do you think those patients' outcome would be worse if they've been maintained for 2 years or so on brentuximab?
Well, probably, brentuximab beats the marrow, beats the immune system. Plus, it's another drug, whether you're using it in maintenance or not. That's like another line of treatment for these patients. Would have side effects, would have organ dysfunction, and as such will result in different outcome, probably because it's a heavier heavier treated population when you use maintenance. Now, these checkpoint inhibitors are amazing, actually, the way we play them in the clinic. I don't know if you do the same, but I do a lot of games in the clinic. So I stop checkpoint inhibitor and patients go into remission. So they have positive PET. I used checkpoint inhibitor for a year and a half, positive PET. I stop it, they go into remission. And then when the disease comes back, I give them the same treatment, they go into remission. And the other thing is, what I started to do actually, I do checkpoint inhibitor. When in CR, I do 6 months and stop, and I've seen patient 2 years now, free of treatment, and if the disease comes back, you re-challenge. What I've seen also, patients on Nivo progressed clearly, despite all these immune manipulation, I call it. And then when I gave them Pembro, they responded for another 8, 9 months, 10 months. So it's amazing because you're using the immune system and you don't have control on all the variables in the immune system. The other thing we did in our center, actually, so, when all these agents fail, you do allotransplant. So we did allotransplant on a number of patients, and they were exposed to checkpoint inhibitors before allotransplant. Okay, they got allotransplant, failed post-allotransplant. We give them very low dose of nivolumab, 40 milligram, 1 vial. 5 out of 6 went into remission. Okay, 40 milligram, 1 dose, and you sit tight. You watch for GVHD, and you watch for response. If they respond, you don't do anything if they're in CR. If they respond, and the GVHD depends on the amount you decide later on. But 5 out of 6 went into CR. And these are all checkpoint inhibitor failures before allo. So they were exposed and failed, and then went to allo. So these immune manipulation are amazing. You just have to, and the disease gives you some time because it's not diffuse large B-cell lymphoma. It's not Burkitt. So you do have some time to manipulate these. And I always do it, actually. Sometimes, when my patient is a stable disease on Pembro. So what I do, I start spacing Pembro rather than every 6 weeks. I have patients on every 9 weeks now of Pembro. Life is good. They come every 9 weeks. They take a dose, stable disease,
So interesting. And so now in your center, the first line is a checkpoint AVD. So
Nivo AVD for advanced disease, yes. Except if patient has autoimmune disease, then we don't use Nivo AVD. We use AAVD.
Okay. And do you think our labs will be able to do a ctDNA? Because there is an evolving literature, even in DLBCL, those people who are MRD positive, they will require some sort of a change in therapy.
Yeah, well, there are commercial now for, like the clonosec for diffuse large B-cell lymphoma. They should be able to do it. The other question is if you can, and we tried several times actually to do it, if you can do a more sensitive, mutational analysis and get a more sensitive test. What we tried to do actually, and we did not pursue it, unfortunately, we isolated Reed-Sternberg cells. So when the tumor is fresh, we did flow, isolated Reed-Sternberg cells, and we told the lab to do sequencing on the Reed-Sternberg cell itself. Okay. And then find, some markers that we can follow on patients. And we did it on a few patients, then we stopped because of the funding. It needs a lot of money to do the isolation on flow and then to do the sequencing. So you may be able to find a signature in Reed-Sternberg cells because, Hodgkin tumor is tons of other things, right? And when you do circulating tumor DNA, it may be true, it is a Hodgkin lymphoma, but it may be coming from the microenvironment rather than from the Reed-Sternberg cell. So if you identify, these variable mutation in the Reed-Sternberg cell itself, you may be able to find a more sensitive test and 100% positive, not 97% positive, and very sensitive for follow-up.
Sounds good. Any further questions? I think with this, we will move on to the next speaker. Thank you very much, Dr. Riyad.
Our next speaker is Dr. Badr Al-Ahmari. He's very well known in hematology field in Saudi Arabia. He's a chairman of Blood and Cancer Research Department in KMARC. He's a consultant in adult stem transplant and cellular therapy Department of Oncology in National Guard Riyadh. And he will summarize to us the local experience in their hospital with T-cell lymphoma.
Assalamu alaikum wa rahmatullah. Thank you, Dr. Musa, for a nice presentation, and thank you, SSBMT, for the invitation. to present our experience with the T-cell lymphoma. It will be very difficult to present data after the data of Dr. Mubarak Mansour. Congratulations, Dr. Mubarak, for your achievement and the publication for T-cell lymphoma. And I hope this data will complement your data as well, to have more and more data from our area is very important to inform the decision for the T-cell lymphoma in our public population. So as we know that, as Dr. Mubarak mentioned, that peripheral T-cell lymphoma considered an rare entity post compared to B-cell lymphoma. And it accounts around 10% of all non-Hodgkin lymphoma. There are some percentage that was shown by Dr. Mubarak this morning, maybe even higher than 10% of non-Hodgkin lymphoma. Male predominance is one of the known features of T-cell lymphoma. And according to WHO classification, there are more than 20 subtypes of peripheral T-cell lymphoma. The frequency of subtypes vary by geographical region, with BTCL NOS being the more common in Europe and North America, while the NKT cell and angioimmunoblastic common in the Asian population. This is a recently published data. It showed the long-term follow-up based on the International T-cell Lymphoma Project. It's a registry that is collecting data in a prospective manner. Around the world, they have more than 1,500 case. However, only 735 they meet the eligibility of more than 10 years follow-up, and they show us clearly here that 10 years overall survival is around 40%, which is much lower than what we see with the B-cell lymphoma. And what they noticed that patients who exceed 5 years of follow-up and they are alive and free of disease, they do actually better, and with an overall survival, 10 years of overall survival of 84%, indicating that there is a huge unmet need in achieving the remission in the upfront setting. And by doing multivariate analysis, they found that age, echo performance status, and IPI score are heavily associated with outcome for those patients. And also the most important thing is achievement of CR or the response to the first line of therapy, again indicating unmet need in providing an adequate upfront setting treatment for those patients. So what we did a retrospective chart review for peripheral T-cell lymphoma, age above 14 years old, who were diagnosed from January 2014 to December 2024. So it's around 10 years period. And we did survival analysis with estimated by Kaplan-Meier method. And also we did a univariate and multivariate analysis using Cox proportional hazard time to event for the overall survival. In this model, actually, in the univariate analysis, we include any variable less than 0.25, while in the multivariate analysis, variable less than 0.05 were considered significant. And why we did this? Because we want to include every possible variable from the univariate analysis, so we don't want to exclude potentially important variables. So what we found that over 10 years, we had 62 patients with the median age of 56, male predominance 77%, peripheral T-cell lymphoma NOS with the predominant subtype 30%, followed by angioimmunoblastic T-cell lymphoma 19%. ALK negative is actually more common with 17%, followed by NKT cell lymphoma, and ALK positive only 8%. Of course, as is known for this disease, 80% of patients, they are with advanced disease, like stage 3 or 4. Extranodal was in 72%. Majority of them, bone marrow involvement, skeletal involvement, but also there are many of them in the gastrointestinal system and lung and so on. We found only 6 patients, they have CNS involvement. Bulky disease seen in a small fraction of patients, 17%. Bone marrow involvement, only 17% of patients bone marrow was done for them, and 36% of them it was involved. LDH was high in 70% of patients. In terms of histopathological aspect, 69% were CD30 positive. Any positivity above 10% considered positive. And EBV in the pathology were seen in 35% of patients, and K562 was more than 30% in 67% of patients. Echo performance status more than 2 in 24% of patients. This is reflected because the median was 56, a little bit younger population here. The IPI score was more than 2 in 60% of patients, and comorbidity index more than 3 in 58% of patients. The first treatment was only received in 54% of patients, so around probably 1/3 of patients could not or a quarter of patients could not proceed into therapy. And I noticed this also in the data of Dr. Mubarak al-Mansour, that 1/3 of patients probably they could not receive the proper treatment or any line of therapy. Again, this is really huge and unmet need, and their prognosis was really dismal. And when I reviewed quickly, I found that age can contribute. Most of them, they are elderly population, but also some of them are young, but because of the disease rapidness and rapidity and the disease in the progression of the disease and requiring ICU in the upfront setting, we could not treat them with the proper treatment in the upfront setting. So CHOP-like was the dominant one. 29% of patients treated with CHOP-like regimen. CHOP was incorporated later with 27% of patients, and more recently, CHOP-BV was treated in 11 patients. And subsequent other type of therapy was multi-agent. Some of them are lighter, and some of them are intense treatment, especially for the NKT cell lymphoma. Brentuximab vedotin was used in 30% of patients, like 17 patients received brentuximab either in combination with the first line of therapy, and some of them they use it in the relapse refractory setting. Autologous transplant consolidation after first line were only done in 16% of patients, indicating this is really a very fraction of patients were able to do for this, mainly because of either age, comorbidity, and majority actually because they could not achieve adequate response. Radiotherapy were used in 18% of patients. At the end of the first line assessment, which is the 54 patient, the CR rate was 51%, were able to achieve CR, and overall response rate was 59%. Other patients, they were in progressive disease. And those who went into subsequent therapy, which is 23% of patients, that means less than a half of patients, you will be able to move them into subsequent therapy. Only 30% achieve CR with overall response rate of 43%. Subsequent autologous transplant were seen in 17% of patients, and 3 patients, they went into allogeneic transplant. Those patients were actually, they are many years away from disease. They are alive and free of disease. So with the median follow-up of 48 months, the median overall survival, median progression-free survival was 12.3 months, and the 3-year progression-free survival was around 25%. Median overall survival was 19.8 months with a 3-year overall survival of 44 months. What's important here or interesting here, we did like an analysis looking into patients who receive brentuximab vedotin at any time, whether they use it in the upfront setting or they did use it in the relapse refractory setting as a salvage therapy. And we found those patients who did expose to brentuximab vedotin, they did actually better, with the median overall survival was not reached after 48 months of follow-up. Versus 12 months for those who did not receive brentuximab vedotin, and statistically was significant. Of course, there are maybe other factors contribute to this, but this analysis does not account for other covariants. Doing univariate analysis, we were able to include bone marrow infiltration, which was significant, CD30 expression, echo lymphoma status, comorbidity, status at the end of therapy and use of brentuximab vedotin were all significant, and we're able to show that they are significant according to the pre-specified cutoff, and we're able to see that they are significant by using in the univariate analysis. However, in the multivariate analysis, only disease status actually that was able to predict the overall survival, indicating that achievement of CR in the upfront setting, this will determine the future outcome for those patients. Again, this is a huge unmet need for patients with T-cell lymphoma. So in conclusion, we show our characteristics for our T-cell lymphoma cohort. Although the number is small, however, we found that survival rate probably similar to what's already published somewhere else. And we show clearly that achievement of complete remission is a strong predictor of survival. And then I would like to thank Dr. Dhaha Al-Ahmadi and Dr. Angham. They started this project with me when they were residents, and now they are fellow with the F2 fellow in our program. And also our lymphoma nest coordinator, Dr. Mariam Al-Tayri. They did a great job in developing the protocol and collecting the data. Thank you very much, and happy to take any questions.
Thank you very much for sharing the experience. Very nice work. Congratulations. I have a question, and then we'll open the floor for other questions. About the consolidation transplant, the rate was, I think, 16% in your slide?
Yeah, very low, yeah.
Very low rate. I would expect to see higher than this. So what is your explanation?
Although the CR rate was around 50%, but when you look at it, I didn't do it. We do have the data, but we didn't analyze it. Although the number is small, but I think majority of the reason because either age, unable to tolerate beam conditioning regimen, also presence of comorbidities as well, and yeah, I think this is what was the major reason not to proceed. And some of them there's no indication to consolidate because either to have a low IPI score and so on.
Did you do analysis comparing different eras?
No.
Like before or after?
Before, after the brentuximab, no. We don't have enough number of patients to do that.
Thank you very much. Any question? Okay, so if there is no further question, we can move to the last part of this session.
So the last but not least is a topic about diffuse large B-cell lymphoma, best of ICML abstract presented by Dr. Khalid Al-Dosri. So Dr. Khalid is actually well known as a lymphoma specialist from King Abdulaziz Medical City National Guards, and he has been instrumental in establishing and maintaining the lymphoma service for the last couple of years. So Dr. Khalid, the floor is yours.
Thank you for the introduction. It's really an honor to be with you today for this remarkable meeting. So thank you for the SBMT team for the invitation and the excellent arrangement. Here we have three abstracts focusing on DLBCL in elderly, hoping to find the best modality of treatment to treat them. So the first abstract was presented by Dr. Bilada, EPCOR DLBCL3, fixed duration, epcoritamab monotherapy, in older than 75 years, anthracycline ineligible patients with previously untreated large B-cell lymphoma. So as we know, chemotherapy containing regimen, including R-CHOP and mini-R-CHOP, is the standard of care. However, 10% of the newly diagnosed patients may not be able to receive this treatment either because of the age or either because of the comorbidities. So unfortunately, they have shorter BFS and overall survival. Epcoritamab is a subcutaneous CD3 CD20 bispecific antibody that has demonstrated deep and durable response across the line of therapy and may provide chemo-free treatment option. So it is a phase 2 open label trial evaluating efficacy and safety of fixed duration epcoritamab in elderly patients with newly diagnosed large B-cell lymphoma. However, they should be ineligible for anthracycline-based chemotherapy, either due to age of above 80 or above 75 with comorbid conditions. So the patients was randomized 1-to-1 to 2 arms. The arm that we are focusing on is the epcoritamab monotherapy. That was given from cycle 1 to cycle 3, Q weekly, and then cycle 4 to cycle 12, Q 4 weeks. The primary endpoint is the CR rate per Lugano criteria. So after screening and randomization, 44 patients has received the epcoritamab monotherapy. 9 of them completed the treatment. And upon the data cutoff, 14 patients were still ongoing therapy. However, 21 patients discontinued the treatment, mostly because of the disease progression and adverse events. So the median age is around 81, and those who are above 80 is around 80% of the patients, and those with the IBI of 3 to 5 was around 60%. Here's the cardiovascular comorbidities and risk factors. 87% had cardiac or cardiovascular disorders. However, it's a bit concerning here that those patients, most of the patients had hypertension, around 71%, and those with reduced ejection fraction was only 4%, 2 patients, because as we know that receiving at least little of anthracycline is better than nothing, even in unfit patients. However, 40% had another comorbidities that made the patient ineligible for cytotoxic treatment. So the CR rate was around 70%, and the overall response rate was around 78%. A preliminary data for the MRD assessment showed that 93% of the patients achieved the MRD negativity at cycle 3, day 1. So most of the responses occurred early. Median time to response was around 1.5 months, and the median time to CR was around 2.5 months. The responses gets deepened from PR to CR in 7 patients. So at the data cutoff, 84% of the patients, all responders, and 89% of complete responders were still ongoing. Although the time follow-up is not that long, the median follow-up was around 8 months for the PFS with 73%, and the overall survival was around 81% with 9 months follow-up. Here's the toxicity profile. The epcoritamab was generally tolerated. However, 18% of the patients had serious infections. 9% of them was COVID-19. The 18% experienced treatment-related epcoritamab leads to discontinued epcoritamab, and those also have mortalities around 5 patients. We'll talk now about the CRS. It was in general manageable because almost the events were a grade 2 to 1 and 2 with a few grade 3. It was also timely predictable, as 97% of the CRS events occurred in cycle 1. The icons here is pretty concerning because of the number of the events. It's around 16%, which is higher than what we expect from the bispecifics. However, it was mostly a grade 1 and 2, and it was manageable and resolved. It could be because of the characteristics of the patient, the baseline, as most of the patients had previous stroke and peripheral neuropathy and a CNS problem.
So in conclusion, fixed duration of epcoritamab monotherapy led to high response rate and manageable safety profile. Early and deep responses were observed, and the safety was consistent with the prior reports of the epcoritamab monotherapy. So we can see epcoritamab is one of the future treatment for this group of patients. The second abstract is about Arbola Glow, Chemolite Frontline in elderly patients with aggressive B-cell lymphoma, was presented by Dr. Rabika Kizera. So Arbola Glow is a combination of 3 highly biologically active anti-lymphoma agents, rituximab, glofitamab, and bolituzumab vedotin. So it is one arm, multicentric phase 2. The initial cohort is around 80 patients, then extended to involve 45 patients more, and 30 centers in Germany and Austria. It involves aggressive large B-cell lymphoma, previously untreated patients, above 60 years, not eligible for those R-CHOP like therapy at discretion of the treating physician. Again, the same concern of chemo eligibility as the previous abstract with the epcoritamab. So the primary endpoint is the 1-year BFS rate. So the study started with the debulking by steroid, and the cycle 1 was involving glofitamab introduced after obinutuzumab and bolituzumab for CRS mitigation. And then the target dose was by rituximab, bolituzumab, glofitamab from cycle 2 to cycle 6, Q3 weekly. And then after that, the consolidation by glofitamab monotherapy from cycle 7 to cycle 12. So they have 4 points for the PET scan before starting the study, then both cycle 2, then both cycle 6, and then both cycle 12 at the end of treatment. So antimicrobial prophylaxis and growth factor support was given as supportive treatment. The cycle 1 to cycle 6 was mandatory as inpatient for the initial cohort. So here we are presenting the initial cohort data. The median age was around 80, and those with abnormal LDH was around 60%. Those with advanced stage was around roughly 60%, and those with IBI 3 to 5 was around 60%. So patient profile aligns with the expected real-world profile of medical unfit and frail DLBCL patients with high treatment complexity. Here is the evaluation by the simplified geriatric assessment that includes activity, daily living, instrumental activity, daily living, SIRS-J, and age. 91% of the patients were considered medically unfit or frail. However, 1 patient has exceeded the cumulative anthracycline dose, and 5 others had relevant cardiovascular comorbidities. Here's the safety profile. The most common side effects was CRS. We'll talk in details in the next slide. 53% of the patients experienced no grade 3 toxicity, and 90% of the patients are alive at the end of treatment. 3 therapy-associated deaths were observed, all infections, and patients with a median age of 86. 2 lymphoma-associated deaths with 1 other cause and 2 unknown causes. So here's the CRS and ICANS events through the cycles. In the top of the graph, we can see that the CRS events was around 21% of the patients, and 2.5% were grade 3. In the bottom of the graph, you can see that the ICANS is around 4% of the patients. So to sum it up, very few, mostly low-grade CRS occurring in early cycles. ICANS were infrequent. So Arbola Glow has an overall response rate of around 90%, with 81% of complete metabolic response rate at the end of treatment. What is interesting here that the CR rate was increased from 73% to 81% from cycle 6 to cycle 12 with the consolidation with glofitamab monotherapy alone. So in conclusion, chemotherapy light ARPOLA glow shows outstanding response rates and manageable safety profile, supporting further clinical evaluation as a first-line treatment option for elderly. This is the third abstract, Verline. It's a nickname of the trial that is part of the ALICE-2 trial. It is tafasitamab, lenalidomide plus rituximab in frontline diffuse large B-cell lymphoma in patients over 80 years or older. It was presented by Dr. Tuslin. So the rationale of this study that they found that in a MIND trial that those patients who received the treatment and achieved at least partial remission after 3 months, they do quite well compared to the other patients. So they try to restrict the clinical design to them. So it's a phase 2 trial, DLBCL, including the high-grade B-cell lymphoma and follicular lymphoma grade 3B. The age is around 80. They should be eligible for R-mini-CHOP, which is in contrast to the previous 2 abstracts. So what they want to do is not to jeopardize the chemotherapy-based treatment for those who are eligible. So if they achieved at least, if they couldn't achieve at least PR after 3 months, they will be eligible to receive R-mini-CHOP, and they will continue following in the trial. So the patients get prephase with vincristine and steroids, and then induction with rituximab, lenalidomide, tafasitamab for 6 cycles. Then consolidation was with tafalen for 6 cycles with reduced dosing of lenalidomide. So 80 patients were screened, and then the safety set was around 68 patients. 67 patients proceeded to induction. Here's the patient characteristics. The median age is around 84, and the patients with advanced stage was around 74%. So Verline trial achieved its primary endpoint. It was the overall metabolic response of 72%, which is actually less important than the complete metabolic remission, because especially in DLBCL, the CMR rate was around 49%. Here's the treatment discontinuation around through these cycles. It's mostly because of the disease progression. However, 57% of the patients started the consolidation phase. Again, although the short follow-up, the median follow-up was around 16 months. The BFS, 1-year BFS was around 52%, and 1-year overall survival was around 82%. The next line outcome, so out of 25 relapsed refractory patients, 20 patients received R-mini-CHOP with overall response rate around 45%. Here's the safety profile, which is again concerning here, as the grade 3 or more were frequent among this elderly population, around 73% of the patients. This was mostly because of lenalidomide. They also developed DVT and BEs around 15% of the patients, although 55% of the patients received DVT prophylaxis. So at the date of cutoff, the mortality rate was around 21%. So the author concluded that chemotherapy-free combination of tafalen, rituximab, and frontline DLBCL elderly patients demonstrated high overall metabolic response However, in this highly comorbid population, adverse events were frequent despite a proactive dose-adaptive design. The chemo-free regimen, which is here the advantage, didn't jeopardize the salvage treatment with arm-mini-chop. So I think we need further clinical trial, randomized clinical trial comparing these novel agents to the standard of care, which is arm-mini-chop. So this is what I have, and happy to receive any question.
Thank you very much, Dr. Khalid. Very exciting, era for diffuse large B-cell lymphoma, especially in the front line. So we'll have a couple of minutes for questions, starting from this side of the room, maybe that side now. So I think epcoritamab reminds me of daratumumab, honestly. It doesn't work as monotherapy, neither in the first line or in the subsequent lines of therapy. And in the elderly, I mean, in this study, the first one you showed, it's for the untreated elderly people, median age 81, and they were planned to be given a sub-Q therapy for a year. They started with 120 patients screen, and they ended up with only 9 patients, finished therapy, which is very disappointing. And then a 20%, so 1 in 5 get an ICANN, which is, a very high number. So in your mind, do you think maybe a combination of, chemo-free therapy is a better option in the first line or even in the relapse setting?
Really, it may be in the future with shortening the period of the treatment, because all what we have, the treatment done, they extend to up to 1 year. And also, I think combination of the bispecific with the other immunotherapy is excellent idea, because I don't think the monotherapy by bispecific would do the job to achieve complete remission and durable remission.
Right. And in your practice, I mean, the study said, they have to be anthracycline ineligible to enroll in the study. But if somebody is 8 years old and has got, diffuse large B-cell lymphoma, do you see any setting where you cannot give, dose-reduced RCVB to those people?
Our population is pretty different from those population they studied. However, of course, doing these scores is better than the eye, but I usually combine them. So I believe if they are fit, at least for a small dose of anthracycline, I would still insist to give it.
I see. And again, I think these are, hypothesis generating studies. They're not meant to change practice, but,
Sure.
could work. Dr. Majid, you can speak up.
It's actually a comment more than a question. So I think part of the reason why with the EPCOR too many toxicities happens, ICANS, maybe because no debulking therapy was given. So these patients, they are elderly, frail, and they're coming with, maybe bulky disease, and then you hit them with EPCOR, you get all of these, adverse effects, which was avoided in the Polar Glufi trial, where they debulk the patient with the steroid and obinutuzumab, and then they hit them with the
Yes, I totally agree. I think this will mitigate the complications, the CRS and the ICANS, and also will be more effective than bispecific alone.
Any other questions? So I think with this, it's actually a very exciting time to first thank Dr. Khalid for presenting, and we would like to have a group photo. So please, everybody, if you can just join us in the podium.
Thank you.
Following this, we will have a 10 minutes break, and we will come back at 3:35. No, yeah.
Hello? Yes. All invited for a group photo, please.
My name is Riyad Dada. I am consultant hematology oncology at King Faisal Specialist Hospital Research Center, Jeddah, and I will hand over to my colleague who will go through the first session.
Assalamu alaikum. It's a great pleasure to introduce my senior colleague, Dr. Ayman Al-Hijazi. He is a well-known consultant hematologist in King Abdulaziz Medical City. He's going to talk to us about the sequencing in the era of BCMA targeting agent. Dr. Ayman.
Assalamu alaikum. Good afternoon, everybody. So since morning, you've been talking about lymphoma. It's time to change habits. It's time to change gears. We'll talk about myeloma for a while. So myself and Dr. Majid after me. في هنا مايك. طب هذا كيف يشتغل؟ Thank you very much. ها؟ هذا كده كويس؟ ممتاز. Thank you. So we'll talk about sequencing in the era of BCMA targeting agents. My disclosure. So this is the timeline since the first monoclonal antibody has been introduced in the treatment paradigm of multiple myeloma. Daratumumab early 2015, and then belantamab mafodotin came into play early 20s, which is an antibody drug conjugate. Talk about that in more details. Isatuximab as another anti-CD38 has been added. And then more recently, we had, and before that, actually, the CAR T cells as a T cell redirecting therapies or T cell mediated therapies, starting with the ide-cel and then the cell-to-cell. And then bispecific molecules, either BCMA or other bispecific molecules that are targeting other than BCMA as an antigen on plasma cells. So we'll talk about each modality of BCMA targeting agents briefly, and then we'll try to find a way how to sequence these, although it's not very clear, but there is the IMWG recommendations, and there are reports of showing some evidence where you can still probably use some BCMA targeted agents earlier than others. So as you know, so far we have 2 CAR Ts approved in the treatment of multiple myeloma in the relapse refractory setting, the ide-cel and the cell-to-cell. They were both, they are BCMA directed. The co-stimulatory molecule is 4-1BB for both, and they have been initially approved based on the KARMA trial and the CARTITUDE for treatment beyond 3 lines of therapy. But more recently, 2 trials have tested the use of CAR T cells on earlier lines. In the KARMA-3, in the third line and beyond, after 2 lines, and in CARTITUDE-4 from 2nd line and beyond. So both have shown a very good overall response rate, but you know, the cell-to-cell, as it has 2 binding domains of the BCMA, has shown a better progression-free survival when it's compared to ide-cel. So basically, CARTITUDE-4 is a trial based on which cell-to-cell has been approved to be used in the 2nd line and beyond. And in the CARTITUDE, cell-to-cell was compared to standard of care, though I did not agree on the standard of care used in CARTITUDE-4. Dara-KD or ISA-KD was not part of this standard of care. But despite this, the overall response rate has been great, beating the standard of care arm, as you can see. So CAR T cell therapies, ide-cel or cel-to-cel, we know that any T cell activation modality of treatment will have a unique toxicity profile, including the CRS and the ICANS, cytokine release syndrome, and the immune effector cell neurotoxicity that is inherent to any T cell activation modality of treatment, and this is known in CAR T. Although in CAR T, as compared to bispecific molecules, this is probably overemphasized, and the risk of developing later grades is more when we talk about CAR T in comparison to bispecific molecules. In addition to this well-known CRS neurotoxicity, there are other toxicities that are not really very much talked about. One of them is unique probably to cel-to-cel, although probably it has been reported elsewhere, but in which is the long-term neurological events, MNTs, movement and neurological neurocognitive treatment emergent adverse events that happens later on. In the CARTITUDE-1, it happened in about 5% of patients. And probably the risk is dependent on multiple factors. But it's one of the late onset toxicities that you have to be cautious about. Other things, as you can see here, B-cell aplasia, prolonged cytopenias, late infections, transient cardiac toxicity, and secondary malignancies. So done with the CAR T and multiple myeloma. So we'll just talk briefly about each modality of BCMA-directed therapy. So CAR T, cel-to-cel, and ide-cel. ADC, antibody drug conjugate. We have only one molecule so far, belantamab mafodotin. It was approved, but it was withdrawn from the market in 2022. So belantamab mafodotin is an antibody against BCMA that carries a payload, which is the monomethyl orostatin F, which is an antitubulin similar to brentuximab vedotin, which has monomethyl orostatin E, not F. But that goes into the cell and exerts action. And we'll talk about it in more details. So based on the phase 1, phase 2, and phase 3 trials, DREAM1, DREAM2, DREAM3 respectively, belantamab mafodotin was approved in the treatment of relapsed refractory multiple myeloma after at least 2 prior lines of therapy. Phase 3, DREAM3 was comparing belantamab with PD. And it did show a difference in duration of remission and PFS. So after being withdrawn from the market in 2022, 2 newer trials have been reported comparing belantamab mafodotin to what we thought is the best therapy in the relapsed refractory setting. The first example is comparing belantamab mafodotin to daratumumab. In the regimen known as DARA-VD, which was tested in the CASTOR study, comparing DARA-VD to VD. So belantamab mafodotin plus bortezomib and dexamethasone was compared to daratumumab, bortezomib and dexamethasone. And beyond cycle 9, it was maintenance, either belantamab or daratumumab, depending on the line of therapy. So this was tested in patients who have relapsed. They have received at least 1 line of therapy. As you can see here, PFS at 18 months, 69% for BVD, belantamab, versus DARA-VD, 13.4. Although the 13.4 is slightly less than what we have seen in the CASTOR, comparing DARA-VD with VD. But you can see the median PFS, there is a huge difference, almost 3 years in the belantamab VD compared to 14 months in the DARA-VD. even there was a benefit in overall survival in comparison to Dara-BD when we say about belantamab-BD. Safety, there has been some adverse events, but of note, the most important that is related to belantamab mafodotin is the ocular toxicity, as you know. So it's very common. It happened in 79%, but surprisingly, it happened also in 29% in the patients that have been treated with Dara-BD. It's just that all patients had to undergo the tests regularly. DREAM-8 is another trial that has been conducted again recently, comparing this time belantamab plus pomalidomide and dexamethasone to pomalidomide and dexamethasone plus bortezomib. So basically comparing belantamab to bortezomib. We know BBD or bortezomib, pomalidomide, and dexamethasone is a regimen that has been tested in the Optimism trial, comparing it to PD, where it had a median PFS around 1 year. So let's see what happened here. Again, the comparator arm, BBD, which is bortezomib, pomalidomide, and dexamethasone, has given almost 1 year of PFS, 12.5 months. But belantamab PD has given 32.6 months of PFS, which is a long duration in patients who have relapsed as compared to the regular pomalidomide-based regimens. Safety, again, there isn't a major problem in toxicity, but mainly the ocular toxicity. And this table summarizes the ocular toxicity seen in the belantamab arm, as you can see here. Quite common, but mostly blurred vision. Thank you. Blurred vision is the commonest, which is about 90%, although grade 3 was happening in 40% of patients. Dry eyes, feeling of foreign body sensation, eye irritation, photophobia. I mean, patients who are treated with belantamab mafodotin have to undergo regular ophthalmology checkup monthly while on the treatment. And once a toxicity is diagnosed, either having blurred vision, dry eyes, or then adjustments probably need to be made, either in the dosing schedule or in the dose itself, or withholding the drug for some time. There are some ongoing studies also. So we talked about CAR-T, belantamab mafodotin antibody drug conjugate, and we have bispecific molecules targeting BCMA. So as you know, bispecific molecules, they have two epitopes, one for CD3 and the other for an antigen that is present on the cancer cell. And here it's BCMA. There are many being tested, but only 3 have been approved already: teclistamab, elranatamab, and talquetamab. So teclistamab and elranatamab are anti-BCMA bispecific molecules. Talquetamab targets GPRC5D. So teclistamab, which is the first to be approved as a bispecific molecule targeting BCMA, has been approved based on the MajesTEC study. Here, as you can see, overall response rate of 63% in these patients with a median PFS of around 11.5 months. Duration of response depends on the degree of response. The green line is for patients who have achieved CR, and the orange line for patients who have achieved VGPR and above. And the blue line is for all patients. Elranatamab, another bispecific molecule that targets BCMA again, is tested in the magnetism trial, giving again 61% overall response rate. Median PFS is 17 months in elranatamab. Talquetamab, although it's an anti-GPRC5D, has been tested in the Monumental trial in different dosage forms, 0.4 milligram weekly or 0.8 milligram every 2 weeks. But it's nice to look at the last bar over there, because this looked at patients who have been treated previously with T-cell redirecting therapy and response rates of 66.7%. Duration of response was reported, and again, based on the response, how deep it is, it reflects on the duration of response. All those levels have given, this is the redirect. Redirect is both teclistamab and talquetamab in relapsed refractory multiple myeloma, giving really excellent results in these patients. And to our surprise, although this combination are both bispecific molecules that use T cells, T cell activation, the rate of CRS and ICANS was not increased in this trial, although combining two bispecific molecules. But it did give a synergistic effect targeting two antigens within the plasma cell. One thing of note is that this combination has given good results even in patients who have extramedullary disease. Again, similar. Something unique to talquetamab is the skin and nail toxicity that happened in 62% of patients targeting GPRC5D. It's unique to talquetamab. In addition, they may complain of dysgeusia, which is a change in the taste. Ongoing trials, there are many, but these are three different molecules other than the ones that we heard of. AbbVie has a molecule which is an anti-BCMA also, but it's given every 4 weeks instead of weekly initially. Cevostamab targets FcRH5, which is a different target in the plasma cells. It's not yet approved. So there are many being tested. Now, how do we select, or how do we sequence really? So I'll just probably mention the science and then you do the choice. It's very hard for anybody to say you have to do this. But there are recommendations that I will share with you also from the IMWG. So just here, comparing the three modalities which are utilizing BCMA as an antigen of plasma cells: the antibody drug conjugates, CAR T cells, and the bispecific antibodies. Advantages, disadvantages. Of course, we know the disadvantage of CAR T is that you have to wait for now here. At this time here, I mean, we wait for 8 weeks. Maybe it will become 6 weeks or even less, but still you have to wait. But other drugs, bispecific molecules and antibody drug conjugates are off the shelf. Toxicity profile is different. CAR T and bispecifics, they have this problem of CRS and ICANS. ADCs do not. Again, ocular toxicities are unique in terms of the disadvantages for the belantamab mafodotin as the only drug, antibody drug conjugate. CRS and neurotoxicity for others. So what are the mechanisms by which resistance happens in BCMA therapies? So there are three mechanisms. BCMA loss, and that is secondary to the biallelic loss of the gene encoding BCMA through mutations or otherwise. leading to low soluble BCMA, or T-cell exhaustion that happens after T-cell redirected therapy that leads to reduced T-cell function and memory T-cells, and structural changes that may happen leading to a mutation in the gene of the BCMA, resulting in representation of the BCMA on the plasma cells, but that confirmation mutation has led to a conformational change within the molecule, losing the site of attachment of the drug that you're using. So it's there, but you cannot attach to it. Now let's see these three different mechanisms comparing CAR-Ts, bispecific antibodies, and ADCs. Now, biallelic class has been reported mostly in the CAR-T, has been reported in the bispecific molecules, not in the CAR-T, sorry, but it wasn't in the antibody drug conjugate. T-cell exhaustion, of course, happens in modalities that utilize T-cells, which is basically CAR-T and bispecific molecules, and does not happen when you use ADC. Structural changes, there is no evidence reported when in CAR-T, but there is some evidence that has been reported utilizing bispecific molecules that can lead to this structural change mutations within the BCMA gene. So again, more or less similar here. This is from the DREAM-7 and DREAM-8, which are the two recent studies of belantamab mafodotin, looking at soluble BCMA from the beginning throughout treatment and at the time of disease progression. You can see here the pink, purple lines are degrees of response. So patients, when they start here, they lose mostly the BCMA if there is an efficacy, and then BCMA, soluble BCMA, recovers upon disease progression, except in patients who achieve CR, which is the blue line. Patients probably, they achieve CR. At the time of progression, they may have loss of BCMA, but those who have achieved VGPR or less, most of them will recover the BCMA as a target. Similarly here in DREAM-8, it also has shown more or less the same. Role of prior BCMA, this is from the CARTITUDE-2, looking at specific populations that had a prior ADC or prior bispecific antibody response rates when utilizing CAR T-cell therapy, cell-to-cell. So you can see here, although small number patients in the CARTITUDE-2, but still good responses have been achieved even in patients that have been treated previously with ADC and bispecific molecules. ADC more or less similar to the overall. This is bispecific antibodies after prior BCMA-directed therapy from the MajesTEC-1 trial that is testing teclistamab. Again, previously treated patients with ADC, CAR-T, BCMA, still having good responses. So we come to the IMWG guidelines, and this is based on the available evidence, I would say. There are no big studies that have really tested this notion of reusing BCMA-directed therapy after a certain BCMA-directed therapy. General recommendations, no concern of T-cell redirecting admitted after PI meds of monoclonal antibodies, 2 weeks washout period, 4 weeks for T-cell engagers, bispecific molecules, avoid alkylating agents, bendamustine specifically, and consider bridging while waiting for CAR Ts to be ready. This is an important recommendation here. Assuming that we are in the perfect world, we have CAR T, we have bispecific molecules, and we have belantamab mafodotin available to our patients, which ones to choose? So based on this assumption, so both what did I do? وين رحت أنا قدام ولا ورا؟ والله ماني عارف. أيوة كويس. So assuming this assumption of equivalent access, T-cell redirected therapy is recommended prior to ADC. Number 6, again, if we have everything available, the recommendation is to use CAR T-cell therapy first by IMWG. These are the most important recommendations. But there is really an evidence. I'll show you just a few studies. أنا باقي لي 9 دقايق يعني ولا كيف؟ كويس ممتاز. خلاص 4 minutes 3 minutes ولا تزعل شيء. So in this small study, looking at 40 patients, the use of teclistamab in patients who have been treated previously with BCMA-targeted therapy. So overall, response rates 52%. Remember the Majestic trial, the overall response is 64%. But here it went down to 52%. Prior ADC, 55%. Prior CAR T, 53%. Not bad at all. Another study using, testing, these are mostly retrospective studies. There is no randomized studies or that have tested this, but it just gives you a hint. Again, teclistamab in patients who had prior T-cell directed therapy, ADC, CAR T, patients who have used bispecific antibodies to reuse bispecific antibodies, these are the worst patients. Response rates is 12% here as compared to almost 50% if patients have utilized CAR T or ADC. Another study looking at CAR T after ADC. So what happened in those patients? Patients who had prior ADC had almost 61% overall response rate compared to the full cohort. Still, a good number of patients can respond to CAR T. Again, ADC after CAR T, here looking at belantamab mafodotin after patients treated with CAR T, median PFS of 4 months. This is my last slide. So in conclusion, we have different BCMA-targeted therapy, CAR T bispecific molecules and antibody-drug conjugate. Belantamab recently in the DREAM7 and DREAM8 have shown excellent results in comparison to daratumumab and bortezomib in these 2 trials. Now, which one to use based on the IMWG? Of course, they mentioned CAR T first, but we really have some evidence sequencing these ADC before CAR T or ADC before bispecific. Patients had still very good responses. So still not very well known. But there is an evidence, at least in retrospective studies, that certain BCMA targeted therapies have less intense, or at least the T cell exhaustion is not there when you use ADC, and the BCMA representation is probably less severe. Thank you very much.
Excellent. Many thanks, Dr. Ayman, for this excellent review over the BCMA-directed therapy. I'll open the floor now for questions. Dr. Majid. Please, the microphone to Mike.
Okay, so thanks for the very comprehensive review. Now, okay, so you elaborated very clearly the data on using CAR T cell or bispecific after the antibody drug conjugate. What about the other way around? So if someone got bispecific, which is a common scenario, I think all of us we have, and there's either the patient lost the response or was refractory to start with. Are you aware of any data?
Yes, I mean, I couldn't really present the whole, everything that I had. There is, again, retrospective studies looking at this, having response rates of around 50%, still there. Can you still use it? Definitely, especially post-CAR T or even post-BCMA. There are studies showing you results of overall response rate of about 50%.
Is there any?
But these are small retrospective studies, mind you.
Any recommendation about testing for BCMA expression?
That's the best if you can do that. You can test soluble BCMA. You don't probably need exactly to test BCMA representation on plasma cells, but that would be the ultimate if you can do that. The test is not readily available, as you know. If you can do that, that's the best, of course.
Yeah, the problem with doing that, even it will not answer the question, is that a normal BCMA or a mutated or mal-configured BCMA, which will affect the binding of both either bispecific or
the ideal way is testing the gene sequencing that encodes BCMA. That becomes the best test to know that the gene has not been mutated, and also BCMA is very well represented in the plasma cells. But I don't know if these tests will be available soon.
Okay. Any further questions, Dr.
Darwish? Thank you again. In the ideal world, as you said, if we want to choose a bispecific, would you say we will start with teclistamab, and if they have extramedullary, we will add to it talquetamab? Is this an ideal scenario, or you don't think so?
Now, if the choice between either teclistamab or adding teclistamab to talquetamab, if I have a patient with extramedullary disease, I can still try teclistamab alone. Although we have a limited experience, we have quite a good number of patients. We are the first ones to approve teclistamab first. But some patients with extramedullary disease have responded well to teclistamab alone. But definitely based on the trial results, the combination has been more effective in treating these patients. So if you have teclistamab and talquetamab that you can give to everybody, and you have somebody with a bad extramedullary disease, combine them.
Okay. Maybe I have one question regarding the extramedullary disease.
Aywa.
We have recently few patients with CNS myeloma, which is very rare. So any of the BCMA or non-BCMA can help in the CNS myeloma?
Unfortunately, these patients were mostly excluded in all of these trials. Patients with CNS myeloma. I mean, as you know, their prognosis is dismal. The only evidence that we have is that in addition to IT chemo or chemo that can cross the blood-brain barrier, of the agents that we have, probably pomalidomide can work. Although we have a patient that has been treated with teclistamab with CNS disease, and she is in remission for more than 2 years now. I cannot recommend this. It's just one patient.
CNS confirmed?
Yes.
By flow?
Yes. Marid Abdullah.
I think this is like in diffuse large B-cell lymphoma. At the beginning, we said, "Oh, don't give CAR to patient with CNS lymphoma." But meanwhile, we know it's effective. Maybe the scenario is very uncommon in multiple myeloma. That's why it's
It's a bad disease anyhow.
Thanks,
Right.
Raymond.
Thank you very much.
I think we move on to the next talk, the same myeloma disease. We will have
myeloma.
It's a pleasure to introduce my colleague, Dr. Majid Al-Ahmadi. He is a consultant adult hematology and BMT from Prince Noura Center, King Abdulaziz Medical City, Jeddah. He will give us some about the multiple myeloma abstract from the ICML 18. Floor is yours, Dr. Majid.
Okay, طيب بسم الله الرحمن الرحيم. السلام عليكم. Give me a great pleasure to be with you today, and thanks for the nice introduction and for the SSBMT for the invitation. So actually, Dr. Ayman made my life, I think, a bit easier. So, we are going over the same theme. I selected a few abstracts. Most of them were either talking about bispecifics or CAR T-cell. Some of my abstracts that I'm presenting actually from the last EHA, ICML is mostly a lymphoma meeting, very few myeloma talk. So the first abstract is an update about the phase 2 redirect T1 using two bispecifics, talquetamab and teclistamab, for patients with relapsed refractory multiple myeloma, mainly with extramedullary disease. So as we know that patients with relapsed refractory myeloma with extramedullary disease, they have inferior outcomes. And we have to differentiate between the bone-related extramedullary disease, which is, plasmacytoma in the bones extending into a surrounding soft tissue. But the worst is the bone-independent or the true extramedullary plasmacytoma, that happens in the soft tissue, not related to the bones. And usually these patients, they do inferiorly, as we can see for true extramedullary with triple exposed, their PFS is only 2.7 months, with the overall survival is only 7.2 months. So based on what we know from the Majestic 1 and the Momental 1, using teclistamab or talquetamab as a single agent for patients with extramedullary disease, their outcomes were inferior in comparison to the others. So their response rate was around only 40% in comparison to the overall cohort. On the other hand, in the phase 1 redirect T1, it included few patients with extramedullary disease, and actually their outcomes were superior to use of monotherapy, either teclistamab or talquetamab. That actually led to this phase 2, including more patients who are relapsed refractory, triple exposed, and extramedullary disease. They allowed few patients who with prior CAR T-cell or BCMA directed therapy to be included, but they were less than 20% of the patients. So the patient would receive the combination, both talquetamab and teclistamab, starting with the standard step-up dosing. And then the study dose that they used is kind of interesting because the teclistamab was different than what was used in the Majestic one, so 3.0 Q2 weekly, and talquetamab was also 0.8 Q2 weekly. Their main primary endpoint were the overall response rate, and it was how it was assessed in the extramedullary by using a PET-CT. They looked at other secondary endpoint, as you can see. So this is the baseline characteristics of these patients. All of them, they had extramedullary disease, as you can see, and all of them, they were triple exposed. But in terms of the refractoriness, also these patients were quite refractory. So triple class refractory in 85% and pentarefractory in third of the patients. So meaning that these are difficult to treat group of patients. So in terms of the responses were better than what we know with the usage of one bispecific. So overall response rate were almost 80% of these patients. So more than 3/4 of the patients achieved the response. And most of these responses were actually deep, so VGPR or better. Also, the time to response was short. So within before 3 months, patient would achieve a response, and by 5 months, you achieve the best response that you can get. That was noted even in the patient with prior CAR T cell, as you can see here, and also prior non-BCMA, non-GPRC5D bispecific or antibody drug conjugate. And that actually summarizes what I showed you. So this is what was shown in this trial in terms of the combination. And that's what we get with the monotherapy, either with teclistamab or talquetamab when you are dealing with patients with extramedullary disease. So if you look at this swimmer plot here, so all the patients who achieved the response, they maintained that response after 12 months. So there was no rate of relapses. And if we want to take the median PFS, so at 1 year, 61% of the patients, they were free of progression. And that was reflected by a survival advantage. So by 1 year, 3/4 of these patients, they were alive, and the duration of and the DOR was 64%. And that's different from the figures I told you before about these patients. You know, their survival is like 6 months and the PFS of only 3 months. So one of the important things when you look at a study like that, you want to make sure that this combination did not result into a more serious adverse effects. So luckily, actually, one of the good things about this trial, that was not the case here. So combining teclistamab to talquetamab did not result in the increase in the rate of the adverse effects, including the CRS. So CRS reported here was mainly grade 1 or grade 2. Very few grade 3 as far, or no, actually, no grade 3 or 4. And most of the CRS happened in the step-up dosing phase or in cycle 1. Beyond cycle 1, rarely you see any CRS. The same thing with ICANS. So ICANS also reported in about 12% of the patients, mainly grade 1 or grade 2, and happens during the step-up dosing or cycle 1. Other toxicities, so as we'd expect, cytopenias is known to happen with such a regimen. And you can see here that grade 4 neutropenia happen in more than half of these patients. Also, you know, one of the things that was taken in consideration in this trial with addition of teclistamab to talquetamab will result in reducing the talquetamab off-target effect, like the hair or skin side effects. So you can see here with this combination, GPRC5D related adverse effect like weight reduction, nail changes, or skin rashes were mainly grade 1 or grade 2, which is also another encouraging things. Infections, always to put that in consideration with the use of bispecific. That's a very common thing to happen. So, and you could maintain that with giving IVIG to keep the immunoglobulin more than 400 milligram per deciliter. So as a conclusion, the result of this trial actually was quite encouraging, especially for difficult to treat group of patients, extramedullary, triple class refractory, resulted in a significant improvement in overall response rate, PFS, and overall survival. So I presented to you the use of two bispecific together. So how about we use one, but it does what both can do. So tri-specific T-cell engager. So this is a new product from J&J. So J&J 532, a first in human study for a novel next generation tri-specific antibodies in patients with relapsed refractory multiple myeloma. So the idea behind this molecule that with targeting two antigen, both BCMA and GPRC5D, you decrease the chances of antigen escape, which, as Dr. Ayman has explained, that one of the main causes of drug resistance. So by targeting the two antigen at one time. Also, by doing this combination, now we're gonna do a one-step up dose, where in the first trial I showed you, now you are doing two drugs, two-step up dosing that might increase the chances of side effects. So here we might improve the safety with this new tri-specific. Also, one of the concepts, the same thing to potentially decrease GPRC5D related toxicity. So this is the phase 1 or the escalation phase, which led to the RP2D, which will be used in the phase 2. The dose starting from 5 milligram as step-up dosing to a full dose of 100 milligram Q4 weekly. So put in your consideration, it's subcutaneous, so it's not an IV medication, and it's given over 4 weeks. Not weekly, not every 2 weeks. So it's more convenient for the patients, especially our patients who comes from far away. So this is the study population that they include. All of them were triple class exposed. And in terms of the refractoriness, triple class refractory in more than half of the patient. Penta refractory was less than 10% of these patients. So with regard, so now this is a phase 1. So one of the important things that we have to put in consideration is the safety. So the encouraging thing, this new tri-specific did not result into a significant toxicity higher than what we expect for that class of medications. So grade 3 or 4 hematological toxicities were recognized in about 30 to 40% of the patients. Infections, complications were recognized as a grade 3 or 4 in 33% of the patients. So there were a few number of deaths happen related to infections, which is well known with this class of medications. So talking about the CRS, so the same finding we have recognized with the former bispecific. CRS happens usually as grade 1 or 2, and usually happens during the step-up dosing or in the first cycle. So In this trial, they used a novel approach. So they used a prophylactic tocilizumab, which definitely, as you can see here, resulted in significant reduction of the risk of CRS among these patients. No ICANS were recognized in this with this cohort. So in terms of infectious toxicity, so as we expect with the use of bispecific, risk of pneumonias, COVID-19, influenza, all of this is something important to keep in consideration, and you have to monitor your patients with measuring immunoglobulin and replace it monthly to maintain an IgG of more than 400. So the overall response rate in this trial was quite impressive. So in the RP2D arm, 100% of the patient achieved the response. Most of them were VGPR or better. And the median time to response was only 1 month, and median time to the best response were 6 months. So good responses, fast and deep responses as well. And the same thing with the swimmer plot here. So almost all patients remain in response in 12 months. And so in terms of the PFS, so at 12 months, the PFS was 95%. And remember, we're talking about a refractory group of patients. So this is actually a very interesting product, and I think it might have an impact for the treating of myeloma patients in the future. Trispecific T-cell engager. It resulted in 100% overall response rate, very deep responses, more than 97% achieved VGPR or better, and acceptable safety profile with a PFS of 95% in 12 months. So I think more follow-up and a phase 2 trial from this product would be very interesting. The third abstract I'm going to present is the long-term safety analysis from the CARTITUDE-1 trial. So the CARTITUDE-1 trial actually, was actually looking at patients with relapsed refractory myeloma who had exposed to 3 or more prior lines of therapy. So this is different from the CARTITUDE-4, where patients who received only 1 line. So here, patients were more heavily treated. So the patient would go with the usual mechanism, apheresis, bridging therapy if needed, lymphodepletion, and then cell-to-cell infusion. They used a lower dose in comparison to what used in the CARTITUDE-4. And this analysis represents the data after 5 years follow-up. And that's very important. Why? Because we want to know the safety data, what happens with the exposure to cell-to-cell after 5 years, especially with the concern that, was brought before, the increased risk of T-cell malignancies, T-cell lymphomas. So that's important to follow. So in terms of the patient disposition, so 97 patients were included in this trial, and all of them, they received infused with cell-to-cell. 46 of them, they progressed. 30 of these, they died. And 2, they withdrew the consent. 13, they were still under the follow-up and included in this 5 years analysis. 32 out of the 97, they were still free of progression after 5 years follow-up. So now, what's included in the 5 years follow-up now is 45 patients, 32 among the progression-free, and 13 who progressed and went most likely on other lines of therapy. So in terms of the progression-free survival after 5 years, so as explained before, 32 out of 97, so 33% of the patients included were free of progression at 5 years interval. Interestingly, 12 out of these 32 patients, they were MRD negative in one center who were tested for MRD. So I'm assuming that if the other did the same, we might get the same finding. So because these are the only patients who were tested for MRD and all of them were negative, meaning that cell-to-cell, if the patient achieved a durable response, you get this very maintained MRD. And everyone treating myeloma would be, dreaming about a cure. So these patients, we never know. Maybe they are cured 5 years and they are maintaining MRD. So in terms of overall survival also was impressive for these patients who were responders. So the overall survival of 60.7 months, so 5 years of overall survival. So in terms of, so that's very important to recognize. So now, looking at this data, I want to know what are the factors associated with a long-term response. And, when they compare between the responders and the non-responders, it's interesting to see that there was no difference in the higher cytogenetics. So they were the same. So meaning that if you have a patient with higher cytogenetics, it might not be as bad as we expect in terms of response to CAR T cell. And the same thing with extramedullary disease. So the responders and non-responders were about the same. So it wasn't the difference. So the difference was mainly related to the amount of the plasma cells in the bone marrow at the time of the infusion. And that how I interpret this is the need or the importance of the bridging therapy. So patients who went for infusion, while their plasma cells 5% or less, they did much better than the patient who had too many plasma cells, 24%, as you can see in the response. Same thing was applicable for the soluble BCMA. So the higher soluble BCMA at time of infusion led to inferior outcomes, meaning that if we control the disease better at the time of the infusion, it might result into a deeper and longer responses. Also, one of the interesting findings that might lead to this difference in the responders is the fitness of the T cells. So and how they looked into that. There are multiple measures. So the E over T ratio, and also the T cell over the neutrophil ratio, meaning that if we are using a fitter T cells with a better expansion, it can lead to a better long-term efficacy for the use of cell-to-cell. That actually was reflected in the CARTITUDE-4, where the cell-to-cell was used after first one line of therapy and resulted in better outcomes. So meaning that using cell-to-cell earlier with the use of a fitter T cells with a better expansion can result into a better outcome like this. And I think what we will be looking for is a longer follow-up for the CARTITUDE-4 to see if these patients also they had maintained that response, they have maintained MRD negativity or not. And that would be a very interesting finding to see in the future. So one of the important things for these long-term follow-up to look for any safety concerns. As I explained to you, there was a major concern with the CAR T cells that it might increase risk of T cell malignancies. So after this more than 5 years follow-up, there was no significant safety concerns. So in terms of the secondary primary malignancy, there were only 2 recognized for the long-term follow-up patients. One of them was a squamous cell carcinoma of the anus, and the other one was adenocarcinoma of the lung. So no T cell malignancies were recognized. Also, one of the major concerns about the cell-to-cell is the neurological toxicity, especially the Parkinson-like disorder. So after this long follow-up, there was no additional Parkinson or cranial nerve palsy that was recognized. So this data is actually quite interesting. It shows more than 5 years follow-up after cell-to-cell infusion, after 3 or more lines of therapy, which showed a great efficacy with a 5 years PFS of 33% and overall survival of almost 5 years. The last abstract that I'm going to present to you was presented at the most recent Lugano by Dr. Dakel. So this is an update interim result of a new novel BCL2 inhibitor called sonrotoclax plus dexamethasone in patients with translocation 11-14 positive relapsed refractory multiple myeloma. The interesting thing, it's an all oral therapy. So there is no injections here. It's an all oral therapy given for translocation 11-14 patients relapsed refractory myeloma. So 11-14 translocation happens in around 20% of the patients with myeloma at the time of diagnosis. Although there is actually approved BCL2 inhibitor, which is venetoclax, until now, there is no approved anti-BCL2 therapy for myeloma patients. The unique thing about the sonrotoclax, it's a next generation BCL2 inhibitor that's more selective and more pharmacologically potent with a potential better safety because there is no drug accumulation in the patients who have used it. So this trial actually looking at the safety of the combination of the sonrotoclax plus dexamethasone in patients who has translocation 11-14 myeloma patients. So this is the dose escalation phase, the phase 1B, which led to identifying 2 doses, the 320 milligram and the 640 milligram, which was used in the expansion phase and the safety analysis. So this is the patient disposition. So 55 patients were included. 19 of them, they received 320 milligram of sonrotoclax plus 40 milligram weekly of dexamethasone. The median follow-up of that group were 7.6 months. On the other hand, the dose of 640 plus dexa were used in 336 patients with a median follow-up of 14 months. So by the time of the final analysis, 11 out of the 19 on the 320, they were still on the study drug in response. And 10 out of the 36 patients on the 640 were still on the study drug in a response. The most important reason for discontinuation was progressive disease in both arms. So this is the baseline characteristic of the patients. So high-risk cytogenetics were identified in about 20% of these patients. ISS stage 3 were about 15%. Prior exposure to EMET, PI, and anti-CD38 were in 3/4 of these patients. Refractoriness were triple refractory were in 40% of these patients. So now looking at the safety, so one of the interesting things about this trial that the rate of the study drug discontinuation because of adverse effect, which was very low as we can see here, meaning that this combination was well tolerated among the patients who have used it. Most of the adverse effects were grade 1 or 2. And if we want to look at the arm, the 320 milligram dosing, most of the side effects were either insomnia versus, or fatigue. And when we are thinking about the 640 milligram, most of the adverse effects were fatigue or diarrhea. And as you can see here, most of the adverse effects were either grade 1 or 2. What about hematological toxicity? Were also mainly grade 1 or 2. Only 20, sorry, what happened? Only 20% of the patient had a grade 3 or more hematological toxicity. Infection also was not common. It was mainly grade 1 or 2. Grade 3 or more was only in 14.5% of the patients. In terms of the responses, so overall response were 78% among all the patients. And if we were taking the 640 milligram doses, the overall response rate was in more than 3/4, 80% of the patients. More than half of them, they were VGPR or better. Median time to reach a response for each cohort was less than a month, and median duration was not reached for the 320 milligram and 12.1 for the 640 cohort. The median BFS for the 640 cohort was 12.9 months, where for the 320 was 6.6 months. So in conclusion, so this is actually the first analysis for all oral novel BCL2 inhibitor for relapsed refractory myeloma. Most of them were triple exposed and triple refractory, targeting patients with translocation level 14. The safety analysis was actually confirmed that this is a safe combination, well tolerated, and with very encouraging responses. Now, taking this a step ahead, multiple trials looking at the use of sonrotoclax with other combination, and I think in the next few years we would see it with either other PIs or monoclonal antibodies. So I think that the data from this would be also quite interesting. So that's what I have for you, and thanks for listening.
Many thanks, Dr. Majid. Very interesting, nice abstracts. So I'll open the floor for questions.
People are tired. It's 5 p.m. on Friday.
A question, Dr. Majid. So you mentioned that the 11-14 frequency in newly diagnosed multiple myeloma is roughly 15 to 20%.
Yeah.
So the patient who were included in this BGB trial, they were relapsed refractory patient. What's the percentage? I guess it's higher in relapsed refractory patient.
It's going to be higher, but not too much, because usually for relapsed refractory, the bad clones are 17p. So the 17p that's well reported in relapsed refractory is much higher. So if we are talking 17p and the type of diagnosis average 10%, in some analysis 17p can reach up to 50%. So 17p relapsed refractory is way more. I'm not aware about increase the rate of 11-14 in relapse setting.
Rehab.
Thank you for your talk. So from the CARTITUDE-1, it seems that the 5-year complete remission, if you are going to counsel a patient, is about 30%.
Yeah.
So
after 3 lines, after 3 or more lines.
After 3 or more lines. So what do you expect that to be with CARTITUDE-4? That's the first question.
Yeah. Thank you. And that's what I mentioned, because it would the long-term follow-up of the CARTITUDE-4 would be very interesting. It was very encouraging to see from this data that all the patients were in response at 5 years. They were also MRD negative. And that's very encouraging. It might be, we never say that, but might be a cure for that group of patients that might not require any lines of therapy after that. So, could be.
So my second question is about the toxicity from CAR T cells. So the Parkinson's, what did they quote as a percentage of patients? It seems that after 5 years there isn't any new cases, but what do they quote as a percentage of patients will get Parkinson's-like symptoms?
I think it was less than 5%. I think, as far as I remember, it was 3 patients in total or something like that. So it wasn't, all the cases happened within 6 months of the infusion. So if it happens, usually it happens early, not later. Yeah. And the good thing, there was no safety concern with the long-term follow-up.
Many thanks, Dr. Majid. I think we must move to the next talk.
Thank you, Dr. Ayman. Thank you, Dr. Majid. So the next 2 talks will be dealing with lymphoma. So I am glad to introduce the next speaker, Dr. Ihab. Dr. Ihab Al-Hamidi is a senior consultant for hematology and BMT. He gained his fellowship and training in UK, and he is a hematologist since 2003. He has many publications, more than 30 publications, including contribution in 2 books. And Dr. Ihab will give us some insights about CNS lymphoma abstracts presented during the ICML. تفضل دكتور إيهاب.
Thank you, Dr. Riyad, for this introduction. So the scientific committee has chosen two abstracts for me to present in CNS lymphoma. And both abstracts are actually on relapse refractory setting. So the first one is the PRISM Plus trial. This is a first result for cohort 1 of zanubrutinib monotherapy presented by CP Fox from the UK. So the clinical problem that we face with CNS lymphoma is that 50% of patients are going to relapse after initial therapy. And this group of patients is very challenging. They have impaired performance, they have impaired neurocognitive dysfunction, and they're usually chemo-resistant patients. So what do we do with such patients? It's very difficult to recruit such patients into clinical trials, and they try to do that in this trial. So this is what happens in the relapse setting. So this is the French group network, and you can see the progression-free survival of this group of patients is only 2.2 months, with an overall survival of 3.5 months in the relapse setting. So looking at gene expression profiling for diffuse large B-cell lymphoma versus CNS lymphoma, and you can see here that the picture in CNS lymphoma is different from here, which is the diffuse large B-cell lymphoma. The gene expression profile signature in primary CNS lymphoma is different from systemic diffuse large B-cell lymphoma. Which makes it a more interesting disease, and the majority of patients have got a BCR NF-kappa B mutation. The commonest one, 50 to 80%, will have the MYD88 mutation. So there has been trials in this setting, and you can see here trials using ibrutinib at higher dose and tirabrutinib. And you can see here that the 15% of patients, 15 to 16% of patients had actually autologous transplant in these trials. And you can see here the median progression-free survival ranges between about 3 to 4 months, so quite dismal prognosis in this group of patients. So the PRISM Plus trial was a trial for patients with a performance status of 0 to 3. So they allowed patients with even performance status of 3 to be included. They've had at least one prior line of therapy, which included high-dose methotrexate. And patients without capacity to consent were allowed to be enrolled in this trial. So it was a sequential single-arm trial. Each cohort had to recruit 20 patients. Obviously, it's very difficult to recruit patients in such a trial. The treatment was zanubrutinib, 160 milligrams BID. The primary endpoint was overall response rate. CR, CRU, and PR after 2 cycles were assessed at 8 weeks from the start of therapy. There were secondary endpoints, which included progression-free survival and overall survival and obviously safety. So this is the recruitment chart, and you can see that they recruited their 20 target patients from September 22 to December 23. So it took them a bit more than a year to recruit this number of patients. These are the baseline characteristics. The median age was about 64. The ECOG status of these patients, 40% of patients had an ECOG 2 and 3. Some had legal representative to sign consent for on their behalf, and about half the patients had autologous transplant using Cyotepa as a conditioning regimen. So the protocol required that the patients actually discontinue corticosteroids on day 15. So corticosteroids were not allowed in this trial, but maximum 15 days in cycle 1, which is different from the trial that I will discuss next, which allowed corticosteroids. Obviously, this means that whatever response we are going to get in this trial is mainly due to the medication rather than the effect of the steroids. So what's the outcome? The overall response rate was about 50%. This is by local assessment. There is a central review board which assessed the outcome to be about 55%. And this was a neuroradiology review. There were about 2 patients who were stable disease and did not experience progressive disease at 8 weeks. So this is the CR rate was about 15% by local assessment. It was about 35% when it was reviewed by the central neuroradiology review, which reflects the importance of having expertise reviewing the X-rays. And you can see that the CR rate, when it was assessed by neuroradiology, it was increased to 35% because then you have experienced people who can assess whether the patient is in CR or not. This is the progression-free survival, which is about 6.9 months, which is an improvement on the previous trials where the progression-free survival, as I have shown you, is about 4 months. So here we have about 7 months. And you can see that there is a plateau after 1 year, which might be something encouraging for the future. The overall survival is about 13 months. And the toxicity wasn't much more than you would expect. Mainly infections. 50% of patients had an infection of some form, lung infections, pneumonias, COVID, sepsis, and other infections. So this is the main side effect that was experienced from this therapy. No patient discontinued treatment due to side effects. 20% of patients had a side effect of 3 to 4. And there were 10 deaths. These were mainly due to progression of disease. They looked at the CSF plasma level of the medication, and you can see here that the peak, there was 2 peaks. One was in cycle 1, day 7, and the other one was in cycle 3, day 1. 2 peaks of the medication in the CSF. And this is very important because if you have a higher peak, then you will have higher efficacy. And it also meant that the medication is actually penetrates the blood-brain barrier. These are different patients, and you can see that there are some patients who actually their peak continued, like patient number 1 and 2, but there are patients in whom the peak has dropped, like patient number 14 and 16. In their article, they didn't mention what happened to these patients who have had a drop in the peak of their medication in the CSF. I was interested to find out actually whether there was better response in patients who had a higher peak than others, and to compare those who had higher peaks with those who had lower peaks. But I couldn't find any data. Maybe when they publish this in an article, they will mention what happens to the patients with different peaks in the CSF. This is an example of a patient who had an MRI at 8 weeks, and you can see the disease there. And then there is an advanced MRI analysis, including dynamic diffusion metrics ongoing. And you can see at 8 weeks, the disease is minimal, and they quoted this as a patient who had 96% enhancing volume reduction in their disease. So this is a very interesting molecular study that they did with this study, is that they did mutation analysis from the tissue biopsy of the material, and this is the green dots at the here. These green dots are actually a diagnosis, the tissue biopsy looking at the mutations. The red dots are actually peripheral blood looking at the same mutations, and this is the blue dots are the CSF. So they were looking at whether circulating DNA actually could predict the outcomes of these patients. They didn't publish this in this abstract, but they said they will publish this in the future. But it would be interesting to see whether circulating DNA can predict CRs in such patients. You can see here the mutations they found, and they found similar mutation to what is published in the literature in this group of patients. The 53% of patients had the MYD88, which is the commonest mutation found in CNS lymphoma. So the future is for cohort 2, which has not been published yet. Here they're using triple therapy for relapsed refractory CNS lymphoma using zanubrutinib for 28 days, and then tafasitamab treatment in addition to zanubrutinib, and lenalidomide treatment as well. So a combination therapy for this difficult group of patients, and we await to see whether this study will show any more benefit to this difficult group of patients. This is the acknowledgement of the patient, of the institutes that were involved in this trial, mainly in the UK, Birmingham and Nottingham. My second abstract is in the same disease, tirabrutinib, for relapsed refractory primary central nervous system lymphoma. It's about the efficacy and safety of this phase 2 prospect study. And simple design, similar to the previous study, is tirabrutinib at 480 milligrams once a day, continuous therapy. The endpoints were actually overall response rates assessed by an independent research committee. So the patients who were enrolled were about 66 patients, 35 patients of whom discontinued the treatment. The majority, 26 patients, actually discontinued therapy due to progressive disease. And here, the demographics of the patients actually, patient age group is similar, 65 years of age. Here, the ECOG status more than 2 was 19% of patients, so less less ECOG 2 and 3 in this trial compared to the previous trial, where 40% of the patients actually were ECOG 2 and 3. So this is a more fit group of patients compared to the previous trial. The overall response rating by the independent committee primary endpoint, they found that the CR is actually 67%. The overall response rate is 67%. CR rates is 44%. This is the duration of response by the IRC, and you can see here that the duration of response was 9.3 months, so decent duration of response. And this is the progression-free survival, 6 months, similar to what we found in the previous trial, 6.9 months. And this is the overall survival, was again about not reached at this follow-up. This study allowed the patients to have corticosteroids, unlike the previous trial where the corticosteroids were stopped at day 15 of cycle 1. So you can say that maybe some of the effects of therapy here was due to the presence of steroids. A number of patients with corticosteroids dose as baseline were 33% of patients. Number of patients with sustained reduction of steroids was 81%. So they're still on steroids, but they had dose reduction. A number of patients with complete discontinuation of steroids was about 70% of the patients. This swimmer plot shows that the patients who actually had a response, and you can see that at 12 months, a significant number of patients continued to have a response. So what about the side effects? And you can see here that the side effect profile, those patients who had one line related side effect was about 75%. Grade 3 was 1/3 of the patients. The majority of side effects did not lead to dose continuation. Only about 30% of patients had needed dose discontinuation or interruption due to side effects. Patients who actually died from the treatment was 4% of the patients, so due to side effects. There is very interesting side effect profile in this group of patients. Fall had a grade 3 side effect was mentioned, and also there was confusion, as you can see here, confusional state. So I'm not sure whether this is related to the medication or whether it's related to the disease itself. But there was some toxicity related to confusion and falls. Other side effects, intracranial hemorrhage, 1 patient, subdural hematoma, 1 patient, cardiac disorders, sinus bradycardia, 0% of patients had a grade 3 toxicity. Hemorrhages, some 4% had some hemorrhages. So in summary, they concluded that according to this study, which is phase 2, it's a Japanese medication, which this is the first time it is tried in the US. But according to this study, phase 2 study, there is a high overall response rate, a high rate of duration of response, and high rate of progression-free survival. And expanding on experience from Japan, where it was first tried this medication, there is interesting findings that might make this medication effective for relapse refractory primary CNS lymphoma. And with that, I conclude my talk, and thank you for listening.
Jazakallah khair, Dr. Now we have 18 minutes for discussion. نروح بدري عارف. So any question? طيب تفضل.
Just in the first studies, the CR rate was much lower with the local analysis rather than central. Is there any explanation? Was there any technical problem sending the images, or because usually we see the reverse?
Yes. So The only finding I found in this study is that they believe that actually there were still findings in the brain that was interpreted by the local group as disease, while it was felt that it wasn't disease related, it was maybe death of the tissues by the central committee.
Any other question? Dr. Ahmed Askar, المدير العام.
Yeah, thank you, Dr. Ihab, for a nice presentation. Just a quick question. So would you now consider BTKIs in combination when you treat CNS lymphoma?
So yeah, I mean, if someone had the full treatment, like the matrix protocol followed by autologous transplant, and they relapse after that, there is very little treatment left to do. A BTK treatment is an option. Radiation is another option. So a combination of the two might be, for me, a reasonable option in this setting.
Because I see all the results for these two agents, zanubrutinib and the other one as a single agent or with DEXA. Yes, there is a good response at the beginning, but then it vanishes later on.
Yes.
So maybe, I'm sure, I mean, studies will come, but the side effects and the adverse events will be considered an issue, but that's something to be considered again.
Excellent. Yeah, excellent comment. So, and I have another comment with regards patients with CNS lymphoma or relapse. Usually, their performance state is very poor. So, do you know? I don't know whether it was, and it's not your own work, but I don't know whether you can answer this question. Do you know the quality of the performance status of the patient who were included in that trial and how they were? Is there anything mentioned?
So there is an abstract form. There isn't a publication yet for these two studies. So there wasn't anything mentioned about the quality of life for these patients, unfortunately.
Because usually patients who reach the state where I will consider them for ibrutinib or an oral drug, these patients they usually don't have anything else. They are not qualified for high-dose RSE as example, which we use usually in the lab setting. So I have another question, and I'm sorry, I don't know whether you can answer this question. It was interesting and emphasize on it. In the Prisma Plus, there was a plateau at the end of the curve. So do you know what's the longest remission that was gained with this zanubrutinib in that trial? How long they lived with the zanubrutinib, these patients?
So these patients at the end of the curve.
Yeah.
So it is not very clear whether, because they are progression free. So one expect that they're still, as you've seen, there isn't a swimmer plot for the zanubrutinib study, unfortunately. One could have seen how many patients who actually were still on the medication, say 1 year, 2 years after the beginning. So the swimmer curve was only with the tirabrutinib. So it's very difficult to say whether these patients were actually still on zanubrutinib at that time or not.
The BFS.
The PFS, yes. I mean, there is, as you can see.
The longest time they benefit. Is there anything from to how much?
So is your question about whether they're still on treatment or not?
How long the patients with the longest response duration, how long it was, Because what we see, I mean, I don't have experience with zanubrutinib in the CNS. I treated patients with ibrutinib. Usually the response is not long lasting, as you mentioned, PFS, 4 months, 3 months, something in this direction. So, and it was impressive, this PFS with the plateau at the end. There were some patients who...
Yes. Yeah, that's what it suggests, that there are some patients who actually... I think that's, to me, might mean that, or this might be the patients who have higher concentration of zanubrutinib in the CSF. because the concentration of it in the CSF was different between different patients. And there are some patients who actually had an initial higher concentration and then the concentration went down. So I was very interested to find out these patients who had a higher concentration of zanubrutinib in the CSF than others, how did they do? And I tried to search for that and I couldn't find an answer to that. But I suspect these patients who had a prolonged remission are probably going to be the patients who had a higher concentration that stayed in the CSF for longer duration.
Anything mentioned? I mean, since you looked after this, any mention that there is any factors that contribute to higher concentration in CSF in some patients than others?
I'm not sure.
Treatment.
No, there isn't anything mentioned in that.
Another question. Looking in the audience, any other question? So you mentioned in the PROSPECT trial, 4 patients died.
Yes.
Treatment related.
Yes.
What's the cause? What was the cause?
They didn't say the cause of these 4 patients, but you can see that there is a lot of confusional states and falls in this study. Grade 3 confusional state, grade 3 falls. So is it due to the CSF? They didn't mention anything about the CSF concentration of this medication, but is it related to their disease? Is it related to the concentration of the medication in the CSF? It's not clear to me what is this treatment-related mortality was due to. Is it infections? There are some patients who had cerebral hemorrhage.
Yeah. Okay. Yeah, for that.
With regard, Dr. Rehab, to the concentration, have they checked the difference between the BD and once daily dosage for the zanubrutinib?
The trial was on BD only.
BD.
So they only gave BD.
Because in the ibrutinib we used for the CNS, we use higher doses. Is it
Yes.
possible, or have they, because you might expect to have a higher concentration if you go higher with the dose in the zanubrutinib?
With the Zano.
It's not been.
Yeah, I think they used the BID because they are targeting the CNS. So they wanted a uniform concentration in the CSF throughout the day. You can use zanubrutinib once a day, but I suspect that they didn't go for that because of the CNS involvement, yeah, rather than CLL.
معلش انا بسألك أسئلة صعبة بس بنتسلى معك. So since you mentioned the CNS concentration of the drug is important, so I was asking myself, يعني there are some BTK بدناش نسمي الأسامي that are being given twice a day, and the others they're being given once a day. Is there any difference in terms of CNS concentration and response?
So the pharmacokinetics of the different BTKs is different. So acalabrutinib, for example, is given twice a day. I'm not aware of any study of acala with CNS disease to be able to comment whether it has a different pharmacokinetics in the CSF than the others. I suspect it will cross the blood-brain barrier like the others, but I suspect to answer your question, you will have to have different studies looking at CSF concentration of the different BTK inhibitors.
طيب جزاك الله خير عزبناك.
Thank you
very much. Excellent. Next speaker موجود. طيب so we will continue with the next speaker. Dr. Muhammad Ad-Darwish. He is a consultant adult hematology, lymphoma, myeloma, and stem cell transplantation at King Fahd Specialist Hospital in Dammam. And Dr. Muhammad will share with us his local experience in King Fahd Dammam. تفضل دكتور محمد.
جزاك الله خير. Assalamu alaikum everybody. It's already an afternoon. We need to maybe exercise a bit to wake up, but I will try my best to include the exercise during my talk. So nodular lymphocyte predominant Hodgkin lymphoma is considered a very rare disease. It is reported that it accounts for around 5% of the total patients with Hodgkin lymphomas. Maybe part of it is because of the difficulty of reaching a diagnosis, including their variant of presentation of not having Reed Sternberg cells a lot and having these popcorn cells instead, and they even the immunohistochemistry is different, that have CD20 positive, CD30 and 15 negative. Anyway, we thought that we do have more patients than have been reported in the literature, so we thought, why don't we study them and see if we have come up with any new thoughts about the idea of why is it rare, or is it really rare, or how we apply it into real life scenario. So we have studied the number of patients over the last 18 years. All the adults above the age of 16 years of age, and we have studied their characteristics, progression-free survival, overall survival, and determine whether there is an impact of the management onto their outcomes. Especially that in our center, it has been shifted, as many of the other centers, from medical oncology to hematology, which changed a bit the practice. So this gave us even the opportunity to check the difference of the different acts onto the patients, like what different modalities of treatment, whether it will affect the outcome or not. So we came up with the number of patients into this period of time happened to be 146 patients, which accounts for around 11% of the Hodgkin lymphomas that we have in our center, which is double what is reported in the literature. Their median age is around 30, which is younger than what is known about the disease, and they are mainly males, as being reported before. The average median, the median follow-up time was around, let's say, 5 years, and we have to take into consideration what our thoughts of choosing the treatment was mainly. We almost followed the GILF criteria into the nodular lymphocyte predominant. So we did go into active surveillance into those who doesn't have symptoms, who doesn't have extra nodal disease, and those who doesn't have B symptoms. We included those who did have splenic involvement, thinking that they are a bit more aggressive. So we, most of the time, when they have splenic involvement, we start them immediately on treatment, even if they were asymptomatic. Other characteristic that we looked into, but we didn't decide upon to choose the treatment, like the LDH was elevated in 22% of the patient, but this was almost equal distributed among the groups and didn't lead to decision making into the treatment regimens. Now, most of the patients were having low IBI score anyway, and giving us a clue that this disease is most of the time not aggressive and not causing effect of systemic effect, I would say. Again, other characteristics that we had looked into, the extra nodal involvement happened to be around 10% of the patient, splenic involvement in 8% of the patient. We had chosen, because there is no much of bulky disease into nodular lymphocytes, so we have chosen half of what is usually being said as bulky to differentiate the patients into bulky or not, having the cutoff as 5 centimeters. And this happened to be in around 12% of the patients. Bone marrow involvement in 4% of the patients. Now, the management strategies that we had came up with, or that the patient had received during this time, was radiotherapy plus minus rituximab in 11% of the patients, chemotherapy plus or minus rituximab in 39% of the patient, a combination in 15%, and rituximab monotherapy in 12%, and active surveillance in 23%, which is happened to be 34 patients. Now, if we dichotomize the patient who underwent active surveillance, as I said, there were 35 patients. Only 6 of them had required treatment later on. And this in an average time between 12 and 44 months. Most of which had localized progression. So for us, we had chosen to go for radiations for such a scenario. And this happened to be in 3 patients. Archer was given for 2 patients, and rituximab single agent was given to 1 patient. 28 patients remained to be on active surveillance till the time of the surveillance. And the average time, the median time of these surveillance were 44 months by then, which is around 4 months. So if we just compare those who went into surveillance and compared to those who went to treatment, regardless of what treatment they received, you can see here that overall they have no much of a difference. And if there is a difference, even favoring the active surveillance. Putting in mind that the active surveillance are, let's say, having a bias of choice because they have lesser disease burden and no B symptoms. So maybe the comparison is not truly that fair. But anyway, it tells us that those at least who went into active surveillance had been plateaued and may not need a treatment for at least a long period of time. And the 2 years and 5 years follow-up and even 10 years of follow-up had proved to make them similar. Now, again, if we dichotomize the patient who received the treatment, we can see here the different modalities of treatment in comparison to the surveillance. Is this a pointer? No. So it's not a pointer. Anyway, so as you see here, the active surveillance was at least non-inferior to the chemotherapy, non-inferior to radiation therapy, and was superior to rituximab alone. And the only exception was the combined modality of chemo and radiotherapy, showing better response. But in a long-term follow-up, this has been like narrowed and reaching almost not having a significant difference in the outcome anyway. And we will come to that in a while. Other pairwise analysis into those who have localized disease, the radiotherapy had shown a significant improvement of their overall, and their progression-free survival compared to chemotherapy. So, if you compare R-CHOP to ABVD, there wasn't really significant difference of their outcome. Actually, all of them had responded almost. So it didn't show a difference whether to choose R-CHOP or ABVD. Now, if you go to BFS2, which means from time of diagnosis till the 3rd line of treatment, or from progression after 2nd line or death, you can see here that those who remained nodular lymphocyte predominant Hodgkin lymphoma almost plateaued. I cannot say that they are cured, but at least it shows that this is a very indolent disease leading to a very long plateau of the disease. And actually, when they even if we have a patient who is classical Hodgkin lymphoma relapsing so late, we will think to biopsy them, thinking that this is actually misdiagnosis of nodular lymphocyte predominant Hodgkin lymphoma until proven otherwise. Now, the exception is those who transformed. We had 13 patients who transformed, which accounts for 9% of the total number of patients. So the median time till transformation is 25 months, ranging from 5 to 120, which is a wide range. But once they have transformed, they will behave differently, of course. Now, most of the transformation was to T-cell rich B-cell lymphoma. 12 of these 13 were into this category. Only 1 patient had transformed from nodular lymphocyte to go to diffuse large B-cell lymphoma. Now, 10 patients of the whole patient, the total number of nodular lymphocyte predominant had gone into auto stem cell transplant. And 6 of these transplant was because of this transformation. Two of them were because of changing into an aggressive subtype of the nodular lymphocyte predominant Hodgkin lymphoma, which is the type E. And the two others, we believe that there is an underlying cause which made them a bit more aggressive, but we couldn't reach a conclusion why did that happen. Anyway, all of those who underwent autostem cell transplant were alive at the time of analysis, and this duration was between 5 and 109 months, which is like 10 years almost, or let's say 9 years. So, so those who did receive active treatment are those who had been transformed. All of those who transformed are actually received treatment prior to the transformation. Again, this could be a biased comparison because those are the patients who came with aggressive nodular lymphocyte predominant Hodgkin lymphoma to start with, and those are more likely to transform rather than those who came with an indolent disease. But still, the number talks, the 13, all of them were treated before, whereas the ones on surveillance had never transformed to T-cell rich B-cell lymphoma or any other aggressive forms. Now, secondary malignancy, there were 3, and the ones who received a treatment, and only one who was in active surveillance had a secondary malignancy as well. I forgot to mention here that 4 of the patients whom we analyzed died. 3 of them were transformed already, and the 4th was having colon cancer and died because of colon cancer, not because of the nodular lymphocyte predominant, which gives us the clue that the disease itself, it seems not a killing disease. Maybe it's a controllable one, but once they transformed, it's a different story. Now, survival of those who had the T-cell rich B-cell lymphoma, their progression-free survival into 2 years is 63%, and reach up to, drops to 39% into 10 years, which is a bit maybe better than what is T-cell rich B-cell lymphoma de novo is causing, and even the overall survival is a bit better than the de novo T-cell rich B-cell lymphoma, but of course way worse than the nodular lymphocyte predominant Hodgkin lymphoma that we started analyzing. Now, we looked into the multiple variants, whether they had affected this outcome. We looked into the B symptoms, LDH, extranodal, liver, spleen, IBI, and stage. We only found that the overall survival is affected by advanced stage, but none of these factors had affected the progression-free survival. So whether they have it or not, it didn't make a huge difference. Now, to come into a conclusion of this number of patients, the first thing I would say is that we have seen double what have been reported in the literature. We don't know if this is exposure to some environmental stimuli in the area, whether we are being more cautious about the disease or what, I don't know. But anyway, this is what we observed in this scenario. Overall, the nodular lymphocyte predominant Hodgkin lymphoma is an excellent outcome, and none of them had died because of the progression of the disease itself. So it gives us a clue that it's not that aggressive again. Of course, this is a retrospective analysis, which we cannot draw conclusions, especially that the ones that had surveillance, as I said, being biasly selective because of their representation. But still, it seems like active surveillance is a good option to selected patient of this disease. And there was no increase of the transformation by just observing them. So leaving the disease doesn't mean that we increase the chance of a transformation or affecting the overall or progression-free survival by this. Of course, as usual, we need more data and prospective trial to look into this further, but at least the number we have shown give us a clue of some hints of what we should do in future if we go into this route. With this, I would conclude and will be happy to receive any question. Thank you.
Allah, thank you. I liked your talk, and it's given size in a rare disease, but in Saudi Arabia it's not that rare as outside. Dr. Ahmed, now we need to put all the Saudi community together in order to have really a good research project about nodular lymphocyte predominant Hodgkin lymphoma. Obviously, they did very good work in Dammam.
That's what I was going to comment. الحقيقة. This is great. Yani, we would be happy to support this joint efforts, collecting the same data to be collected from other hospitals. It'll be a joint project. It'll be great. Excellent.
Of course.
Congratulations. So any questions? I have some couple of questions because the topic is really interesting. And في حدا عنده سؤال؟ طيب. The stages, maybe you later on you mentioned the stage 2. How many patients they were stage 3 and 4 and the percentage of patients? So maybe I didn't pay attention.
The number of advanced stage was higher than the early stage. Seeing it here. I don't think I wrote it here, but the most of them were stage 3 to start with, but this wasn't the key factor of affecting the outcome and didn't by itself choose the treatment or not. Only those who were, there were fewer patients who came with the early stage of disease. If they are in a localized area, we elected to irradiate them, thinking that this is a potentially a curable intent treatment into this scenario.
So you had 34 patients who followed just active surveillance.
Yes.
So why I'm asking after the stage, because I want to ask which kind of stage they have, these patients?
By the scenario we are going, most of them would be stage 3, as I said, because they are not localized to receive radiation or having aggressive disease to start treatment.
Why I'm asking this, because some patient who may come with stage 1 disease and their disease is removed, you don't need to do anything. So just observe him. That I wanted to ask this, whether some of these patients were among these 34 patients.
No, we did have a few patients that there are very few that they had totally resected the mass and went into surveillance. I believe they were like 2 or 3 that had completely resected the mass and had nothing else left to do anything further.
Right. So you mentioned in your data patients outcome treated versus not treated. Okay, it was no major difference. My question is, and I'm interested really in this, whether do you have the data in mind to have just pure stage 3 and 4 who were treated versus stage 3 and 4 who were not treated? So forget about stage 1 and 2 who got radiation.
Well, we didn't look into it this way. We just combined those who were treated to those who were not treated. And this is a cocktail that will be difficult to be compared with. Maybe what you have said will make more sense of like clearer proposing the outcome, but we didn't look into it this way. But by default, more likely would be that those who received chemotherapy or chemoimmunotherapy are stage 3, and those who were active are stage 3. So this will be the closest comparison, I would say.
Probably, yes.
What you have.
Some stage 2 who don't have stage 2 as in the neighborhood, so they will get chemo or bulky disease patients. So transformations, 9% of your patients, they had transformation, and most of them, they had rich B-cell lymphoma. I mean, I don't know whether we have a pathologist here among us. We know that sometimes it's really very difficult to distinguish between nodular lymphocyte predominant Hodgkin lymphoma and T-cell rich B-cell lymphoma. Was it maybe a misdiagnosis? I'm a provocative here.
Who's there? Sorry. So we did have at least into those who had transplant, at least we looked into them more extensive than others because we thought since they had the relapse aggressive enough to need the transplant means most likely they have transformed. So we were digging into those patients more than anybody else. So that's why I have even mentioned the exact number of like at least 6 and 2, and the other 2 is missing, and we are still fitching whether these 2 are really having something extra to make them aggressive, much to need of a transplant. But of course, diagnosing T-cell rich B-cell lymphoma is so difficult, and we are struggling with that. Yes.
Are you transplanting patients who have a transformation also when they relapse, or do you transfer relapse patients with the same histology, nodular lymphocyte or non-Hodgkin lymphoma?
So just having aggressive disease after receiving anthracycline-based therapy is a justification for transplant. But with this scenario, we dig much as we can to figure out whether this patient had relapse after anthracycline because of really same scenario of nodular lymphocyte, or do they have the question is, why did they progress after anthracycline? We believe that nodular lymphocyte is so sensitive to the anthracycline, whether ABVD or R-CHOP doesn't make a big difference. But since they had progressed again with aggressive form, means there is something else to push them to this scenario.
So any other question? Last question? Yeah.
Just to Muhammad, one question regarding the treatment options. You use R-CHOP. Is it because of transformation or risk of transformation, or is it like anyone requires treatment, you go for R-CHOP? The reason I'm asking, because as you mentioned, anthracycline and the risk of 2 reasons. Anthracycline, there is a risk of secondary cancers, the breast cancer recently now, there is data about this. And also these patients, they might transform in the future. So you need to use the anthracycline in the future. If you used it early without risk of transformation, it will affect its future.
Actually, this is why we are trying our best to put the patient on surveillance, not to put them on R-CHOP. But anyway, we are even trying to radiate those who have localized disease, to give rituximab into those who have a low burden of disease, or those
RCVP or PR rather than anthracycline.
Well, BR and RCVP are not, good, standard of care in such a scenario to go with. But of course, there are centers who are giving RCVP. So still, this is an option, but this is not the most common practice, let's say.
And rituximab, I don't like rituximab single agent. Germans, they're saying this is not good. So earlier we believed on this, but meanwhile. So but the last question that I have, which is...
Can I just comment on what you have said? So the rituximab, usually what we do is that we give it to local disease, trying to debulk to give radiation most of the time. But of course, there are certain scenarios where they are like elder, not fit, giving rituximab single agent. RCVP may be fit to such a patient, but we give them rituximab. So we are trying to avoid rituximab as sole single agent.
I am glad that you clarified this. This is a very important point. The last question what I have is a question which you ask, but you didn't answer, which the era oncology versus hematology. How it was? Is there a difference?
Well, the oncology, we're giving ABVD once we had the hands on the patients, we give the R-CHOP. So this made the comparison between R-CHOP, the ABVD obvious here.
الله يرضى عليك. شكرا جزيلا. So, next we'll hand over to Dr. Ahmed Al-Askari. I know.
Thank you again. Thank you. طيب بسم الله الرحمن الرحيم. So we continue and we carry on with our program. I know it's a long day. However, bear with us. We felt that we continue rather than interrupt and come back. So it's just one day in a year, ya Jama'ah. So let's carry on with our program. Now, we're on time. That's good. Second, I would like to thank our sponsors. So we have the next 4 sessions or 4 talks will be all pharma-sponsored talks. The first one is by AstraZeneca. Again, thanks to our sponsors for supporting this event. So it's the art of choosing BTKIs, and will be presented by Dr. Ihab Al-Hamidi. And Dr. Ihab has been already introduced. He's well known to all of us here, consultant at Princess Noura Oncology Center at King Abdulaziz Medical City, Jeddah. Dr. Ihab, please, the podium is yours and the stage is yours.
Thank you, Dr. Al-Askar, for this kind introduction, and thank you, AstraZeneca, for sponsoring this event. And I liked the title they chose, The Art. So, art of choosing BTK inhibitors. Which one should we choose? So hopefully you will have an informed decision by the end of this session, which one could be chosen for which indication. So this is a disclaimer. And I'll start with a case from the clinic. Case 1 is a 72-year-old gentleman who has diabetes for 20 years, hypertension, and mild renal impairment. So he's a newly diagnosed CLL. He has an IGVH unmutated status, and he also had TP53 normal unmutated, and requires treatment due to cytopenia. A common scenario in the clinic. So the latest NCCN guidelines say in this situation, they put a combination of venetoclax or zanubrutinib or acalabrutinib as an indication. But you notice that the first question for me when you look at this NCCN guidelines, why was ibrutinib removed from the preferred option of NCCN guidelines? Now ibrutinib has been put under other regimen section. And you can see it here in the NCCN guidelines that ibrutinib was removed from the preferred regimen section to the other recommended regimens. So we look at the ibrutinib data, and this is the E1912 trial. This is updated results, long-term outcomes of this study, which show clearly that ibrutinib has a better progression-free survival than chemotherapy, FCR in this case, a statistically significantly better outcome from efficacy point of view. Also from overall survival point of view, the efficacy of ibrutinib is better than FCR. When you look at the unmutated versus the mutated, again, there is statistically significant improvement using ibrutinib in the unmutated status like our patient. Also, there is improvement in mutated, but the improvement is not as good as in the unmutated section. But both are statistically significantly better than chemotherapy in ibrutinib. So we go to the ELEVATE trial, which was a randomized trial looking at acala versus ibrutinib in the relapse refractory setting. And in this trial, you can see clearly that from toxicity point of view, there was improved or less toxicity using acalabrutinib in this setting compared to ibrutinib. So atrial fibrillation was less. Hypertension was much less using acala versus ibrutinib. And this was an update in ASH 21 showing the hazard ratio from the toxicity of acala versus ibrutinib statistically significantly better in terms of atrial fibrillation and hypertension compared to the ibrutinib. Other toxicities from between acala and ibrutinib, again, there is less bleeding events, less diarrhea, and less arthralgia using acalabrutinib. Looking at the zanubrutinib, this is the Alpine study, and you can see that the toxicities using acalabrutinib is similar in terms of hypertension between acala and ibrutinib. So that 15% versus 16%. Bleeding was similar between ibrutinib and zanubrutinib, 37 versus 36. So from toxicity point of view, the toxicity of zanubrutinib is similar to ibrutinib in this study. So now which BTK is more efficacious to use for this patient? Is it acala versus zanubrutinib? And this study was done zanubrutinib versus bendamustine from efficacy point of view, the Sequoia study. And this is the 5-year follow-up data in naive patients like our patient. He hasn't had any treatment before. And this study has shown clearly that zanubrutinib is more efficacious than bendamustine rituximab in this setting, so better than chemotherapy, statistically significantly better. The overall survival is similar. There is no overall survival benefit using Zana versus BR. The Elevate trial 6-year follow-up update was in the treatment-naive setting using acalabrutinib, obinutuzumab in one arm. The second arm was acala on its own, and the third arm was obinutuzumab chlorambucil. And in this study, it has shown again clearly that using the acala obinutuzumab or acala on its own is statistically significantly better progression-free survival than the chemotherapy arm. From overall survival point of view, there was statistically significantly better overall survival in the acala arm versus the chemo arm, and in the acala arm, acala obinutuzumab arm versus the chemotherapy arm. So when we look at the efficacy point of view, comparing the 3 BTKs, you can see that the progression-free survival is similar between the 3 BTKs. Obviously, the follow-up of the trials is different, but the efficacy of the 3 BTKs is comparable. Acala, ibrutinib, and zanubrutinib. The overall survival, again, is comparable. When you think about using fixed duration treatment in unmutated, one can think about ibrutinib plus venetoclax, and what you get here is about 50 to 60% progression-free survival in the unmutated setting. The CLL13 also gives you about 60% in the ibrutinib plus venetoclax fixed duration. So if we were to use a fixed duration strategy in this patient, you will get about 50 to 60% at 5 years. When you use this strategy of continuous therapy in such a patient, acala pooled efficacy was about 80% at 4 years, and zanubrutinib was about 80% at 3 years follow-up. So again, continuous therapy in such a patient might be a better option than fixed duration in terms of progression-free survival benefit. So if efficacy is similar between the different BTKs, so how can we differentiate? How can we choose which BTK to use, which one to give to this patient? Our patient with comorbidities, he had diabetes, he has hypertension, and he has mild renal impairment. When we look at the zanubrutinib versus ibrutinib study, the Alpine study from toxicity point of view, you can see here the toxicity is similar in terms of diarrhea, anemia, arthralgia. And you can see it in this visual, and especially hypertension, similar incidence of hypertension compared to ibrutinib. So the incidence of atrial fibrillation is better using zanubrutinib than ibrutinib. However, the incidence of hypertension, 25% and 26% in the ibrutinib arm. Grade 3 hypertension is 13% in zanubrutinib arm and 14% in the ibrutinib arm, and our patient is hypertensive. So in summary, I looked at this article from Blood. It's from the Dana-Farber article. I wanted something to compare zanubrutinib with acalabrutinib. Obviously, there is no study to compare the two together, whether the one was more efficacious than the other. But this Dana-Farber article tried to do that by an unanchored, match-adjusted indirect comparison, which is a method, statistical method, piling up the different trials of the two agents, zanubrutinib and acalabrutinib. So what did they find? They found that the progression-free survival when you use acalabrutinib plus obinutuzumab was statistically significantly better than zanubrutinib as a single agent. They found that the acalabrutinib and zanubrutinib, actually they were identical in terms of progression-free survival. So the only benefit is when you use obinutuzumab with acalabrutinib, there is improved progression-free survival. But both are, from efficacy point of view, they are very similar. They give very similar progression-free survival outcomes. So what about the toxicity? They compared the two toxicities, and you can clearly see here, this side favors the acalabrutinib, and you can see here that hypertension was statistically significantly less with acalabrutinib than zanubrutinib, and you can see that the rest of the toxicities tend to be less with acalabrutinib and favors acalabrutinib compared to zanubrutinib. They all move towards the side of acalabrutinib. So is fixed duration option in this patient, this hypertensive patient, diabetic patient? The GLOW study was a study using ibrutinib with venetoclax. Initially, ibrutinib on its own for 3 cycles, followed by ibrutinib and venetoclax. And there was a recent update of this GLOW study. But the problem with this study, which is in the elderly, was that there is excess related mortality with the IV arm, was about 6% in those who had ibrutinib with venetoclax in this elderly population, compared to the comparator, which was chlorambucil obinutuzumab, which was only 1.9%. So toxicity from the combination in the elderly is something that makes me worried using this combination in the elderly patient, like our patient with comorbidities. The toxicities were mainly cardiac failure, sinus node dysfunction, sudden death, ischemic strokes, and cardiac arrest, as you can see here. So it's a grade 5 toxicity, as you can see. So action to take in renally impaired, like this patient is renally impaired, there is no dose adjustment needed for BTK inhibitors in any renally impaired patient. While venetoclax in many studies has shown that the toxicity of venetoclax is increased when the GFR is less than 45 mils per minute. And our patient is actually renally impaired. So that's another reason why one should be careful using fixed duration in such a scenario. So my personal verdict for case 1, considering the following data of efficacy data, toxicity data, patient-related factors, namely the comorbidities, acalabrutinib would be the most appropriate choice for such a patient. We move on to case number 2, is a 62-year-old woman who was diagnosed with CLL. Molecularly, she was found to have TP53 mutation. This patient was more fit than the previous patient. She had no comorbidities. She required treatment because of cytopenias. And what do NCCN guidelines tell us about this patient? So again, the combination is of venetoclax, acalabrutinib, and zanubrutinib are the preferred option for such a patient. So the SEQUOIA study, which is arm C of the zanubrutinib, was a monotherapy in patients with deletion 17p. And in this study, the arm C was mainly patients with deletion 17p. More than 100 patients were enrolled in this study. And it has shown an excellent progression-free survival of about 72%. And when it's adjusted for COVID, because this study was done during the COVID era, again 73% at about 5 years. So very good result with TP53 mutated patients. We look at the long-term efficacy of acalabrutinib in such patients. This is pooled data. And again, in TP53 patients, you get about 78% at about 4 years. So again, similar efficacy of deletion 17p TP53 mutated patients. What about the toxicity? Toxicity, atrial fibrillation was 7% in this pooled data. Is fixed duration an option in such a patient? That's a question, a valid question. We look at the Captivate study, which was, again, we spoke about it before. It's ibrutinib, and then you follow it with ibrutinib with venetoclax. And the outcome at the TP53 mutated patients was about 36% at 5 years. So not a very good outcome at 5 years in terms of progression-free survival. So when we compare the TP53 mutated patients in the different trials, so Captivate gives us about 30% at 5 years. The CLL14, which is another fixed duration study with ibrutinib versus venetoclax done by the Germans, gives you about 38% at 6 years. So again, similar to the Captivate. The acalabrutinib gives you about 78% at 4 years, and the zanubrutinib gives you about 72% at 5 years. So for this type of disease, I would say that acalabrutinib or zanubrutinib would be a valid option. She doesn't have any comorbidities. Both give you about more than 70% progression-free at 5 years. The final case number 3, it's a 55-year-old gentleman diagnosed with CLL, so younger than the 2 previous patients. He has CLL, he has unmutated IGVH. He needs treatment, no comorbidities, a fit patient. And here we might employ the fixed duration therapy. And we look at the Amplify phase 3 study, which was a randomization between acala venetoclax 14 cycles and acala venetoclax obinutuzumab 14 cycles. And the third arm of the study was FCR and BR. So the median age is similar between all arms, about 61 years of age. And there is no difference in terms of ECOG status, 9%, 4%, and 9% of the patients with ECOG 2. So the outcome from this study has shown very nice outcome. This is the group of patients who actually had acala venetoclax only, and it was stopped obviously after 14 cycles. And at 36 months, which is after stopping, the MRD negative is about 37% of patients at 36 months, despite not being on any therapy. 37% of patients were actually MRD negative. How about those who had acala, venetoclax, and obinutuzumab? And you can see here, 71% of patients were actually MRD negative at 36 months in a fixed duration setting. So excellent outcome in terms of MRD negativity. So what about the independent research committee progression-free survival? Is showing 83% at 36 months, 76% at 36 months for acala obinutuzumab venetoclax or acala venetoclax combination. The progression-free survival for unmutated, like our patient, 82% with the acala venetoclax obinutuzumab, 69% in the acala venetoclax for the unmutated group. However, this study was done during the COVID era, and many patients actually had COVID infections and had COVID-related deaths. In the acala venetoclax obinutuzumab had 8% deaths from COVID infections. And they had to adjust their progression-free survival based on the COVID problems. And if you adjust it for COVID issues, then the progression-free survival increases to 91% when obinutuzumab is used and 78% when obinutuzumab is not used, so acala venetoclax on its own. The overall survival, again, if you adjust it for COVID death, then it becomes statistically significant for acala venetoclax obinutuzumab and for acala venetoclax compared to FCR or BR chemotherapy. So overall survival benefit using the combinations in fixed duration. What about the side effects? You can see here, this is hypertension. 2% of patients had grade 3 hypertension. So again, toxicity is quite manageable using the combination. You can see here 2% again with the acala venetoclax. The other trial that you can compare with this one is the Captivate, which I spoke about earlier. It's ibrutinib, then followed by ibrutinib with venetoclax. And in unmutated setting, here you get about 60% at 5.5 years follow-up. This table is a summary of all the trials of fixed duration. And what you get from these trials is a progression-free survival of fixed duration about 60 to 70% at 5 years if you use this strategy. If you use a strategy of MRD-directed therapy like the FLAIR study, you get about 90% 90% progression-free survival if you use the combination. Zanubrutinib doesn't have a license in fixed duration, but there is this study, Sequoia study, arm D, which is venetoclax with zanubrutinib. And arm D actually is two sides. One is fixed duration for the 17p deleted patients, and one arm for those who don't have a 17p deletion. It hasn't been reported yet, but I want to point out something in this trial is that the number of patients in arm D so far is only 114 patients, and that the TP53 arm has 66 patients. And those who received the zanubrutinib venetoclax are 63 patients, and those who are 17p, in which their 17p is not deleted, are only 47 patients. Those who received the medication are 46 patients. So I'm not sure how you can make a conclusion in fixed duration using this combination when the numbers are so low. The Amplify had about more than 200 patients in this fixed duration arm. So what about the toxicity? We talked about diarrhea. 6% had grade 3 diarrhea. So the toxicity from zanubrutinib is still there. The hypertension, 10% grade 3 is still there as well. So fixed duration for this patient, I would choose acala, venetoclax, plus minus obinutuzumab combination for this patient. So in conclusion, 70 to 80% of my CLL patients are actually elderly with comorbidities. And medicine is a science infused with artistic skills. And skillful physician would be able to harness his science and artistic skills to interpreting clinical data to choose the most efficacious and safe treatment for their patients. And with that, I conclude my talk and thank AstraZeneca. And thank you for listening.
Well done, Dr. Ahab. Thank you again for finishing on time, and so we could carry on with the discussion and questions, and also move on with our program early. So do we have questions? Yes, Dr. Majid.
Okay, so thanks for your final comment. So CLL is a disease of elderly. So very rarely we see that, young and fit patient who really eligible for combination therapy looking for fixed therapy. So in general, we will be looking for a single agent. So now, if you decided to go with acalabrutinib, so what's your recommendation, acala alone or acala obinutuzumab? Now, in the Elevate TN, there was a PFS advantage with addition of obinutuzumab, and also for the Amplify, the group who has obinu, then acala had more MRD negativity, meaning that there is some additional benefit with use of obinutuzumab, but that will be on a price of increased risk of infection, especially with these elderly patients. So what do you think?
Okay, so I will dissect your question into multiple levels, because one of it is continuous therapy, like will I choose acala plus obinutuzumab or acala on its own? And I think the gain that you are going to get in progression-free survival has to be balanced with the risk of infection. So I have to say that I would choose adding obinutuzumab to acalabrutinib for a selected patients who are going to be able to tolerate this combination without the increased risk of infections. So I think patients who have diabetes and they have other comorbidities, I think I will be careful adding obinutuzumab in this setting. So the second part of your question is about the fixed duration, acala, venetoclax, obinutuzumab, or acala, venetoclax on its own. And I think in this setting, both achieve an overall survival benefit, which is a good aim for. So the only benefit I will get by adding obinutuzumab is actually a progression-free survival benefit, because both of them achieve an overall survival benefit compared to chemotherapy. So one has to be also careful, because you are aware how venetoclax is a tough medication when you use it on its own, even. So adding obinutuzumab to the combination, I'll have to have a really fit patient to add that, because the gain I'm going to get from this triplet might not be worth it if the patient is going to be admitted every now and then with an infection. I'm not going to gain in overall survival benefit much, so I would concentrate on acala venetoclax combination, and very few selected patients may be getting the triplet.
Okay. So we moved from myeloma using multiple agents to CLL using multiple agents, and always the thought of, are we burning the lines in up front, or are we, I mean, of course, if you use more weapons, you will have a better result, but at the expense of then being lost on what to do next. I know this question have been asked in the morning, but again, I want your thought about if we use the combination, the patient comes early relapse after this, it would be a difficult scenario.
Yes. So there was a very nice debate whether you use fixed duration or continuous therapy in Lugano. And it's a question that we are going to find difficult to answer, which strategy to use. I think the strategy is going to depend on the patient status. A younger patient, I think, will benefit a lot from fixed duration, because you're going to use it for a fixed duration and you're going to give them a good quality of life without any therapy. And then you can reuse what you've used before later on. I think for the elderly patients, I think continuous therapy would be my choice. I think fixed duration is associated with significant toxicity, and I think it worsens their quality of life. It might lead to them actually dying from an infection. So I would use fixed duration in young, fit patients who can tolerate the toxicity of the combination, personally.
So let me tell you the real scenario we had. So we had the combination of obinutuzumab, acalabrutinib, venetoclax, who responded very well early in the treatment and finished the treatment. 1.5 years later, he progressed. This is a real scenario we had. What would you do in this? So to make it practical.
So what are the cytogenetics?
He had 11q deletion.
11q.
Yeah, and the IGHV was unmutated.
Okay. So at presentation and at relapse, both?
To be honest, I'm not sure about the relapse, but this is because he was in a trial, so we know the details of the presentation.
So 1.5 years relapse. It's a short remission. I think if he doesn't have the 17p deletion mutation, it might be still an idea to use continuous therapy in this patient with acalabrutinib as a single agent, and see what you get out of that. That's what I would do in such a scenario.
This is what happened, and he responded very well again, and he's now 2 years on the BTK inhibitor, by the way. Just
interesting. I mean, this is a case that will let's conclude our session, I guess. But interesting. But again, the other option would be to have bertibrutinib in those patients, right?
Yes. But I don't think in fixed duration you've burnt your first line if you have more than a year and if you don't have 17p deletion. I think you can still reuse and see what you get out of that, because you can still get a decent outcome for a while. And then you preserve your pirtobrutinib and other therapies for later, especially if the patient is young.
All right. Dr. Ihab, just a quick question, and if you could have a quick answer as well. If you have those cases with atrial fib on anticoagulation, what would be your selection?
So good question. I don't think atrial fibrillation is if it is well controlled. I don't think it's a contraindication for using a BTK inhibitor. Acalabrutinib has the least chance of bleeding when you look at the data. I wouldn't use warfarin as anticoagulant. A DOAC would be my preferred option in such a scenario. So Acala plus DOAC. And I would clearly instruct the patient that if they are going to go to the dentist, if they are going to have a dental extraction or they have any surgical procedure, that they have to stop their medication and their anticoagulant 3 to 5 days before.
Great. I think with that, we'll conclude our session. Thank you again, Dr. Ihab. And I want to take vote here. So shall we carry on, Ijma'a? We have a prayer. We need to pray. Those who haven't prayed, I guess we will go for prayer. But we need to come back immediately and carry on with our session. Alternatively, those who already prayed or جامعين ويجمعوا, they could, I think, carry on the session. I could call Dr. Ibrahim Martabi, who is going to moderate the next talk, to carry on, and we'll join you immediately.
Assalamu alaikum wa rahmatullah. First of all, I'd like to thank Dr. Ahmed Al-Askar and Saudi Lymphoma Group and SSBMT. Also, I'd like to thank Roche for sponsoring this session. This session is about glofitamab use in heavily pretreated patient with diffuse large B-cell lymphoma. It will be presented by Dr. Majid Al-Ahmadi, who is Dr. Majid is consultant hematologist at National Guard Hospital, Jeddah. He has a special interest in myeloma and lymphomas. So Dr. Majid will share his experience with his patient treated with glofitamab, and he will present overview of the use of glofitamab in this group of patients. Dr. Majid. So thanks for the organizers, and thanks for Roche for sponsoring this event, and thanks for all the attendees who are staying until almost 6:30 on a Friday evening. I'm sure you have better things to do than listening to me, but thanks for staying all of this time. So I'm gonna share with you some of the difficult cases that we have seen in our practice in DLBCL. And how bispecific T-cell engagers, mainly glofitamab, can solve these issues. So before, what is the barcode? Is there a barcode? What is the barcode? I'm not sure what. Okay. So because we're supposed to have a barcode, but no, it's not showing. Anyway, so it's just for interest. If the approach wants, your feedback about this questionnaire. So if you have just a few seconds to look at it and We'll try to share a barcode with you at the end, but if you can just go over it quickly. And so how familiar are you with glofitamab in clinical data? Very familiar, somewhat familiar, heard of it, but not familiar with it, not familiar with it at all. In your opinion, where does glofitamab best fit in DLBCL treatment pathway after or more than 2 lines of therapy after CAR T-cell failure as an alternative to CAR T-cell in eligible patients? Other, please specify. What could you prevent you from using glofitamab in third-line DLBCL? Safety profile, duration of therapy, patient eligibility criteria, access, reimbursement, lack of long-term data. Other, please specify. The last question, what would be the strongest driver of you to prescribe glofitamab? More local real-world data, clear guideline inclusion, positive experience from peers, easier access program, additional safety reassurance. So as a background, DLBCL is the most common non-Hodgkin lymphoma, represent about 30% of all cases. And since rituximab introduction, 60% of these patients, they go into a long-term remission after first line of therapy, but 40% of them, they relapse. And that's a challenge because these relapse cases based on the Scholar 1 trial demonstrate poor prognosis with overall response rate, maximum 26%, CR 7%, which support that this is an area of a huge unmet need and needed more advances. So now this is the new algorithm for treating relapsed refractory DLBCL. In the old era, the first question that comes to our mind when we have relapsed DLBCL is the patient transplant eligible or transplant ineligible? Now, the first question we have to ask ourselves, when did the relapse happen? So is it within 12 months from finishing therapy or beyond that? So if it is less than 12 months, the second question, is the patient CAR T-cell eligible or you have access to CAR T-cell? If patient eligible and you have access to CAR T-cell, so definitely the answer is to refer the patient or proceed with CAR T-cell therapy, either axi-cell or liso-cell. If the patient is not CAR T-cell eligible or you have no way to access CAR T-cells, then you have different modalities. So the clinical trial definitely POLA-BR, Tafa-LNR, Loncostimab, glofitamab with combination as the POLA-R-GEM-OX or Glofi R-GEM-OX. If the patient relapsed beyond 1 year, then is he transplant eligible? Back to the first question, is he transplant eligible or not? If transplant eligible, then proceed with stem cell transplant. If not eligible for transplant, then you go back to that box with investigational agents, bispecific a possibility here. So out of all the variables for relapsed refractory setting, the most important prognostic factor that affect the prognosis of these patients is how far from immunochemotherapy. So if the patient relapsed earlier, their outcomes usually are worse, and also the age at the time of the relapse. The older the patient, the worse outcomes. So 3 important scenarios. First, early relapse in a fit patients within 12 months of finishing therapy or primary refractory disease. The second scenario, late relapse beyond 12 months in a fit patients or relapse in frail patients, unfit for CAR T-cell or stem cell transplant. So this is actually one of my patients. So a 41-year-old lady, previously healthy. She presented to another hospital with tonsillar mass on October 2023. The mass was resected and pathology confirmed DLBCL GCB subtype. Initial staging showed a 3B stage disease. She received 2 cycles of R-CHOP, and fortunately, after the 2 cycles, her disease has progressed. So now, definitely, this is actually an example of primary refractory disease, which is worst of the worst. And this is based on the ORCID trial. Any relapse within 12 months, the median overall survival is less than 1 year. So very bad outcomes. So back to our algorithm. So patient primary refractory, we have to ask ourselves, is the patient eligible for CAR T cell? She's young and fit, so the answer is yes. And that's the data coming from the ZUMA-7. So patients who are primary refractory or relapse within 12 months of finishing their chemoimmunotherapy, they were randomized to receive either axi-cell versus standard of care with platinum-based chemotherapy. And the primary endpoint was event-free survival. So the trial met its primary endpoint with axi-cell showed significantly better in terms of event-free survival, as we can see here, 8.3 versus 2, which was also reflected with an overall survival advantage. Not reached in the arm of the axi-cell versus 31 months in the standard of care. And this is the list of the approved CAR T cell for DLBCL. For the second line setting, the approved ones are axi-cell and liso-cell. Sorry. I think this, okay. So the patient was referred to us for consideration of axi-cell. So this is when she came to us. She actually, I remember when she came how aggressive the disease was, and she had a bulky disease everywhere. So immediately we got her admitted, and we collected her. We put her as top of our list, and we performed her apheresis, and then she underwent pola-R-GMOX as bridging, but unfortunately she progressed with it. So she received axi-cell infusion, and that complicated with grade 1 CRS, no ICANS. And this is basically, so the one on the PET-CT on the right is actually before the infusion. And the one on the left is 30 days post axi-cell infusion. So excellent result, but you can see here that there is that still PET-avid lesion that's higher than the liver. So do well for partial response. So PET-CT repeated after 2 to 3 weeks from that one, and unfortunately, she progressed even further with development of more lymphadenopathy in the axillary, and that lesion got even worse. So we biopsy one of these lesions, and it confirmed the same pathology, so DLBCL GCB subtype. So primary refractory to CAR T cell. So what to do next? And this is usually the dilemma. It's a tough case. So now, luckily in the current era, we have multiple options. So the T cell directed therapy, so CAR T cell, we talked about it. The bispecific T cell engager, we have 2 that's been approved, glofitamab and epcoritamab, plus other options that can be considered for these refractory cases. So antibody drug conjugate, polatuzumab, and loncastuximab. Also monoclonal antibodies like tafasitamab and obinutuzumab. So bispecific, I think we heard about it a lot in this meeting. So basically it share the same mechanism. So you are basically targeting the CD3 on the T cells and an antigen on the cancer cells, which is in this case is a CD20. So it's all activate the T cell, causes local proliferation, CK release, and then T cell recruitment, lysis of the malignant cells. So all of these are outcomes. So glofitamab is a CD20, CD3 T cell engager, has a high avidity binding to CD20 on B cells, and the FC portion extend half-life and reduce toxicity. So, so from this landmark phase 2 trial, they included patients with DLBCL or high-grade B-cell lymphoma that they have ECOG of 0 to 1, 2 or more prior lines of therapy, and including that must include anti-CD20 and anthracycline. So if I ask you, would my patient be eligible for that clinical trial? So the answer is yes. So yeah, so my patient received more than actually 3 lines. So to be eligible for this trial, and my patient had an excellent performance status. So the patient on this trial, they were treated with a fixed duration of glofitamab, Q3 weekly, up to 12 cycles. They received obinutuzumab as a CRS prophylactic measure, and all the patients would receive a step-up dosing of glofitamab. Their primary endpoint was a CR rate, secondary endpoint overall response rate, DOR, and PFS, overall survival. So these are the baseline characteristics of these patients included, and we can see that a third of the patients included, they have received CAR T cell, like what happened with my patients, and they were refractory to CAR T cell, exactly to what happened with my patient that I presented to you. So the result of this trial was quite promising. So the CR rate was 62%, and we are talking about a patient who have failed multiple lines of therapy, including CAR T cell. And the duration of response, duration of response in that patient who achieved the CR at 2 years was 56%. So that was reflected with a better BFS. So very impressive results. So for very refractory group of patients, 62% at 2 years, and that was clearly in the patient who achieves a CR. So basically, when you are trying a bispecific, if your patient achieved a CR or CMR, I would say, usually these are the patients would have a long remission. But you know, most of the patients who achieved less than a CR, they unfortunately relapse, and this is what we see on this, Kaplan-Meier for the patient with BR. So the CR cases, they do very well. So in terms of the safety, similar to what to expect with bispecific infections. So that's why we have to be careful with appropriate antimicrobial prophylaxis with these patients. IVIG monthly as needed. In terms of the CRS, mainly grade 1 or 2. So based on this trial, glofitamab got approval after 2 lines in relapsed refractory diffuse large B-cell lymphoma. So that's what we did with our patients. So we started her on glofitamab, and after 4 cycles, PET-CT was done, and it showed a CMR, complete metabolic response. So she completed the 12 cycles of glofitamab, and while on therapy, she received 4 doses of IVIG. She had a short admission with uncomplicated COVID-19 infection, resulted in some bronchitis. End of therapy PET showed a CMR Duvel 2. And now she is almost 1 year, actually, post completion of glofitamab, and she's still doing well. No history of more infections. So that's the first case I want to share with you. This is a second case also from our center. So 43-year-old lady, previously healthy. She presented to another center in December 2022 with increasing abdominal pain, weight loss, subjective fever. She actually was quite ill on presentation. She had a CT scan done which showed a large abdominal mass involving the jejunum with evidence of bowel obstruction. So she underwent laparoscopic exploratory surgery and she had multiple biopsies taken from that mass. And it actually showed sheets of large lymphoma cells, aggressive looking, that's positive for CD20, 10, BCL2, BCL6, and CMEC on immuno. And the fish came back positive for CMEC and BCL2 rearrangement, confirming a diagnosis of high-grade B-cell lymphoma with CMEC BCL2 rearrangement. So she was referred to us, and the baseline PET-CT showed an intense metabolic bulky mass in the retroperitoneum with extranodal involvement in the pancreas, left adrenal, duodenum, duodenum and the jejunum, ovaries with positive bone marrow. So multiple extranodal. That reflect, how aggressive her disease is. For any patient like that, definitely you have to assess for CNS disease. So she underwent MRI brain and CSF analysis, both were negative. So she received 6 cycles of dose-adjusted R-epoch, achieved a partial response after cycle 3, Duvel 4, but end of therapy PET showed a progressive disease of Duvel 5. Sorry, the 5 is missing here, Duvel 5. So as we can see here, this is the interim PET, and she developed this lesion here, end of therapy. So we try to take a biopsy from, and this is important. So whenever you have something like that, you have to do your effort to do a biopsy to make sure that you are dealing with the same pathology. So we try to do that, but unfortunately the mass was very close from a great vessel. So it was very risky to take a biopsy even by laparoscopic surgery. So with that, we confirmed that this patient had a primary refractory disease and she underwent T-cell apheresis for axi-cell, received Pola-R as bridging therapy, and underwent the infusion in October 2023. That was not complicated with any CRS or ICANS. So unfortunately, after the cell-to-cell infusion, she still has this avid lesion, which was even getting more avid and larger after the infusion. And the PET-CT repeated at day 60 of the CAR T-cell, which showed also a further metabolic intensity with increase in the size. Again, we try to, discuss if we can do biopsy, but unfortunately still it was very technically difficult. So she was referred for radiation and she completed 36 gray of radiation and PET repeated post-radiation. Again, it showed a progressive disease with increase in the intensity of that residual lesion. So after long discussion with the patient, she started on glofitamab and she received the first cycle of Gluvi complicated with unusual symptoms, so transient slurred speak that was either ICANS or TIA. So she underwent MRI and neurological assessment, but the symptoms resolved on its own. No CRS. Cycle 2 was well tolerated. So she had a PET-CT after cycle 2, and finally we got a CMR. So now she completed five cycles. So far, clinically, she's doing well. No evidence of progression. So my next patient that I want to share with you, a 74-year-old lady with past medical history, hypertension, depression, on therapy. She had a poor functional status with ECOG of 3. So she presented to the orthopedics clinic with a left hip pain and difficulty with walking. Her imaging showed aggressive left acetabular osseous lesion with soft tissue component and pathological fracture measuring 14.2 centimeter maximum diameter. CT guided biopsy done, and it showed diffuse large B-cell lymphoma. And this is her PET-CT that done initially. So because of her frailty and comorbidities and poor functional status, she was started our mini CHOP, completed 6 cycles, plus 2 additional rituximab. End of therapy PET showed a PR with the residual PET avidity at the acetabular lesion. So she received involved field radiation at 36 gray. And unfortunately, 3 months later, after finishing the radiation, PET-CT showed a progressive disease. So what to do next? So now we are dealing with an elderly woman, poor functional status, who had a primary refractory disease to chemoimmunotherapy and radiation. So back to our algorithm. So now if you want to think about this patient, so she is primary refractory, but on the other hand, she is not eligible for CAR T-cell or stem cell transplant, definitely. So what options we have for her? So bispecific would be an option, and I'm gonna show you the data. Other options that can be considered for such patient is POLA-BR. It's an approved indication for or clinical trial. So, you know, if you have an open clinical trial for such cases, these are the, you know, the really unmet need. And, you know, we have seen in the afternoon that even all of these novel agents are being now tested for these difficult to treat group of patients, frail, unfit. It's a huge unmet need for that group. So I'm gonna discuss with you the data from the recently updated the STAR GLOW trial. So using comparing GemOx in both, glofitamab GemOx versus R-GemOx. Which patients were included? Similar to the one I showed you. So relapse refractory DLBCL after 1 or more lines of therapy, and patient must be transplant eligible. So basically they included these patients who are frail and unfit. Their ECOG were 0 to 2. So their stratification factor was relapsed or primary refractory and the number of lines of therapy. So their primary endpoint was overall survival. Other endpoints were PFS, CR rate, and they did safety analysis. So these are the patients were included. And as you can see here, the median age was 69 and 68 in both groups. So the group of the one that I, you know, always have difficulty with, the elderly, the frail. And in terms of the number of lines of therapy, if it is 1 versus more than 1, so about 50% of the patients were received 1 line of therapy, and they did analysis for that I'm going to show it to you. So the trial met its endpoints. So Glofi GemOx had a better overall survival. And that's actually, for me, I always respect that, you know, endpoint. So even if you are telling your patient, okay, the chances for you to survive with this option is better than the other, it's always, you know, better to see. So Glofi GemOx had the overall survival was not reached after 2 years of follow-up, versus 13.5 for the R-GemOx. The hazard ratio of 0.6, meaning that Glofi GemOx decreases the risk of death by 40% with a statistically significant p-value, as we can see. So at 24 months, 54 patients on the Glofi GemOx were alive, comparing 33.6 in the GLUFI, in the R-GEM-OX arm. So if we want to, so in terms of the overall response rate, so for the patient who received the GLUFI GEM-OX, 68% they achieved the response. Most of them were actually a CR in comparison to only 25% on the R-GEM-OX who achieved a CR. So now this is also an interesting finding. So what patients who achieved a CR, how their outcomes, and as I told you before, so these bispecifics, if the patient achieved a CMR, they usually do well, and that's what we have seen from this trial. So more than 80% of the patient with a CR remain progressive free at 12 months. And we know that in patients with DLBCL, most of their relapses happen in their first 1 year. So at 12 months, these patients who achieved a CR, which is majority of the responders on this trial, we've seen that most of the responders on the GLUFI GEM-OX, they were in CR. So most of them were free of progression at 1 year. And that's another interesting finding. So what about for the patient who received this as a second line, so with one prior lines of therapy? So the outcomes was even more clear. So the 24 months overall survival was 60% in comparison to less than 40%. So meaning it's a 1/3 increase in the survival with hazard ratio again of 0.64 after 1 line of therapy. So in terms of the safety profile, so addition of GLUFI GEM-OX did not result into anything more than what we expect in terms of CRS, mainly grade 1 or 2. Very few grade 3, same thing with ICANS, so mainly grade 1 or 2, very few grade 3. Infection rate, and okay, so the infection rate here, so addition of GLUFI resulted in slight increase in the infection rate, so that's why for such protocol, we have to be very careful with antimicrobial prophylaxis and monitoring the immunoglobulin status and replace it as needed. So based on that trial, so it showed a fixed duration of GLUFI R-GEM-OX for patients who are relapsed refractory, not transplant eligible, were superior to the standard, which is R-GEM-OX. That actually resulted into the FDA approval for this protocol, GLUFI GEM-OX, for transplant ineligible relapsed refractory after 1 or more lines of therapy. So final conclusion, so patients with DLBCL refractory to second line or relapsing after transplant has a very poor prognosis. T-cell therapies, including the bispecific, are emerging, providing greater CR and change the current therapeutic paradigm of the DLBCL. The bispecific demonstrate remarkable activity in patients with heavily pretreated DLBCL with a manageable toxicity profile dominated by the T-cell overactivation syndrome. Bispecific antibodies do not require manufacturing time, which is a good advantage for such class, making them accessible therapy at any time. The introduction of step-up dosing and a preemptive steroid treatment minimize the incidence of adverse events to enhance safety. Combining bispecific with other agents, as I showed you with other chemotherapeutic agents, might be the future for relapsed refractory cases, even in the upfront setting, as we have seen this morning. That's what I have for you, and thank you.
Thank you, Dr. Majid. Very nice presentation and very interesting cases. So I have 4 minutes left for this presentation. We can have some questions.
Thank you, Dr. Majid. Of course, those who progressed before within a year of R-CHOP, the best scenario is the CAR-T. But if the center doesn't have the CAR-T and I cannot refer to CAR-T out of the box you have mentioned, I didn't see an auto stem cell transplant, which I think a valid option, especially that has a potential curative intent, although it's less than CAR-T. What do you think?
Yeah, so according to the guidelines, that's what it says. But yeah, recently there is a published data for patients who are relapsed refractory. So who achieved a complete response after salvage. And, they, compared the outcomes of these patients to the outcomes for the patient who underwent CAR T cell. And there was no much of difference. So if you have a patient with primary refractory and there is, you don't have access to CAR T cell. So one of the options is to salvage with, platinum-based protocol. If they achieve the CMR, these are the patients that might benefit from transplant. So far, the Glufi GemOx is approved by FDA, but still not approved by Saudi FDA. If once we have that approval, I think also would be a very interesting and excellent alternative, since it's available and you can give it in your center, and it showed a very good efficacy and safety.
Any more questions? Dr. Ghazi?
If you allow me, I would even take this further to say, if you have a protocol that is much cheaper than a CAR T, and you can give it to an elderly patient and their flat curve stays at 40%, it's probably the same outcome we get from CAR T.
Yeah, yeah, that's very true. Yeah.
So thank you so much, Dr. Majid, for being on time. I think we conclude this session, and I will again thanks SSBMT and Roche for sponsoring this event. And the last Dr. Sumaya now to share the next second.
Good evening, everyone. We almost there. It's my pleasure to introduce Dr. Ghazi Laitabi. Dr. Ghazi is the director of the King Saud University Oncology Center. Dr. Ghazi will talk about the new strategies of the management of myelofibrosis. Dr. Ghazi, the floor is yours.
Thank you very much, and thank you very much to the SSBMT for organizing this activity, and to our colleagues at JSK for, first of all, providing us with a lot of compassionate access for momelotinib, and also organizing this activity. So, this is, I think myelofibrosis is one of the diseases that does not interest a lot of hematologists. So I ended up inheriting a lot of patients of Profile Mu'min with myelofibrosis. So this is a sponsored satellite activity by our colleagues at GSK, and momelotinib is not yet Saudi FDA approved, but it will be very soon. So we're quite actually privileged at the university to have somebody who is interested in MPN, and so most of the cases we see are polycythemias or ETs, but actually have quite a bit of myelofibrosis, and I think this is quite common across the board. And most of the primary myelofibrosis cases are very difficult to treat. They're mostly young patients, and luckily, transplants still offer them, a good opportunity to achieve cure. But you will always struggle with those, secondary post-PV and post-AT, and that's, I think, where most of the medical therapy, is designed for. And we don't know exactly, what's the true incidence of the disease, but I can tell you it's actually not very uncommon. The national data says, you're looking at about 6 per 100,000. This number can go up and down based on how hematologists are, how often they're doing bone marrow biopsies on people with mild cytopenias and unexplained splenomegaly. But the hallmark of the disease, as you would all know, is I think the main problem is their cytopenias. And even with the advent of JAK2 inhibitors, cytopenias are very difficult to manage. They come with a lot of anemias and thrombocytopenia. But to the patients, sometimes the presence of B symptoms, so the constitutional symptoms from the reticulin and fibrotic changes, the night sweats, the drenching, sweats and the fevers, and the big spleen that's causing a lot of dyspepsia and early satiety is a big problem. And, unfortunately, until today, most of the treatment is not really well known to prolong survival. Although we're actually seeing, a good signal with the use of, second generation JAK2 inhibitors, but these therapies are actually designed for the B symptoms, and they actually work quite a bit. And then you look at the secondary complications of myelofibrosis, the leukemia transformation, the VTE, and all these things, and none of these therapy has been very effective in preventing transformation to acute myeloid leukemia. So in 2003, there was a New England paper that clearly illustrated the hallmark of a disease in myelofibrosis, and the JAK STAT pathway activation, leading to a lot of I would say hepcidin increased activation and a lot of anemias and the extramedullary hematopoiesis that comes from the fibrotic bone marrow. So now we know all JAKs are involved, so JAK1 and JAK2. We've also came to know that even the activin receptor 1 pathway is actually well known to be upregulated by the inflammation that's caused by the JAK1 and JAK2, and at the same time, it leads to hepcidin upregulation and cause a lot of anemias. And again, the symptoms are mainly the fatigue and increased inactivity experienced by all patients, but at the same time, a lot of cytokine-mediated symptoms, and more importantly, even the splenomegaly that can be seen as a very massive spleen in most of the patients. And unfortunately, even the presence of the splenomegaly can be, problematic for those who would like to take the transplant. So most of us will try to, shrink that spleen a tiny bit to increase the chance for graft uptake for transplanted patients. So the early myelofibrosis, let's say early pre-fibrotic MF, that can be seen in ET. I think there's quite a bit of patients that are undiagnosed at that level. They usually present with a tiny bit of erythrocytosis, so we don't get too excited to do a bone marrow biopsy in those people, but it's actually very important to label those people at the beginning. But when they achieve or when they actually move to an overt myelofibrosis, they mostly get diagnosed at that time, and most of those people are quite sick when they come to the clinic at that stage. So the diagnostic criteria by the WHO, hasn't changed, since I would say 2008. Even in the 2016 update, there is not a lot of update, but mostly, you have to look for increased reticulum fibrosis. So at least grade 2 to 3. There is actually quite an interesting now AI modeling that looks at bone marrow biopsies and will truly quantify the amount of fibrosis better than the eyeball grading. And then you certainly have to look for a clonal marker, so either a JAK or CALR or an MPL mutation, and they have to not meet any WHO diagnostic criteria for other myeloid malignancies like CML, for example. And then the minor criteria you've known and you've seen before. So the scoring system, very difficult to apply to a lot of patients because of the dynamic nature of their disease. So the IPSS is what's commonly used in clinical trials. It actually stratifies people, based on certain simple parameters, mainly, how much plasma they have and what are the cytopenias they carry around, and they can live up to 11 years if they're low risk, and it can go up as low as 2 years if they're high risk. So that's what's commonly used. We've got also the dynamic IPSS, and we've got also the to the modified IPSS. So there's so many scoring systems, and they mostly function the same. So the mutations are very important. So CALR carries the best prognostication marker. So it's about 20 to 25% of patients with primary myelofibrosis. JAK2 is not too bad, and triple negative is actually the worst, and they progress too much to either an overt fibrotic disease and transformation to acute myeloid leukemia. There's also some NGS markers that are actually correlated with disease progression. So most of these things are actually CHIP mutations, mainly A6L1 and splicing RSF1. So the MIPS is similar, but it's actually more dynamic, and it's modified to include certain genetic changes. So unfavorable karyotyping carries a heavy weight actually in that score. So the IPSS and the modified and the dynamic are all designed to look at myelofibrosis that is primary in nature. It's not post ET or post polycythemia. So that's why the secondary the secondary myelofibrosis is not really well predicted with these models. So that's why the MySEC primary myelofibrosis modeling have came, and it actually looks at similar variables, but it's actually a much smaller, easier in the clinic to do. So the treatment, I think most of us will agree that if those people are asymptomatic, even if they have, an reticular fibrosis of 2, we usually just observe them and not offer them any treatment, especially if they're not requiring any supportive care. And if they actually move to a higher risk, then this is very important to, think about, sending those people to transplant. And it's very important that, even if they are low risk, I would always encourage to make sure that the spleen size doesn't go bigger than it should be, because if you're going to take them to transplant, the myelofibrosis, splenomegaly related changes makes engraftment very difficult. And the early initiation of ruxolitinib is actually quite indicated at that point. So in the high risk, we've known ruxolitinib for quite a long time now, and we came to know that it's very effective in reducing B symptoms based on the COMFORT-1 and COMFORT-2 clinical trials. But cytopenia is a main side effect of ruxolitinib at all doses. I mean, we aim for 20 milligram BID, but we never reach even. I've got patients who are on 5 milligram every other day because of the cytopenia, mainly thrombocytopenia and anemia. So the FDA approved JAK inhibitors in the market now, ruxolitinib, which actually targets both JAK1 and JAK2. Fedratinib is also a very nice molecule that mainly targets JAK2, to a less extent JAK1, but it's also got some FLT3 inhibition in JAK3. Pacritinib has got a unique activin receptor upregulation, so it actually works quite a bit, especially in those people with thrombocytopenia. And momelotinib has got a more potent ACVR1 activation, so it actually inhibits hepcidin and ultimately is actually very nice in people with anemia. So it's mainly used in those category of patients, but there's also clinical trials that have used momelotinib in JAK2 naive patients. So we don't have to go through the COMFORT-1, 2. I'm sure you've seen this in the past. It's been more than 10 years now since the publication of COMFORT-1 and 2. We've known that COMFORT-1 have shown maybe a tiny bit of overall survival advantage, but that did not translate very well in COMFORT-2. Spleen reduction is quite prominent, and most of us we use it for the spleen reduction and the B symptoms. The overall survival advantage. So I've shown you the COMFORT-1 have shown a tiny bit of improvement in overall survival, but that did not translate in COMFORT-2, and that's the reason why they did COMFORT-2 is actually because of the survival signal. The best advantage of ruxolitinib is it actually works in about 2/3 of patients and shrink the spleen more than for 1/3 in the majority of the patients in the study. So spleen reduction more than 35% has been seen in about 50% of the patients. And those people, they actually respond very nice. Usually max response is about 6 months, but then unfortunately they actually lose that response. And most of the lack of splenomegaly improvement response is because of the cytopenias and inability to tolerate this medication more than progression to an MDS or an AML. So this is the discontinuation rate, and you can see that literally by 2 years, 50% they're off therapy. By 5 years, almost all the patients are actually cannot continue on ruxolitinib, and mostly because of side effects and whatsoever. We will not go through, how do you define ruxolitinib, failures, but, suboptimal responses can be seen. And I think the take-home message from all the discontinuation literature is, we are not, doing a good of a job when it comes to, titrating the dose of ruxolitinib. But ultimately, I think even with the most ideal, titration, most of those people, they will end up off therapy, mainly because of cytopenias, and more importantly because of thrombocytopenia and anemia. And then so there's actually so many definitions to talk about failures, but the progression of spleen again and the worsening of thrombocytopenia is the most common definition. So there are so many predictors for survival and benefit with ruxolitinib, but mostly if they improve their transfusion requirement, if the spleen reduction is less than 30%, and if their rux dose is less than 20%, then those people are a very high risk to lose that advantage of survival. So now most of the clinic patients today are on ruxolitinib. So now how do you transition those people to a more newer generation JAK inhibitors? I think it's very important to know that if they're primary refractory from the get-go, then it's much easier. You just switch from one to another without actually having a discontinuation period to avoid the known discontinuation syndrome or withdrawal syndrome. And if even get a suboptimal response to JAK inhibitor. So if you give somebody ruxolitinib at the maximum tolerated dose, I think in our population is 15 BID, and then they ultimately at 3 to 6 months their spleen did not improve, then it's actually recommended you switch to a newer generation JAK inhibitors, or if they progress after response, and that's actually a rare scenario. So how do you define or how do you actually transition? I think the most important thing is avoid stopping and waiting. Most of those people have to be you stop the medication today and actually start tomorrow the new medication. So pacritinib is a great example that actually overcome some of the challenges with ruxolitinib. In the pathophysiology of the disease, it actually works through mostly JAK1 inhibition. So it actually JAK2 inhibition, and it doesn't actually work on JAK1. And ultimately, the most of the thrombocytopenia side effect happens from an activation of JAK1. So the BERSUS-2 is pacritinib versus best available therapy. And in that study, they randomized to 400 Q daily or 200 BID or best available therapy, mostly ruxolitinib. And if you actually look at the study, you'll see that about 50% of the study population were actually on ruxolitinib. A small number on hydroxyurea and watch and wait, and some of them are on danzol. So in that study, you can see the primary endpoint in that study is an improvement, the improvement in spleen size. So splenic volume reduction, and it has been seen in about 22% versus 3% of post-available therapy. Mostly, I would say ruxolitinib. And if you actually look at those patients who got more than 50% improvement in the total symptom score, so the TSS is basically all B symptoms, lumped together. There's a significant improvement with ruxolitinib compared to best available therapy. So it's a great option, works in about 2/3 of patients when it comes to spleen reduction, and about 1/3 even if they're refractory to ruxolitinib. And this is just a modified, total symptom score. It actually have shown an improvement in overall symptoms, mainly B symptoms, in patients on full dose, 200 BID. So the improvement in transfusion requirement have also been shown. So we know that we promote pacritinib for thrombocytopenia mainly, but there is actually some mild improvement in their anemia. So you can see 25 versus 12% improvement, and this is at the end of study follow-up, which is about week 24. And the amount of people who've got reduction in their RBC transfusion requirement is about 22% compared to their baseline. So there's some element of transfusion burden decrease over time if you actually continue to use pacritinib. So this is the improvement in platelet hemoglobin. I think this is actually speaks for itself. So you can see most of the patients have started with a very decent, amount of platelet count. So in the study, they allow people with a moderate, thrombocytopenia, so platelet count of 100 or so, but it has to be more than a 50. And you can see it actually did not actually get worse with time. Same thing can be said about hemoglobin. So yes, we report improvement in anemia, but you see the baseline have started very nice, and there is no change over time. I mean, maybe there is no worsening over time is the message here. And it's actually as safe as ruxolitinib. So there's nothing much different here, except the good proportion of patients, they've got some GI disturbance. So it reminds me of positinib, actually, where everybody gets diarrhea from week number 1. And it's actually quite intolerable to the patients. So that's why, a huge amount of patients will stop this medication because of the diarrhea, which happens as soon as 1 week after initiation of study. And in the study protocol, they incorporated the use of Imodium or loperamide, as part of therapy. So you buy pacritinib, you get 1 Imodium with it. So PERSIST-2 is another study that have looked at pacritinib, but versus ruxolitinib as the best available therapy. So now everybody is compared to ruxolitinib, and not to take too much time of this, but the outcome is not too different. So with splenic reduction volume is about 22% of the patients, and more than 50% happens in about 35%. So 1/3 of the patients will actually respond quite a bit if they have used the full dose, which is 200 BID. And there's no new safety signal. So most of the patients they manage this. They managed to tolerate this compared to ruxolitinib. So there's no difference between both outcomes. So the new kid in the block, which I think is a newer generation of JAK inhibitors that actually target JAK1 and 2, but also works quite a bit on the activin receptor 1, is momelotinib. So it actually addresses the symptoms as well as the spleen, but also it's geared toward patients with anemia. And the whole idea is, how many of those people will transition from requiring frequent transfusions to not needing any transfusion. So this is how it works. So it actually works through interleukin receptor of the JAK1 and JAK2. So it actually blocks the STAT pathway downregulation. At the same time, it also works through hepcidin. So it actually blocks the ACVR1 receptors, so you get hepcidin dysregulation, so there's improvement in the anemia. And now, there's actually so many new molecules that are actually working, mainly through the ACVR1 to prevent or to treat anemia that can be caused because of myelofibrosis or can be caused from anemia of chronic disease. And now you can see that this is a non-inferiority design. So there's no difference when it comes to spleen response. So in treatment-naive patients, there is no difference in the spleen volume reduction. So you get an excellent spleen volume reduction. You've also got an excellent total symptom score. So those people, they actually respond quite a bit, and there's no difference in both. Now, the most important thing is the transfusion requirement improvement. And you can see compared to ruxolitinib, the baseline requirement is high, but at week 24, you get about 25% improvement in their transfusion requirement, and the amount of dependency goes down quite a bit from 30% to in the patients on momelotinib versus 40%, so about 25% difference. So moving on to the second line clinical trials. So the SIMPLIFY-2 is actually a study that looked at pre-treated patients, and the Momentum have looked at patients who are, more or less similar to the initial population of SIMPLIFY, but they had to have the hemoglobin of less than 10, and their platelet count has to be more than 25. And then the initial abstract was actually presented in last ASH. So this is the Momentum. I'm not too happy about the control arm here, but I think you'll get the summary from at least the improvement in anemia markers. So momelotinib versus danzol. Danzol is probably not the best standard of care control arm, but it's quite reasonable for B symptoms. So the amount of improvement you see when it comes to symptoms is actually quite magnificent. So most of the people, they've got a very nice improvement. The study have shown superiority in total symptom score, in transfusion independence, in splenic response rate, So it's actually quite effective in managing the B symptoms and what we've seen from the initial JAK inhibitors. But the best thing is the improvement in transfusion requirement, so that there is actually superiority compared to danazol as the control arm. So the momentum study have also shown that the transfusion independence rate is best achieved at week 24. So most of those people, their baseline, you start at 70%, and most of those people they actually improve quite a bit at week 24, which is not a reasonable amount of time, for the JAK1 to kick in as an inhibitor. So in the study, you can see that the anemia numbers or the mean hemoglobin numbers, continue to climb, throughout the study. So anemia in myelofibrosis, I think, is a big concern for patients, especially if they're not transplant eligible. And I think, momelotinib have been considered, a great adjunct to help those people with anemia, and at the same time, improves the iron requirement and chelation therapy. So now we have in our armamentum, danazol, which actually has a very low response rate, but it's at least 30%. And you've got IMiDs, mostly thalidomide with prednisone, based on a small blood publication from 10 years ago. Erythropoietin have been used, and if it doesn't work, usually in 3 to 4 months, then usually stop it. And most of I'd say 1/3 or even less, they will respond to erythropoietin. Transfusion, we've got people who are dependent on transfusions, and my experience with momelotinib is not with a huge number of patients, but with the 4 we've got, either we get a complete independency on transfusion, which is an excellent outcome. I have a guy who's 90 years old, actually, who now he's not transfusion dependent, so I think that works in his favor. But at best or at worst, you get a spacing of their transfusion requirements. So they go from 4 weeks to 6 to 8 weeks. This allowed me to, give them more iron chelation and bring their iron requirement. And then, momelotinib is the new addition. Response rate is about, 1/3, and time to response is as soon as 4 weeks. So that's a great addition to the myelofibrosis, armamentum. So the impact is the last clinical study we'll talk about in myelofibrosis. So it's actually an imetelstat in those patients with myelofibrosis who have received the JAK2 inhibitors. We don't have a lot of data on this, but the data is actually quite promising, and I think this will be also a great addition that we will see probably in the next 2 to 3 years. With that, I open the floor for questions, and thank you, Mr. Chair.
Thank you, Dr. Ghazi. We'll open the floor for a question. Any question? تفضل دكتور.
Thank you, Dr. Ghazi. Great talk. What do you think about the luspatercept in the field of myelofibrosis? In addition to momelotinib, we have used this in some patients, and we have seen some responses. So what's your take on this?
We've got a couple of patients that we send them to Ilotiveri, and anytime they'll come with luspatercept plus a JAK2 inhibitor. So I think, there's actually an initial small data on this. We give it to patients with anemia, and honestly, the experience is very limited, but it's not super encouraging. Even if you go from 75 to 100, most of our patients, did not respond quite a bit. So we tend to keep it at least in our hospital formulary for patients with beta thalassemia or MDS with ring sideroblast. But we've actually tried luspatercept, and I know Ilotiveri keeps on preaching the idea that the combination JAK2 works, but I think there's nothing to lose here. I would definitely give it a try for at least 3 to 4 months. But it's an expensive choice.
Any other questions? Dr. Askar?
Very nice overview, Azi. So thrombocytopenia, is it due to the, bone marrow infiltration, bone marrow issues, or this spleen or splenomegaly? And then, does it matter what is the cause when they respond or use bacteriotin, for example?
So that's actually a great question. So if you actually look at ruxolitinib, you see about 40% they end up developing a moderate to severe thrombocytopenia. And I think the thrombocytopenia per se is not a function of the spleen size, and it's not even a function of how much fibrotic changes they get in the bone marrow. So most of those people, they end up with significant JAK1 activation, and they get a lot of inflammatory response. So it's actually a cytokine response on the TPO. So there's a small subset of studies that have looked at maybe when you use ruxolitinib, you can use something like Doptelet or avatrombopag to push the TPO, and the outcome is actually quite encouraging. So our colleague Dr. Amr Alim have actually published a small case series of people on ruxolitinib and a TPO, and the outcomes are seems reasonable. So I think it's mostly an inflammatory response similar to thrombocytopenia you see from infections.
And I missed what you said about transitioning. So would you, if somebody not responding to ruxolitinib and you switch to other agents, would you transition again the ruxolitinib, gradually reducing or move?
So I think what I'm trying to say here is, even if those people continue to lose response, it's very important that you do not stop, JAK inhibitors. But once you start on a new medication, you can actually just immediately stop. So they don't have to have an overlap. But I think until you get your momelotinib or pacritinib, then keep the ruxolitinib continuous. But you can switch next day. So there's no as per the FDA label, you can actually start the next morning with the new JAK2.
Thank you, Dr. Ghazi, for the excellent presentation, and thank you for GSK for sponsoring this session. In the interest of time, we'll move. In the interest of the time, we'll move to the next speaker. Dr. Ayman Ibrahim is consultant hematology at King Abdulaziz Medical City, Riyadh. Dr. Ayman will share with us real-world cases and his experience with Yescarta. Dr. Ayman, the floor is yours.
Assalamu alaikum. Many thanks, Sumaya, and thanks for the organizer and Kite for giving me this opportunity to be part of this great event. So I'm going to share some real cases from our department. So the first case is a 61 male presented with abdominal pain, significant loss of weight, and night sweats. He had an OGD showing ulcerating gastric mass, and the biopsy confirmed diffuse large B-cell lymphoma, non-germinal subtype. And it was an advanced stage, locally advanced stage disease, stage 4BX, with a big mass, bulky mass around 11 centimeter. So he was started on R-CHOP treatment. He completed 6 cycles of treatment. And at the end of the treatment, his PET scan has shown good response, but with residual disease. So the mass has shrunken, but still very avid. So he had a repeat biopsy, and that confirmed the refractory disease. So primary refractory disease, agreed to go for CAR T-cell therapy. So he had a CAR T-cell collection, and he had a bridging with Pola RG-MOX, completed 2 cycles. He had a CT abdomen just prior to the CAR T, and that has shown development of fistula. There was a peripancreatic collection, so developed a fistula between this collection and the first part of the duodenum. So the CAR T, he had the lymphodepletion, the standard regimen, fludarabine and cyclophosphamide, infused in the 8th of August. The product was Yescarta Axicel. He had like ICANN grade 3, required ICU admission, treated very well with dexamethasone. He had also CRS grade 2, treated with TOSI and dexamethasone. He had also CMV reactivation, treated with valganciclovir. So at the disease assessment, he had day 30 PET scan, has shown good response, but still the peripancreatic collection was still there, but the disease has almost gone. So we repeated again the PET scan at day 90 after 3 months. Still, the peripancreatic is there, but it's start to regress in size, but was still there. So we got worried. Do we need to consider giving radiation to this patient? We tried to biopsy. We discussed him in our tumor board, but it's difficult to biopsy. And the fact that it continues to regress, we just agreed to follow this patient up. So we had another PET scan after 4 months and still coming down gradually. If you see, this is the mass initially, so it's regressing in size. And after 8 months has completely resolved. So at the end, he achieved complete metabolic response, and he continues to be in complete remission so far. So the only point in this case are the residual activity, which was we not easy. We are trying to biopsy and to go for radiation, but we just observed, and he achieved complete remission. The second case is a 37-year-old male presented to ER with a 5-day history of left upper quadrant abdominal pain. He had a CT abdomen, had shown extensive retroperitoneal and mesenteric lymphadenopathy with very high LDH. So also he had extensive disease with a very accessible left cervical lymph node. He had a biopsy from this lymph node, and that confirmed the diffuse large B-cell lymphoma. Germinal center subtype Ki67 was around 70. So because of extensive disease, we asked for the FISH, but unfortunately it was failed. So the stage of the disease, stage 4, he had gastric, bone marrow, bowel involvement. So more than or 3 extranodal sites and extensive disease. His IPI, intermediate risk 3, and his CNS IPI was also 3. So he was started on discussed on the tumor board, and we agreed on R-CHOP, but we were like to chase up the FISH, and we were planning to escalate his treatment if his cytogenetic came to be double hit or triple hit. But unfortunately, as I mentioned, the FISH was failed. So regarding the CNS, we also we said to give him some CNS prophylaxis because he had 3 extranodal sites. So we agreed to give him ITs during the R-CHOP and to give end of treatment to give him high dose MTX. He declined the IT chemotherapy. We had CT brain initially, which was normal. So he completed 6 cycles of R-CHOP, and also he completed 2 cycles of high dose MTX. And his end of treatment PET scan has shown very good response, excellent response, apart from this small area, mesenteric, which is slightly above the liver uptake, Duvel 4. So we agreed to, because it's very difficult to biopsy this, so we agreed to just to observe and to repeat the PET scan in few months' time. Unfortunately, before repeating the PET scan, he was presented to the emergency with neurological symptoms. He developed finger numbness, asymmetry in face, and also short memory loss. So he had the CT, brain, and MRI that has shown there is some infiltration, lymphomatous infiltration, but it was not clear if it is disease or toxicity from the recent high MTX he has received as a CNS prophylaxis. So we have done the PET scan just to see if there is a disease or not, and he actually achieved CMR at this point, and the mesenteric node, the mesenteric uptake has completely resolved. And we again looked into the brain. There was symmetrical uptake. You know, the brain is already avid area, has a physiologically uptake, so it's very difficult to appreciate any focal uptake. So we have discussed this case again in our tumor board in the presence of the neurosurgeon and the uroradiologist, and they reviewed the scan, and they agreed that this is unlikely to be disease. It's most likely drug MTX encephalopathy. And based on this, we just gave him dexamethasone and leucovorin with significant improvement, and he has been discharged home. However, after a few weeks, he presented again to the ER with more neurological symptoms, slurred speech, inability to walk, and vomiting. And the MRI brain now has shown significant increase in his previous uptake with midline shift required craniotomy. but they couldn't do the biopsy because the infiltration was deeply seated. They just done the craniotomy to relieve the high pressure. So we agree that this is now disease and it's isolated because the recent PET scan was negative. So we agreed to start him on matrix protocol as a secondary CNS relapse with isolated disease. So he started on matrix. He received 3-4 cycles, and we agreed to go for stem cell transplant as a consolidation. But after the 3 cycles of the matrix, doing disease assessment, his brain MRI actually has shown complete resolution to the previous infiltrate. However, the PET scan is totally asymptomatic, showing now systemic relapse. He has now significant disease most everywhere. So we agreed to go for CAR T cell therapy. He has collected, and bridging, we gave him RD-HAB with IT chemotherapy. So at this time, we done the biopsy from the mesenteric mass again, and this shown high-grade B-cell lymphoma, and the fish now is showing that he has a triple hit, c-Myc, BCL2, and BCL6. And this can explain his disease. So his CAR T course was not eventful. He had collected with standard lymphodepletion, and he had the Yescarta axi-cell infused January of this year. And he tolerated the treatment very well with no major any toxicities, only ICANS grade 1. And then after that, ICANS grade 3, he did not require ICU, and he responded very well to dexamethasone. So his post-CAR T assessment, day 30, he has achieved complete remission in day 30, and this maintained on day 90, and up to date, he's still in remission. He's doing great. He's back to work, and he has no any neurological manifestation. This is a very successful story with the CAR T, and we have this pilot study of axi-cell for the treatment of relapsed refractory primary and secondary central nervous system. So this is a study design. They enrolled adult patient. So they do the leukapheresis and then standard conditioning. There was no bridging allowed apart from steroids. And after the infusion of the axi-cell, there is a period of window of 28 days, and this just for the safety, looking for any treatment-limited toxicity. And the plan was if the patient developed significant toxicity, if there is no toxicity, they go and enroll more patients to complete the study. But if there is only one treatment-limited toxicity, they will enroll less patients with more like closing follow-up, very close and monitoring and very cautious monitoring these patients. And if develop more than 2 treatment-limited toxicity, they amend the safety plan. So they end up like recruiting around 18 patients, primary and secondary CNS lymphomas. And they have inserted Ommaya reservoir to all the patients, and they collected CSF and blood samples at the time of leukapheresis, at the time of leukodepletion, at the time of infusion, at the assessment to look for the flow cytometry, and any, also they've done single gene RNA sequencing, looking for the characteristic of the CAR T prior and post CAR T infusion. So the primary endpoint was safety, mainly rate of treatment-limiting toxicities and any grade 3 adverse event. And secondary endpoints were efficacy, objective overall response rate, complete response rate, duration of response, and PFS and overall survival. So this is the patient characteristic. So the median age is around 62. Primary CNS was the majority, 13 patients. And the CNS disease, the tumor location, the majority are parenchymal disease, around 95% having parenchymal disease. The prior treatment, heavily pre-treated patient, around 7 lines of treatment, and 33% they had autologous stem cell transplant. Adverse event, so CRS in any grade around 90 and ICANS around 44. However, grade 3 and above CRS was 0 and ICANS around 28% of grade 3 and 0. The prolonged grade 3 cytopenias, neutropenia, thrombocytopenia, and anemia, it was very common initially at first months, but all resolved by 3 months. Efficacy, the overall response 94%, and the CR around 67% is a very good result in this group of patients. So the median PFS beyond 1 year, 14.3 months, and the median overall survival, 26 months. Interestingly, here they have looked into the RNA sequencing for the CAR T cell in the CSF. They did find it has a characteristic gene expression profile. And also they did find that the CAR T cell in the CSF, they looked into the responder and the one who progressed. They did find in the one they responded, they have upregulation for the immunoregulatory gene, including CD226. This is very helpful in competing with another TIGIT, which is an inhibitory for the T cells. So this helps the T cells to be more active in fighting the disease. And they did find that overexpression of this CD226 in the CD19 CAR T cell demonstrated higher lymphoma cell killing compared to the control, as you can see in this here. So the killing effect of the CAR T cells with overexpression of the CD226 showed more killing ability for the lymphoma cells. So the conclusion that the axi-cel is safe for treatment of primary and secondary CNS lymphomas with no increased risk of high-grade ICANS. And the axi-cel promising efficacy in heavily pre-treated. We know these patients, prior to this, they're having very dismal outcome. They live only for a few months. So as we mentioned about the overexpression of CD226, and they would like to see if this is only peculiar to the CAR T in the CSF, or they need to look into this in the other study if this also required in systemic CAR T as well or not. So we move to last case, 57 years old male. He has mainly referred to us because he has a very refractory mantle cell lymphoma, referred to our institute for CAR T cell therapy. So in his medical report that the previous treatment he received R-CHOP 3 cycles, RD-HAP 3 cycles. Seemed that he did not respond, and they put him on acalabrutinib 100 milligram for 6 months. Then he developed lower limb ulceration. They thought it's secondary to acala. This acala stopped, and they gave him rituximab, single agent, 7 doses. Then he had ibrutinib rituximab for 6 months. Ibrutinib gradually increased to the maximum dose. Then he had R-GMOX 6 cycles. Then they put him again in acalabrutinib 100 milligram BID. He came to us at that time. He refused stem cell transplant, and they referred him at that point for us to consider CAR T cell therapy. So he's young and he's fit and well. He has only psychiatric mixed anxiety and depression disorder, but otherwise he's quite well with very good performance status. So we have done a workup. So we have done a biopsy from a cervical lymph node that confirmed the diagnosis of mantle cell lymphoma with Ki-67 of 40. And the PET scan actually has shown there is disease, but low burden disease, only cervical disease. So at that time he was taking acalabrutinib. We thought we don't know the previous, we don't have the previous scan. So we agreed just to continue on acalabrutinib and to observe the patient.
Then after a few months, he came back and with a repeat PET scan has shown significant disease progression. As you can see, this is in 2 months, and here at that time still was taking acalabrutinib. So we discussed him again, and we agreed to go for CAR T cell therapy. He had the leukapheresis and bridging with bendamustine rituximab. He did not receive bendamustine before. And he received the lymphodepleted standard fludarabine and cyclophosphamide, and the product was tecarticel. So he developed CRS grade 2, and also he treated very well, responded very well to dexamethasone. He did not have major problems, just very reasonable side effects with minor things that all treated with no major problems. The only thing he had like recurrent infections. So his disease assessment on day 30, he achieved the CMR, and that continued until now he's in CR after 6 months and more. The only thing, as I mentioned, he's having recurrent infection. He gets IVIG every month. So looking into the literature about the role for proxy-cell in the mantle cell lymphoma, this is a real-world outcome in patients with relapsed refractory mantle cell lymphoma, systemic literature review and meta-analysis. So the background, we know that the proxy-cell is already approved in 2020 for relapsed refractory mantle cell lymphoma based on the ZUMA-2 trial. And in this trial, the outcome was very good. The overall response rate around 91%, CR rate 68%. Overall response was 46 months. The safety-wise, the CRS more than grade 3 was in around 15%, and ICANS more than grade 3 was 31%. So the objective to assess the safety and effectiveness of proxy-cell in a broader real-world mantle cell patient by identifying. So they have just reviewed the literature and done a meta-analysis, very good number of patients. And we just jump to the results. So overall response rate is a good number of patients, more than 1,500. So overall response rate was 88%, and the overall CR was 76%. And the estimated overall survival, 40.6 months. And the PFS, 18.4 months. And this compared to the ZUMA trial, actually had almost similar overall and overall response rate and overall survival, slightly higher in the CR rate, 76 compared to 68 in the ZUMA trial. Most importantly, they have less ICAN and CRS, most likely because they have very cautiously, they gave more prophylaxis medication. By this, I conclude, and thanks for you waiting to the end, and I'm happy to take any questions.
Thank you, Dr. Ayman, for sharing these interesting cases. I will start with one question. Is there any difference in the outcome between the high risk and non-high risk in the mantle cell lymphoma in terms of CAR T?
Usually when you come to CAR T, the patient is already have a relapsed disease. So at the time of the relapse, the disease is already proven to be poor risk. So usually the high risk and low risk disease, you mean regarding the morphology and the Ki-67, these things to decide about the disease. So usually if the disease relapsed, this is already bad disease. We usually important at the time of the diagnosis initially, if you have Ki-67 or TP53 mutated, this is usually more important at the time of initial presentation.
Any questions?
I think it's already very late. People are hungry. Yeah.
All are tired. Thank you so much, Dr. Ayman, and thank you for Kite for sponsoring this session. And thank you all for staying with us until this until the last session. Shall I join? I warmly now invite you to join us for the dinner and looking forward to see you in other meeting.